So this is the same thing, just telling you what are the vessels that you have to ligate and what part of the colon has to go. This is the conventional right, just taking down proximal 1/3 of the transverse colon. Extended right, proximal 2/3 of the transverse colon, transverse colectomy, and subsequently left hemi and sigmoid colectomies. Mechanical bowel preparation nowadays is controversial. We do give antibiotic prophylaxis, some cases rifamycin as well, and then pneumatic compression devices for any pelvic surgery as is usual. For a cecum ascending colon, it is, for an open, it's always lateral to medial approach usually, but for a CME with CVL, it is medial to lateral approach. For an extended right, when the tumor is in the hepatic flexure, you may also need to mobilize the splenic flexure for adequate tension-free anastomosis. Transverse colectomy, it could be an extended right or just a transverse colectomy based on adequacy of the blood supply of this marginal artery. Left hemicolectomy, it involves high ligation of the left colic artery and the left branch of the middle colic artery, and you can get away with the colocolic anastomosis in this. Sigmoid colectomy, high ligation of the inferior mesenteric vessels with adequate lymphadenectomy. Important is to identify and preserve the left sided ureter and the gonadal vessels, and if the rectum has to go out in case of an anterior resection, total mesorectal excision is important. Anastomosis, it could be classified based on the type of approximation, end to end to side to side, or hand-sewn or stapled. So end to end anastomosis, usual practice, especially in case of a small bowel anastomosis, but it carries a risk of luminal narrowing if there is a gross size mismatch. End to side, very useful when bowel diameters are unequal, a dilated bowel being anastomosed to a proximal non-dilated bowel. Side to side, in an era of staplers, this has really come into vogue, side to side anastomosis, wider lumen, lower stricture risk. Stapled anastomosis, it could be this way, you just place the bowel adjacent to each other, do an enterotomy, fire the stapler, and then close the enterotomy manually. Or it could be an absolute no-touch technique where you just do an enterotomy, first do the anastomosis, and then fire the stapler across it. So either which way, this is more often practiced in case of a minimally invasive approaches that we do. Now the role, a bit about role of ICG, it has really revolutionized the field of surgery, helps us in better delineating the lymphatic anatomy, as well as tells you the vascular anatomy and adequacy of perfusion. Once you have dissected, taken down the vessels, the remaining bowel, is it adequately perfused or not? Here an ICG helps a lot in identifying the true lymphatic drainage of the tumor, apical or the central lymph nodes, which helps in identifying where to take down the vessels. And there have been studies which shows that use of ICG in this colon surgery has ensured higher lymph node harvest as compared to the standard surgery. Role of minimally invasive surgery, as is the case with all cancers, it has revolutionized this field as well. You're all familiar with these terms, cost, color, classic, which established the equivalence of MIS versus open colectomy with no difference in recurrence, DFS or OS. And now it's almost the standard of care, with lymph node yield being higher in minimally invasive surgery owing to better visualization as compared to open surgery. Better magnification, precise dissection, obviously learning curve is high, but it is there to stay. Now the last few slides just telling you how a robotic setup differs as compared to a laparoscopic colectomy. The main difference being the port placement. In laparoscopy, it's always triangulation, which we have been taught that you have to have scattered ports ensuring triangulation, right? But in robotic surgery, especially in this XI system, its ports are usually in a linear line, more widely spaced as compared to your robotic, because robotic instruments are slightly longer. So the distance between the ports has to be at least 7 to 8 centimeters. And if you can make out from here, this is your port placement for the robotic port. Yellow one is your camera port. The blue ones are your robotic ports. Green is the assistant port. It's all in a line, straight line or a curved line. This is in contrast to your laparoscopic port placement, which is always triangulation. So that's the main difference. Obviously, better ergonomics, better degree of freedom in robotic surgery makes a surgeon's life much easier. Thank you, and I'd like to welcome you all for this national conference, which is happening in Lucknow on 9th, 10th, and 11th October. Everybody is welcome to join. Thank you, and I'll be happy to answer any questions.
Thank you, sir, for the crisp and insightful overview. Now, I would like to call Professor Avnish Kumar, sir, to felicitate. Our next talk is on carcinoma esophagus, which will be given by Dr. Shivrajan, sir. He is additional professor in surgical oncology, KGMU. We welcome you, sir.
Good morning, everyone. So I will be speaking on esophageal cancer. Although it's the disclaimer is that it's a very long topic and it has many nuances, but I will try to be very specific and to be very useful for you. So esophagus, as you all must be knowing, it starts from the neck and goes all the way to the stomach. So what is the landmark which we see on the CT is the lower border of the cricoid. It starts from there. Endoscopically it starts from the 15 centimeter and it goes till the entry of the stomach, and we divide it into the three parts: upper, middle and lower. The upper part is from the cricopharyngeus muscle, or you can say the lower border of cricoid to the lower border of azygos. From azygos to the lower border of inferior pulmonary vein is the middle one, and from inferior border of pulmonary vein, inferior pulmonary vein to the G junction is the abdominal part, or is the lower 1/3 of the esophagus. Compared to the all other luminal organs or the end organs in the body, esophagus is it has very specific anatomy which is very essential for its surgery. The first thing is regarding its blood supply. You must have heard the splenic artery, gastric artery, renal artery, many arteries, but there is no esophageal artery in the body. It is only the esophageal branches. Wherever esophagus goes, it takes the branches from the nearby arteries or the veins. Like in the neck, it takes some branches from the thyroid artery. From the thorax, it takes branches from the aorta. When it goes into the stomach, it takes some branches from the left gastric artery. So the thing is that you can do the segmental resection of the esophagus. You just need to cut that much branches and you are secure. It doesn't doesn't make the organ ischemic, like if you cut the splenic artery, spleen become ischemic. It doesn't happen in the esophagus because there is no big artery, it's only small branches. Another thing is regarding the nerves. The nerves, esophagus is along the vagus, and from vagus the recurrent laryngeal nerve arises, you all know that. So in the upper third of the esophagus, from above the carina, the esophagus is supplied by the branches of the recurrent laryngeal nerve. So whenever there is a lymph node dissection around the upper part of the esophagus, we have to safeguard the recurrent laryngeal nerves. And below that, the small branches from the vagus comes in. But the important thing is that the branches to the heart, for the parasympathetic branches, it arise just above the carina. So whenever we are doing the lymph node dissection along the upper part of the esophagus, we have to safeguard those cardiac branches so that patient doesn't go into the very high tachycardia or tachyarrhythmias. So vagus is generally cut at the level of carina or just below that. देखना यार आगे नहीं जा रहा. इसमें जा रहा है उसमें नहीं जा रहा. अभी तक तो चल रहा है. इससे ये आगे जा रहा है, वो नहीं, वहाँ पे प्रोजेक्ट नहीं हो रहा. So the next thing is about the esophageal wall anatomy. Esophagus is the only organ which doesn't have serosa. All luminal organs in the body has the serosa. So for all the anastomosis, you must be knowing that serosa is the most important layer, but there is no serosa here. So the strongest layer for the esophagus, which has to be there into the anastomosis, is the submucosa. That is number one. And number two, in the esophagus there are two channels of lymphatics which goes. One is in the just under the submucosa, and one is outside the outer layer of the mucosa, outer layer of the esophagus. And all these lymphatics have the crisscross connection. You can see here, you can see here, there are channel here, this may be connecting somewhere next. So if something arises from here, it can travel here, it can go here, and it can give lymph node at some other location, right? So tumor may be in the lower 1/3, but node may be in the neck along the esophagus. So this is the importance of this. So the submucosa is the strongest layer, which is important for the anastomosis. There is no serosa, so there is early involvement of the adjacent organ, because serosa also act as a barrier. There are two lymphatic chains. Lymphatic is continuous, it is not segmental, unlike the blood supply. So the lymph node is early, lymph node spread is early and is unpredictable. From lower it can go to the neck, from the neck it can go down. So just a point for the G junction tumor, it's a, you must be knowing this Sivert classification. So the from the 5 centimeter above the G junction to the 1 centimeter above the G junction, it's, we call it type 1 Sivert's tumors. From 1 to 2 centimeter below, we call it type 2, and from 2 to 5 centimeter below, we call it type 3 or Sivert T3 junction. This is the epicenter of the tumor, not the tumor itself. If suppose tumor is 8 centimeter and it's spanning across the G junction, so 8 का जो middle point होगा, where it lies, we classify the tumor based upon that. Tumor may be 1 centimeter, okay, tumor may be 2 centimeter, tumor may be 8 centimeter. So depending upon where the epicenter lies, we classify that. इसका charger देना, इसका बंद होने वाला. So we have two major types of cancer. One is squamous cell, which is more common in Asian population. The cervical part, upper part, middle part, they are most common site for the squamous cell, because as we go from up to the down in the esophagus, the squamous cell epithelium, it decreases and the columnar epithelium increases, cuboidal epithelium increases. So the squamous cell is most common in Asia. The risk factors are smoking, alcohol, hot beverages, corrosive light strictures, achalasia, Plummer-Vinson syndrome. Whereas in the West, the adenocarcinoma is most common, and it typically arises from the distal 1/3 of the esophagus, associated with the reflux, which is more common in obese patient, high BMI patients, gastroesophageal reflux disease, Barrett's is reflux caused Barrett's, and so they have very high chances of developing adenocarcinoma, tylosis and scleroderma. If we come to the symptom, dysphagia is the most common symptom, because it's a mechanical obstruction which is caused by the tumor into the lumen. So the dysphagia starts from the solids, then it progresses to the semi-solids, and finally it progresses to the liquids also. And in very advanced stage, patient is unable to swallow its own saliva, so we call it as absolute dysphagia. The weight loss, loss of appetite, because there is problem with the eating, so these symptoms occur very early. Hoarseness of the voice if there is recurrent laryngeal nerve involvement. Coughing on taking food, it's a sign for there is a communication with the trachea or the bronchus. Tumor has perforated, so tracheoesophageal fistula, and increasing heartburn. Investigations for the diagnosis, you need an upper GI endoscopy and you take the biopsies. For the staging of the esophageal cancer, you do a PET CT scan or the CT chest, abdomen and pelvis. For the surgical fitness of the patient, other than the routine blood test, you do pulmonary function tests to see how good the pulmonary functions are. You do two-dimensional echography, ECG, and to rule out early involvement of the airway, we do the bronchoscopy to see the mobility of the tracheal wall because it is adjacent to the esophagus. We do this only where the tumor is in the location in the esophagus which is in contact with the airway, like upper one third of the tumor or tumor is near the bronchus. So there we do the bronchoscopy, not for the lower third tumors. This is the TNM staging. You must all be knowing and you can read it. Like other tumors, we classify T1, T2, T3, T4. The important thing, the two things which you need to remember is T1B means invasion of the submucosa, and T4 are classified in T4A and T4B. T4B are technically unresectable tumors, means it has invaded into the aorta, vertebral body or trachea. T4A tumors are still resectable, like it has invaded into the pericardium, you can resect it. Diaphragm, you can resect it. Azygous vein, you can resect it. As far as management is there, T4A early tumor, endoscopic management, endoscopic resection is okay as far as margins are negative. For T1B, I just told you that it's a submucosal invasion only. So submucosal invasion or T2 means muscularis invasion. If tumor is restricted to that and there are no nodes as such, so you can do upfront surgery. But for all T3 or T4A tumors or where there are nodes, we call it as locally advanced tumors, and here you have to give neoadjuvant treatment. Either you give chemotherapy or you give chemoradiation. After that you do the surgery. Unresectable tumors are called T4B tumors, or where there are already vocal cord palsy because of the recurrent involvement. You do the definitive chemoradiation. From the past 1 or 2 years, there is a conversion therapy. You need to know the name. You just don't need to know the much details about it. Conversion therapy basically is the combination of chemotherapy with immunotherapy. It makes unresectable tumors resectable. It has not yet come into the guidance, but soon it may be coming. It's just a line which you should know. And for the metastatic tumors or the tracheostomial fistula, if it is there, we just do the palliative chemotherapy and we stunt the airway so that it doesn't block the airway. Regarding esophagectomy, these are the 9 points from the approach till the end. I will be going all this quickly. These are the things which you should remember about the surgery. Regarding the approach, you have 3 approaches. You can do open surgery, you can do lap surgery, you can do the robotic surgery. Regarding the incision, here on this side you can see the big thoracotomy scar. You all know the problems of the thoracotomy: pain, pneumonia, complications are more, hospital stays are more, blood loss is more. And on this side you can see the minimal scar and minimal invasive surgery. Regarding the type of surgery, the esophageal surgery is basically broadly divided into the 2 types. One is where you don't open the thorax, or on the other side you give incision into the thorax. When you don't give incision into the thorax, it is called transhiatal approach. When you give the incision in the thorax, these are called transthoracic because you are entering into the thorax. Transthoracic approach are further 3 types: 3 incision, 2 incision, 1 incision. 3 incision means 1 incision in the neck, 1 in thorax, 1 in abdomen. It is McEwen's approach. 2 incision, 1 in thorax, 1 in abdomen. Ivor-Lewis approach. 1 incision, left single incision which goes from the left side of the thorax, 7th or 8th intercostal space till the abdomen. Single incision, that is called thoracoabdominal or Sweet's procedure. The first one, let's see, is the transhiatal approach. Here the abdomen incision is given, you mobilize the stomach, then a neck incision is given, you mobilize the cervical part of the esophagus, you put finger from the neck and you put the hand into the hiatus, into the abdomen, and you just blindly mobilize the esophagus with your fingers. You don't see anything, you just feel it and you just go. So, and finally the anastomosis is done into the neck. Advantage is there is no chest incision, so there is less pain. Cosmetically it is better. Less pneumonia, less mortality, because in anastomosis in the neck. So even if it is leak, it doesn't go into the mediastinum. So mediastinitis doesn't happen. so less mortality with the neck leak. Disadvantage is high leak rate. The more higher you go in, the more blood supply has to go up, so more high chances of the leaks. So high leaks rate, high recurrent laryngeal nerve injury, because it's a blind procedure. Your finger may damage the recurrent laryngeal nerve, you may not be knowing it, you will know only after the surgery. So high recurrent laryngeal nerve. Less lymph node removal, it's a blind procedure. जो भी हाथ में नोड आ गया, फिंगर से पकड़ लिया, वो आ गया, जो छूट गया सो छूट गया, because you don't see anything, you just feel it and you just remove it. More cardiac arrhythmia, your hand itself goes into the thorax, so you are pressing more on the pericardium and left atrium, so arrhythmias are more common in transhiatal approach. The second is Averroes approach. As I told you, the first incision into the thorax, first incision in the abdomen, you mobilize the stomach, you make the tube and you close the abdomen, you turn the patient, you put the incision in the thorax, you mobilize the lower part of the esophagus, pull the conduit into the esophagus and then anastomose in the thorax. So the anastomosis here is intrathoracic, okay, intrathoracic anastomosis. Advantage is no recurrent laryngeal nerve injury. Why? Because we generally remain below carina. Recurrent laryngeal nerve तो ऊपर आती हैं, carina से ऊपर, उसके नीचे आएंगे नहीं. So very less, no recurrent laryngeal nerve injury. Less leak rates. Why? Because intrathoracic anastomosis, thorax has positive pressure and negative pressure, inspiration, expiration. When there is negative pressure, it sucks more blood in. So the anastomosis की भी जो vessels है, वहाँ से भी blood अंदर खींचता है thorax. So these are better healed anastomosis. Intrathoracic anastomosis are better healed. Second point is it is low into the thorax, so blood supply is better. High lymph node yield. Why? Because we are entering into the thorax, we are seeing what we are removing it. So we see the lymph node, we remove it. So more lymph node yield. Problem is, if the leak happens, then it's a severe mediastinitis and the fatality is almost 80 to 90%. So chest leaks are very dangerous. More pain, chest is open, so thoracotomy pain is there. More pneumonia, more chyle leaks, because we are entering into thorax, we are working near the chyle duct, so chances of chyle duct leaks are there. High reflux rate, because anastomosis is low into the thorax, so the bile, chances of reflux of the bile is very high. The next procedure is a McEwen 3 incision procedure. Here the chest is opened first, we mobilize the esophagus, we do the lymph node dissection, then we close the chest, we turn the patient supine, we do the abdomen part, mobilize the stomach, give the incision in the neck, mobilize the cervical esophagus, and we do the anastomosis into the neck by pulling the conduit. Advantage is highest lymph node removal, because we are removing all the lymph node into the thorax. Less mortality with the neck leaks, because again the anastomosis in the neck, if it is leaks, it doesn't cause much problem, there is no mediastinitis. The problem is thoracotomy pain is there, so more pain, more pneumonia, more chyle leaks, more anastomotic leaks, more recurrent lymph node laryngeal injury, because we are mobilizing the whole of the esophagus near the recurrent laryngeal also till the apex of the thorax. The next is left thoracoabdominal incision. So it's a single incision which goes from the 7th or 8th intercostal space across the costal cartilage, go vertically down till the umbilicus. In this you have to cut the costal cartilage, you have to cut the diaphragm, and then you make the thorax and abdomen a single cavity, and then you do the surgery. And after the surgery you anastomosis into the thorax, and after the surgery you close the diaphragm. So advantage is no recurrent laryngeal nerve injury, because you remain again below the carina, you don't go above that. Less leak rate. Disadvantage is very painful, because the end of the costal cartilage, they move against each other, so it's very painful incision. Diaphragm palsy if diaphragmatic nerve is injured during the cutting of the diaphragm. Chest leak has high mortality, and mortality is very high because anastomosis is intrathoracic. If it leaks, then it's a problem. Regarding the position of the patient, you can do this surgery into the lateral position, you can do full prone, you can do semi prone. Either way the surgeon likes. Regarding lymphadenectomy in the esophageal cancer is of two types, basically two field, means where abdomen and thoracic lymph nodes are removed, or three field where abdomen, thorax and neck, all three lymph nodes are removed. Two field means abdomen part is common in all the lymphadenectomy. The change happens in the thoracic part. The thoracic part of the two field, there are two types, standard lymph node dissection. If in the diagram you can see this shaded part, you remain below the carina, all lymph node below the carina are removed. This is what we call standard two field lymph node dissection. And another is extended two field lymph node dissection. You extend your lymph node dissection part above the carina till the apex. So in this you remove rectal laryngeal lymph node also in extended two field lymph node dissection. Three field means you remove the neck node also, this shaded area between two carotids, and from carotid to spinal accessory nerve you remove all these nodes also. The studies have shown that it has more morbidity because rectal laryngeal nerves are also handled into the neck, and blood supply of the cervical esophagus is hampered because neck lymph nodes are removed. So chances of leaks, rectal laryngeal nerve injuries are slightly higher if we do three field lymph node dissection, but the advantage is that it improves staging. So prophylactic means when there are no neck nodes, we don't do this, but when there are indications, there are only two indications of doing neck dissection. Is one the tumor is in the upper one third of the esophagus, then you have to do this even there are no nodes, and second is any location but you have neck nodes, so you have to do that therapeutically. Conduit, you have three choices: stomach, jejunum or colon. Most common is the stomach, which is based upon the right gastroepiploic artery. Sometimes we also take right gastric also, but it is the right gastroepiploic which is the main. Advantage is that it has flexible length, it has robust blood supply, only one anastomosis is needed into the neck, it is simple and it's quick. Second is jejunum. We can take jejunum based upon the second or third arcade, sometimes fourth arcade also. You can take it pedicled way, means you don't cut the vessels, or you take it as a free microvascular graft. You cut the vessels and you anastomose into the microvascular anastomosis. Advantage is more resilient to the bile and acids. It preserves the stomach capacity because stomach is preserved, so patient can eat more. दो चपाती तीन चपाती जितना पहले खाता था उतना भी खा सकता है वो. Disadvantages, there are three anastomosis and long operative time. Colon, you can take right colon based upon the middle colic artery, you can take left colon based upon the ascending branch of the left colon artery, colic artery. If you take middle colic, right colon, you cut off the cecum, you don't take the cecum. Advantage is very long length available, again preserve the stomach capacity, so weight is preserved. Disadvantage, again three anastomosis are there, so chances of leaks from the anastomosis is there, and long operative time. Regarding pyloric drainage, initially surgeons used to do the pyloric drainage because of the delayed gastric emptying time, but now the studies have shown there is no advantage of doing pyloric drainage. So there are options. You can do pyloromyotomy, you can do pyloroplasty, you can inject the botox into the pylorus, it relaxes it. You can just internally dilate the pylorus from a sponge holder, or you just don't do it. Regarding the route of the conduit, you can take into the posterior esophagus lie here, so you can take the stomach into the same way from the posterior mediastinum, or you can do a retrosternal. Just behind the sternum you create a space. So the posterior mediastinum, it is a short and straight route, space is already there, you just have to pull the conduit up. In the retrosternal it requires more length, you have to create this space, you have to dissect it and you have to create this space, and you have to close the hiatus, the posterior mediastinum wala route, you have to close it. But the advantage of retrosternal is it is safe, even if there is something happens to the conduit, iski ब्लड सप्लाई चली गई या वहाँ से कुछ लीक हो गया, it does not contaminate the mediastinum. So mediastinitis doesn't happen in the retrosternal. That is the only advantage of this route. Anastomosis, you can do it hand sewn, you can do linear stapler, you can do circular stapler. Circular stapler has more stricture formation rate, so usually it's not preferred. Hand sewn or linear stapler, whatever is the preference. And the last thing, you have to do the feeding procedure, feeding jejunostomy. So so that till the time anastomosis heals, patient can be, enteral route is present and you can do the feeding. So thank you.
Thank you, sir, for highlighting the practical and oncological perspectives. Now, I would like to call Professor Surendra Kumar, sir, to felicitate sir for his talk. Thank you. Thank you, sir. Now, our next talk is on gastric cancer, what a postgraduate should know. May I invite Dr. Akash Agarwal. He is professor in surgical oncology. Thank you.
Backward. Good morning, everybody. You just heard a very extensive talk on esophageal cancer. This is probably going to be easier for two reasons. One, stomach is what everybody has seen numerous times. Esophagus दिखता ही मुश्किल से है क्योंकि आधे से ज़्यादा thorax में होता है. So I'll take you through what I think is important for a postgraduate level. So as my teacher many years back told that everything can be divided into three parts. One, what is mandatory, इतना तो आना ही आना है. एक desirable, इतना आएगा तो अच्छे मार्क्स आएंगे. और एक एक्सेलेंस वाली चीज़ होती है जिसमें अगर आपने बताया तो आपको गोल्ड मेडल मिलेगा. तो you can choose where you want to do. I am not going to give you any information about excellence. I am trying to give you all the information about what is mandatory and desirable. I have given my PowerPoint presentation to Dr. Geetika. She must have shared with you, so you don't need to bother to write anything down if you want. And I've also shared a few articles which might be useful for people who want to learn more. So basically everybody will be familiar with the anatomy of the stomach. We have the gastroesophageal junction, cardia, fundus, body and antrum, and the lesser curvature and greater curvature. These are pretty straightforward things. So next important thing about gastric cancer, about stomach, is that the vascularity is very well known. All the vessels are easy to visualize, and as Dr. Shivarajan said, in esophagus you don't have named vessels. Here you have numerous named vessels, and they also have got a very good supply in the muscular layer, which all the vessels will communicate with each other, and that is why gastric dissections are easy to do, and leak rates are not a problem. And you can do a variety of different types of gastric dissections and removing different parts of the stomach. Similarly, venous drain is also very consistent, and there are not a lot of aberrations in the arterial venous anatomy. More importantly, nodal stations. Now, nodal stations are very important, and from an exam point of view, I think at least in my time, they used to ask about nodal stations, numbers, and all these things. So this is just all the nodal stations which are important. This is from Sabiston, everybody must be having it. So I think it is important, and you remember these nodal stations, especially if your Viva is going well. More pertinent things I'll take up when I'm taking up surgery. So what are the signs and symptoms? This is where we start from. So early signs and symptoms are non-specific. Generally people will have very non-specific symptoms. You don't know, they will not know that it is malignant, no specific signs for malignancy. Generally it is burning, dyspepsia, reflux, which are common features otherwise. However, when the things progress, then the symptoms become more pronounced as dysphagia is like more relevant for proximal lesions. Vomiting is because of gastric outlet obstruction for distal lesions. Melena, generally it's not very common, but for large lesions melena might be there, or there might be small bleeds that can lead to anemia. Anemia is a common presenting feature for gastric cancer. Anorexia, because of loss of distensibility will be there, especially when you have something called lineastic plastica, where the whole stomach is basically like plastered and it cannot distend. And weight loss is a late feature generally associated with advanced disease and maybe probably even liver metastasis. So coming to what are the signs. So again, on examination generally you would not find a lot of signs. However, from an exam point of view, you need to know about succession splash. Very difficult to elicit, I mean practically cannot be done, and some people might demonstrate it to you. If they ever do it, definitely learn from it. And then these are what all the examiners would want to know from you. So this is sort of mandatory and desirable as well. So if you know all these specific named metastases, then it's going to be it's important. So please make a note of these. Workup. So workup, people generally start with when we ask, and I also given an exam, when people ask what workup you like to, people start with CBC, LFT, KFT, PTINR, viral markers. Don't start with this. Be structured in your answer. So the structure is two things. One, you need workup to establish the diagnosis, and secondly to stage the disease. Let's, so once you're organized in your mind, you will be able to give a better answer. So establish a diagnosis. How do you establish a diagnosis? Simple, endoscopy. You can do an endoscopy, you can see where the lesion is and do a biopsy. So it gives you some amount of anatomical information and it gives you a pathological diagnosis. This is what we want in the first place. Some people would say EUS, endoscopic ultrasound, fine. It has some benefits in staging, but if you want to keep it simple, just stick to endoscopy. Next, you want to stage the disease. Now, how do you want to stage the disease? Don't start with ultrasound abdomen, or maybe you can start, because that's what teachers might want at times. What I would suggest, say you want a CT thorax and abdomen. If people push more, they might say, do you have indications of MRI? I would generally say no. Some people would ask, would you want to do a PET CT scan? I would say generally not required, but yeah, fine. If you want to, if they push for it, say yeah, fine, we can do it. Generally people would ask, why do you want to do a CT scan upfront? Why you don't want to do a ultrasound? You can simply say it's not very useful in gastric cancer, because even if you do an ultrasound, you need to do a CT scan. So why do an ultrasound in the first place? But again, don't, I mean, you made your point, but if the examiner is like pretty bent over the fact that you need to do ultrasound, say okay, fine, I'll do an ultrasound as well. So don't justify what you're saying, but don't be, don't be obdurate about it. Next, so how do you do staging? So what all you want to see? So this is the TNM staging, tumor node metastasis. Simple. You have to do it for all tumors. Now this is a clinical radiological screening, as in it is both clinical features and radiological. So this is T1 to T4, N1 to N3, and M1 and M2. So this is basically something about T stage. So what TIS is, T1A, T1B is to submucosa, T2 is muscularis propria, T3 is subserosal connective tissue, and T4 is serosa or adjacent organs. So this is a bit about what do you call this T staging. Now coming on to management. So basic principles of management are not very difficult. So we'll just divide this into three major parts. One, what do you do for early disease? Early disease, something like T1N0, maybe early T2N0. You do surgery. So if they ask what you want to do, you say surgery. But most of our patients come in locally advanced disease. Now locally advanced disease is a big gamut of things. We don't want to make it complicated. So simple thing is, what do you do for locally advanced? You give neoadjuvant chemotherapy, then you reassess with using whatever modality you want to do, and you do and then you give adjuvant therapy. Third category is metastatic disease. So इसमें things are pretty clear. You give palliative chemotherapy. However, there are a couple of indications which I can think of for surgery in metastatic CS stomach. One of them is bleeding, other is obstruction. If you can manage these through other means, well and good, but I think these are two important things, and we do end up operating for these indications at some point of time in some patients. So to reiterate, early disease surgery, any locally advanced disease that is T2, T3, N plus, you have to give neoadjuvant treatment. There are dozens of regimens, some common engines, there are a lot of trials. I don't want to discuss with them. It's not needed from you. Types of gastrectomies. Now there are basically two ways of how you can classify. One is about how much stomach you're removing, and second is how much nodes you're removing. So this is what how you would like to define about gastrectomy. So when you remove this greenish part, it's called a proximal gastrectomy. You remove the distal part, it's a distal gastrectomy, and there is something called a subtotal gastrectomy, in which you remove almost the whole of it, just keeping the fundus and G junction and part of the greater curvature, which is supplied by the short gastric artery. So that's why short gastric artery is going to take care of your vessels. So this is basically a simplified way of, there are other classifications more complex, let's not get into it. More important, let's get to lymphadenectomy. Lymphadenectomy is what a lot of people would ask. There are three types of lymph node stations: D1, D2, D3. D1 is stations 1 to 6. Okay, I'll show it to you in a minute. So what you do in a D1 gastrectomy, you do some sort of gastrectomy with a D1 nodal clearance. What is a classical D2 gastrectomy is a D1 gastrectomy plus D2 nodes plus splenectomy and distal pancreatectomy. This is what is known as a classical D2. What is D1 plus or a D2 conventional? Now what we are doing is a spleen and pancreas preserving D2. A D3 is a D2 plus D3 nodes. So, and as a rule convention, you need to at least harvest 15 nodes. So this is probably the most important slide which is going to be useful for you during a surgical viva. So just keep in mind these two things. This is, if your viva is going good, they are going to ask you about D1, D2, D3. I'll briefly show you what the D1 nodes are. These are the D1 nodes. It's there in your handout. So the nodes which are in the proximity to the stomach, immediate proximity to the stomach, are called the D1 nodes. The nodes which are along the main named vessels, the hepatic artery, the gastroepiploic, the left gastric, right gastric, these are all known as the D2 nodes, and the D3 nodes are the nodes which are at the aorta, the superior mesenteric artery, vein, intra-aortic lymph nodes. So these are D3 nodes. So again, this is a picture I have taken from one of the books. So this is showing the difference when you do a distal gastrectomy. When you do a D1 dissection, you just remove stations 3, 4, 5, 6. When you do a D2, you also remove 1, 8, 9 and 7. Similarly, for a middle third or a body cancer, there is a difference in when you do a D2, you do some additional nodes. So this is just to give you an idea of what D1 and D2 is. In proximal, you do extra nodes. So D2 is extra nodes, D3 is still more extra nodes, D1 is basic. So what we generally do is a D2 with a spleen and pancreas preserving. If they ask you what you do, you say you do a D2 with a spleen and pancreas preserving surgery. Now once you have removed the stomach, what do? We need to reconstruct it. How do you reconstruct it? One, you can take the duodenum and stitch it to the stomach, which is generally not practiced as the Billroth one. What we generally do is a loop gastrojejunostomy or a rule loop. So what do you do in a loop gastrojejunostomy? You pull up the loop of the jejunum and stitch it to the remnant of the stomach. Now you can do it in two ways. You can take it in front of the colon, or you can do it behind the colon. So it's an anticolic or a retrocolic. And again, there are modifications. You can do an antiperistaltic or isoperistaltic, but let's not get into that. Okay. So basically, you can do it by the loop, or you can do a rule loop. Then, do you people know about a rule loop? You know about a Roux and Y loop? So what you do in a Roux and Y loop is you basically transect the jejunum and then take it up, and then make another anastomosis of the jejunum with the jejunum. So basically, from one anastomosis you are moving to two anastomosis, which is not a big problem, and it's actually safer and less complicated. I will not discuss major complications of this. Now when you do a total gastrectomy, what do? So you just anastomose the esophagus to the jejunum. It's a rule loop. When you do a proximal gastrectomy, now proximal gastrectomy is generally not a very frequently done procedure. However, some people might do it. Proximal gastrectomy has problems of reflux and other things. So people would generally do a total gastrectomy even for proximal tumors. So if you're doing only a proximal gastrectomy, you do a double tract reconstruction. So basically you take a loop of jejunum, anastomose it to the stomach as well as to the other loop of jejunum. So slightly more complicated but not undoable. So other things which I have not discussed are something called endoscopic mucosal resections for very early disease, endoscopic submucosal dissections, laparoscopic surgery, robotic surgery, different types of neoadjuvant, adjuvant, chemo, radiotherapy. I think that's not needed. You just need to stick to, I think, basics. As far as reading is concerned, I would suggest Sebastian Textbook Surgery. I think is a wonderful book. Thanks to you all, I got an opportunity to read it after many years. It's got, I think, everything for even what an MCH person knows. So for MS, I think it's a go-to book. For operative, I've been reading this book for years, Fisher's Mastery of Surgery. I think if you want to read about gastric cancers, these two books should be more than enough. Some other important things for exams. While you're giving an exam, look out for non-verbal cues. If the teacher is unhappy, you can change your answer. And look out for some good examiners who will be nodding, so you can look at them and you know you're on the right track. You should stand on your ground and you should defend your decisions, but don't get obsessed with that. One example, when I was giving my MS exam, one of my friends who's a transplant surgeon, they asked what will you do if you damage the right hepatic artery. He said, I'll repair it. So he said, fine, what else will you do? And it went on for 5 minutes. Basically what the examiner wanted to hear was a very simple thing, that I'll call somebody to help me. So don't be, everybody is good at surgery, I know that. But then, you need to respect people and don't stick to your ground, but don't go to the level where you offend the examiner. Again, as Samir said, that's it. Thank you.
Thank you, sir. That was a comprehensive review on gastric cancer. May I call Dr. Ajay Kumar Parsal to felicitate sir on his talk?
If you, in case you want to have any other, you want to have any questions, so in the handout, you will have my email and phone number. You please don't hesitate to contact me. Thank you. Thank you. Bye. Teji sir. Anytime. You can drop a message.
Thank you, sir. Our next talk is on the principles of Whipple procedure that will be given by Dr. Anshuman Pandey. He is professor and head in GI surgery, RML. Welcome you, sir.
So this is the phone. So good day everyone, I am Anshuman, and it's always a privilege to speak to young minds who are prospective surgical gastroenterologists, luminal surgeons and cancer surgeons. So I hope to keep you awake. It's a lengthy surgery, but everybody would see what we are doing. I have taken the textbooks for reference and a few patients, predominantly periampullary tumor because it's easier to represent. So this is the basic presentation. Apparently this is not working, so I'll just go ahead. We all know about the origins. So it is a surgery which is very interesting in that regard, that it has stayed the same for many, many years, and still we are deciphering how to get the best outcomes. So Allen of Whipple in 1930s did a multi-stage, then one stage in 1941. The classical Whipple's operation involves the removal of pancreatic head, distal stomach and greater mentum, the entire duodenum and proximal jejunum, and the distal common bile duct along with the gallbladder. The reconstruction, which is also interesting, is pancreaticojejunostomy, hepaticojejunostomy, and a gastrojejunectomy or a pylorojejunectomy. Subsequently, in pylorus preserving pancreaticoduodenectomy, somewhere in 1978, Traverso and Longmire described this procedure. We all know about the surgical anatomy. I'll just brush through it because Dr. Akash has covered a bit of it. This is a very important slide, although I did not know whether I should discuss it with you, because you need to know how to see a pancreatic head tumor. The resectability criteria is essentially on a triphasic CT scan, may or may be without a pancreatic protocol. Please go and read about it. This is a very important slide. Why? Because most of the pancreatic head tumors are inoperable. So the operable criteria is essentially based on the venous and arterial, predominantly arterial criteria. So if no tumor is in contact on the major arteries or vessels, or even if there is a vessel contact of less than 180 degrees, it is resectable. The borderline resectable is the concept whereby we actually give these patients some kind of neoadjuvant treatment and then subsequently try and resect them. So if SMA is around, say, less than 180 degree contact, the celiac axis is 180 degree contact, the common hepatic artery is in contact without extension into celiac axis or hepatic bifurcation. Same goes with the veins too, but veins are more amenable for resection and reanastomosis. The unresectable criteria is the most important criteria whereby you can actually decipher that these patients are unresectable from the outset. The preoperative considerations, of course, we will tell about the modifiable and non-modifiable criteria. The preparation is basically done with the staging laparoscopy. Staging laparoscopy, why? Because we may actually, these patients may have a disseminated disease from the outset which is not picked by any of the imaging and PET scans, especially in patients who have got alleviated or increased CA19-9 values. Sometimes CA19-9 values may be increased in inflammatory processes too, but usually less than 3 times. The incision is usually midline or bilateral subcostal, known as chevron. The initial maneuver is division of the umbilical ligament, which may be used as a cover to the gastroduodenal stump. I'll show you some photographs and a very small video. Now the first step is entering the lesser sac after we have identified that this patient is resectable. So the gastrocolic trunk, as we just discussed, is the anatomical hazard. It may cause a lot of bleeding. The surgical strategy is to ligate these vessels. The mobilization, after mobilization of the hepatic artery and right colon and mesentery of the duodenum and pancreatic uncinate. So this is how it looks like. This is a periampullary tumor, and whereby we enter this place. Now we have heard about this Cocker's maneuver. The Cocker's maneuver is usually extended. What is extended Cocker's maneuver? We are not talking about cattle brash. You should read all these terms. They are very good terms, but essentially means the amount of dissection of picking up all these anatomical things from the retroperitoneum. So the Cocker's maneuver is essentially pancreaticoduodenal specimen is lifted anteriorly. Posteriorly, we see the inferior vena cava, right gonadal vein, left renal vein, and aorta. All the fibrofatty tissues from medial to right gonadal vessels is swept with the specimen, and the gonadal veins are preserved. So this first step, if you can, this is the pointer, if I may have the pointer. So can you appreciate what is the structure? This is the IVC. This is the entire pancreaticoduodenal specimen. This is a Cocker's maneuver. Now in the next step, we'll see all the vessels. So can you appreciate this vessel over here? This is an extended Cocker's, and this is the bile duct being seen over here. Next comes the portal triad dissection and vascular control. The initial portal access is taken through the pars flaccida. I'm sure you must have heard about that term. The gastrohepatic ligament is then open. we have to be considerate about the replaced accessory left hepatic artery if present. It may give rise to a lot of bleeding, and we may sometimes unnecessarily tie it also. Incise the anterior leaflet of the hepatoduodenal ligament or hepatoduodenal ligament. The key lymph node dissection, the lymph node overlying the common hepatic artery is dissected and removed. Identification and ligation of the gastroduodenal artery. Now, this is a very important step. We all know about the common hepatic artery with its bifurcation into the proper hepatic artery and GDA. All these terminologies essentially mean that once the GDA is given off, then we call the artery in a separate term. Circumferentially dissect the gastroduodenal artery, ligate the small anterior and superior branch of gastroduodenal artery, and then subsequently test clamp the gastroduodenal artery. Sometimes the gastroduodenal artery may be the sole thing, or we may actually pick up the common hepatic artery, which is the sole supply, and we may give rise to a subsequent catastrophe. So, can you appreciate this? This is of course after the resection of the specimen, but I'll just put this picture here. Now, we always tie it off, giving it a stump of 1 to 2 centimeters, so that we may have an access in terms of post-operative bleed. So, we all have heard about post-operative pancreatic hemorrhage, POPH. So, this is one of the most dreaded complications following the surgery, following a leak. So, you actually have to have a stump so that your intervention radiology friend can give rise to this. So, we have made it a practice of actually putting in a metallic clip over here so that it is easily identifiable. So, can you appreciate it? I hope everybody is not sleeping. We have done nearly half of the surgery. Then comes the gastric and duodenal transection. Of course, the classic part and the pylorus preserving part. The division point may be along the distal stomach, as Dr. Akash had suggested. Pylorus preserving is usually avoided when we have the large tumors. The technique is to divide the duodenum 2 to 3 centimeters distal to the pylorus. You may do it with hand or with a GIA stapler. The preservation of the right gastric artery for vascularity and nerves of Letaget is there. So, this is the basic difference. Sometimes you may be asked that what is the difference between the classic Whipples and the PPPD. We can always go along the resection content, the benefits, the oncological safety, and the long-term outcomes. Now comes the division of jejunum along with the ligament of Treats. It is in the infracolic compartment. Lift the transverse colon cephalad to identify the ligament of Treats and the proximal jejunum. The inferior mesenteric artery is an important landmark, and the dissection should be medial to it. It is always lying onto the lateral side. Sometimes we may have a tortuous vessel, but still you will have to be above it. The jejunal division is divided around say 5 to 10 centimeters distal to the ligament, and then subsequently we may bring the jejunum on the same side, the anatomical side, or we come through the transverse mesocolon. The major risk: posteriorly the duodenum crosses the superior mesenteric artery. Avoid large bites into this tissue, and especially with hormonic and other energy devices. Sometimes it may cause torrential bleeding. So, after we have dissected this thing off, we may pass the entire thing from the posterior to the major vessels. So, this is how we divide it. Once we have done it, can we appreciate that we will take this proximal part of the jejunum from the anatomy behind the vessels onto the supracolic compartment. Now comes the division of pancreas and venous dissection. The pancreatic transection is done after creating a retropancreatic tunnel, which is usually done initially because that is a concept for resectability. It is done over the superior mesenteric and portal vein. The pre-placed hemostatic sutures are important. We take it superiorly and inferiorly. Please do not sleep, because it is very, very important. We have just discussed what are the anterior and posterior arcades. The important thing is the uncinate venous dissection. The specimen is separated from the superior mesenteric vein by ligating multiple small venous branches from the pancreatic head and uncinate. The critical structure over here would be the first jejunal vein, which runs posterior to the superior mesenteric artery. It receives tributaries from the uncinate process, and excessive traction may avulse this branch. Now, can you appreciate it? This is the sutures, the transpancreatic sutures taken inferiorly, superiorly and inferiorly. This is the specimen side, this is the patient side. We are cutting it with the electrocautery onto the neck of the pancreas, and this is the transected pancreas with the vein being lying behind. Now, important thing, if your viva is going well, as Dr. Akash had just said, that we may actually decipher what kind of uncinate the patient possesses. It is type 1, 2 and 3. Please go and read about it. Sometimes the uncinate may be very bulky and it may go well behind the major vessels and it may be a problem. So, the uncinate dissection, the goal is for R0 dissection. The technique is to retract the superior mesenteric vein to the patient's left to expose the SMA, establish a periadventitial plane, dissect from caudal to cranial or otherwise. The inferior pancreaticoduodenal artery arises to the SMA and it should be ligated individually for clear visualization, and we have to be considerate about the fact that there may be a right replaced hepatic artery, means it is coming directly from the superior mesenteric, and so we may actually encounter that and we will have to tackle that. So, this is how we do it. Now, this is a small little thing. Can you appreciate that this is the artery and this is the vein? My assistant is just picking it up onto his side. This is the uncinate process which we will just see. Can we appreciate this thing? Now, this is the real plane. We do not have to leave this plane quite significantly. Why? Because this is the area where we have the maximal recurrence. Now, this is a very important step. This is the most critical step, I believe. Why? Because it may give rise to a lot of hemorrhage, and we have to be cautious about the fact that this is a site of recurrence. Now, we come to the reconstruction. The surgery is done, the specimen is out, just check for any kind of hemostasis. The pancreaticojejunostomy, many questions would be asked about what kind of pancreaticojejunostomy. It is considered to be the Achilles heel, the most important small. So, we may have to pass in a stent, and we take some kind of a transpancreatic suture to know to do some procedure like splaying of the duct, whereby we open up the duct so that it does not close on its own and give rise to pancreatic ductal hypertension and leak. So, these are the few steps. This is the completed PG. We do an invagination technique where I will just tell you about the techniques, which is the question. Techniques are usually Blumgart, modified Blumgart. These are duct to mucosa. Essentially, there are two kinds of technique: duct to mucosa, whereby the duct is given to the mucosa, and then invagination, whereby we bury the head of the pancreatic stump onto the jejunum. So, we usually do a classical dunking or invagination technique. You may read all these things in the books, but essentially one example I will give you, that we place a transpancreatic sutures with seromuscular sutures, and the duct to mucosa anastomosis is done in a circular fashion, then complete the seromuscular bites. These are the modifications of these bites, and then subsequently all these people have done all the modifications. So, in the interest of time, I am not going into that, but all these terminology, if your viva is going very well, you may actually be asked. This is the classical invagination technique. Invagination means that we are not doing a duct to mucosa, we are just burying the head of the pancreas after the seromuscular sutures, as we have just shown, in 4 layers to the thing. We may or may not stent the pancreatic duct. Now, the recent happening which is here is basically a Peng's binding technique. He is a Chinese surgeon. He just actually retroflexed the entire jejunum, put the pancreas inside, took the jejunum limb over the pancreas, and then subsequently did the anastomosis. Then from the edge side, just 2 more minutes please, from the hepaticojejunostomy enterotomy side, he checked whether on table is there the pancreatic sutures are holding up or not. So, this is the comparative technique. Essentially all of them are similar. Patient should have a good outcome. Then we come to the hepaticojejunostomy. It is basically a modified Blumgart technique. How does it look like? Is basically a single layer interrupted suture. The gastrojejunostomy and reconstruction, followed by a feeding jejunostomy. So, this is the basic sequence: PJ, HJ, GJ, and subsequent we always do a feeding jejunostomy. feeding jejunostomy is basically a safety valve so that the patients would be having some kind of a feeding port if the pancreaticojejunostomy leaks. The newer concept is basically the artery first approaches. I am not talking too much into it. Is basically maybe approached from all these various sides. And the important thing, I'll just take a minute or two, is basically the mortality rate. Historically 20 to 40%, but now it is significantly decreased to 4 to 6% or 4%. Despite reduced mortality, that is the interesting part, that is why this surgery is still intriguing. The procedure remains complex and the overall complication rate or the morbidity rate is 30 to 40%, which is quite significant. Nearly the half of the patients would have some kind of morbidity. Important complications: pancreatic fistula, delayed gastric emptying, post-pancreatectomy hemorrhage, intra-abdominal infection, and of course long-term diabetes. I am not talking too much into the details, but you must read about the post-operative pancreatic fistula. There are newer definitions with all these techniques, the grading systems. This thing has stopped working. The delayed gastric emptying, again, this is a classification. There have been randomized studies. There is a definition of A, B, and C. You may read it. This is the basic criteria. This is the International Society. How are we managing all these things is again the same thing. So I am not talking, this is not my domain. This has been our data a couple of years back. We looked into our data. The rest of the complications remain the same. This is 108 or 10 patients, and we have been able to publish this kind of a data whereby we suggest that if the technique is standardized, the pancreaticoduodenectomy is feasible, possible in nearly every case who have been actually taken up for surgery after a good assessment. So key messages: it's an interesting surgery. Most of the diagnosis is done preoperatively. The patient has to be prepared well. How you do it is not important. The patient has come to you for cure. It can be done laparoscopically, robotically, or open. The important thing is that the patient should have cure, and we have got good results of it. So thank you so much for all your patient hearing. I hope I have done a bit of justice to this very extensive topic, and thank you the organizers for actually letting me in again in this beautiful campus. Young minds, please be young. Ask questions.
Thank you, sir, for simplifying such complex topic for us. Now, I would like to call Dr. Gitika Nanda ma'am to felicitate sir on his talk. Thank you, sir. Thank you, ma'am. Our next talk is on cystic neoplasm of pancreas. That will be given by Dr. Puneet, sir. He is professor in the Department of Surgery, IMS BHU. We welcome you, sir.
Okay. All done. Yeah, good morning everyone. At the outset, I want to thank the organizer and the head of department, KGMU, for inviting me for this talk. And the topic which was allotted to me was cystic lesions of pancreas. I can see there in the brochure, it has changed to cystic neoplasm of the pancreas. But what I feel like, it is better to talk about the cystic lesion of the pancreas, because as a resident, when the lesions present to us there in the OPD or the clinics, we want to differentiate exactly, is it a neoplasm or something else. So first, as a resident, we have to differentiate, are we dealing with a neoplasm or some benign lesions we should differentiate it, then only we can proceed. So it is very common when we are sitting there in, I am audible there on the back? It's okay. So it is very common when we are sitting there in the OPD, we get a ultrasound or CT, the patient presenting where there is a cystic lesion there in the pancreas. So as a resident, we must know exactly, we should classify them, we should identify them exactly what is the lesion, and we can treat them accordingly. It is important to know that majority of the pancreatic cysts are the pseudocysts, and autopsy series have shown that 25% of the pancreas they have a cyst. So it is very common to have a cyst there in the pancreas. So when the patient present with ultrasound or CT, one should know exactly, because we can see here the various type of cysts what you can get there on CTs. They are different cysts, they are not the same cyst, and the management is totally different. I will be elaborating in the further slides. So already I have told you it is very common to have a pseudocyst there in the pancreas. The other cyst, that is the neoplasm, can be a serous cystic neoplasm, mucinous cystic neoplasm, intraductal papillary mucinous neoplasm, that is also known as IPMN, or the solid pseudopapillary neoplasms. So these are the different neoplasms which can be seen there in the pancreas, and apart from that there are others rare cystic lesions, they are also seen there in the pancreas, and those rare cystic lesions are the cystic islet cell tumors. With the islet cell tumors are there is a cystic degeneration may be seen. Lymphoepithelial cysts, they are basically the peripancreatic cyst, not the pancreatic cyst, and there may be a cyst seen there in the autosomal dominant polycystic lesion, where the cyst in the pancreas, they are associated with the cyst there in the liver and the kidney. So these are the various cystic lesions you can find there in the pancreas. Now how we should evaluate? I will be covering there in the further slides what findings you can get, but of course if you have a cystic lesion there in the pancreas, they should be evaluated with the CT, MRI. But the EOS is the other investigation which has been done in the patient, where the differentiation between the lesions are not possible as such, because EOS has got an advantage. Not only we can characterize the lesion, at the same time we can do also the FNA. FNA means we can aspirate the solid component which is there in the form of nodule or thickening, or we can send the aspirate, that is the fluid aspirate there for the cytology and other investigation I will be covering later on, to know exactly what is the cause. Now I am talking about the pseudocyst, which constitute around 70% of the pancreatic cystic lesion, and we all know that if the patient have a history of pancreatitis, whether it is acute pancreatitis, chronic pancreatitis or traumatic, then we can suspect it is a pseudocyst. So it is very important when these histories are present in the form of pain and so forth and so on, then we may suspect that the patient may have a pseudocyst. And of course we all know that pseudocysts, they are rich in amylase. Now imaging are done in, of course that can show a lesion in the pancreas. Now the serous cystic neoplasm, this is basically a cyst which are present there in the, mostly there in the head and uncinate, and these cysts are usually less than 5 centimeter, common there in the female. When we talk about the cystic neoplasm of the pancreas, it is more common in female in broad way to remember, except for one lesion, that is IPMN. IPMN is more common there in the males, otherwise rest of the cystic neoplasm are more common in female in comparison to the males. And it is important to note that the serous cystic neoplasm, these are the oligocystic or microcystic. Oligocystic or microcystic means you can have a sponge-like appearance. There are n number of cysts which are present there in the lesion, as you can see there in the diagram, photograph here. And you may have a few cysts present there in the head of the pancreas. So these are the various, in various form these cysts are present, and these cysts are the benign cysts, they are not the malignant cysts, and the incidence of malignancy in these lesions the incidence of malignancy in these lesions is less than 3%, and therefore you can easily leave these patient and put it there on the surveillance, and of course if we suspect any malignancy we should operate these patients. Already I have told you there are n number of cysts which can form a honeycomb appearance or sponge like appearance here, and there may be a central stated fibrotic scar which may be evident there in this CT scan, as you can see here, and it may be also evident there in the pathological specimen. So if these lesions they are detected, we can easily make a diagnosis of serous cyst adenoma. Now serous cystic neoplasm, they are also associated with the von Hippel-Lindau syndrome, where the multiple cysts are present in the pancreas. As I have said, these are the benign lesions, therefore there is no need for any treatment in these patients, you just follow up this patient. Now, the other neoplasm is the mucinous cystic neoplasm of the pancreas, which may vary from the cyst adenoma to the moderate dysplasia to the adenocarcinoma. Adenocarcinoma as such is not so common as such. The mucinous cystic neoplasm is the most common type of pancreatic cystic neoplasm. As already have enumerated, all these neoplasms, they are more common there in the females. They are mostly been seen there in the body and tail, as you can see there in the photograph. And you can see the septa which is present there in these lesions. It is very evident present there in the tail of the pancreas, and they are not they have no connection with the ductal system, and therefore there is no increase in the amylase level. You can find it out. I will be elaborating there when I will be showing and telling you about the aspirate, how you are going to assess these lesions. This is the CT scan where you can have a huge lesion present there in the form of mucinous cystic neoplasm. You can see the septa which is there. This is the specimen and which is resected out. The cut open shows a multiple septated, you can say, cyst which is present there. How we can suspect a malignancy? Malignancy may be present in these patients to the tune of 5 to 25%. And how, when we suspect, if it is a large cyst which is there, it is thickened wall, or if they are hypervascular there on CT scan. So normally, if there is a hypervascularity is seen, we suspect it is a malignant lesion. Now, the next condition is the intraductal papillary mucinous neoplasm. They are not so common as such. They constitute around 10% of the pancreatic cystic neoplasm. Already I have told you this is the only neoplasm which is more common in males. Rest of them, they are more common there in the females, and you can see mostly it is seen there in the head of the pancreas, as you can see there in the diagram. Now, it may involve the main duct, it may involve the branch duct, or it may be a combination of both. But it is important to remember that if these lesions, they are arising there from the branch type, they are mostly common there in the younger male group, and they have low malignant potential. So it is important to note that they may be present in both main and branch duct, but they are less malignant if they are present in the branch duct. So how they are present there on CT? What happens there in the cystic mucinous collection in these ducts may form a cystic lesion there in the pancreas, and they are apparent like a cyst of the pancreas. So it may be there in the main duct or the branch duct, depending upon the sites also evident there on CT scan. And there is a mucinous accumulation occur in these cysts, and these mucin, they may be excluded out there from the ampulla of Vetter, and if you do a ERCP, they may be appear like a fish eye appearance. You can see this fish eye appearance of the papilla there on ERCP, and you can see the mucin is excluding out there from the papilla. These IPMN, they are notorious. They are notorious means they may be present in the form of adenoma, and they may progress in due course of time to have an invasive carcinoma, and that duration vary there from 3 to 6 years depending upon, and therefore, if we detect these lesions, we must operate. So the mucinous cystic neoplasm and the IPMN are the two conditions. If we get there in the clinical practice, we must operate because of the incidence of malignancy. Already I have told you the branch type have a lesser incidence of malignancy in comparison to the main duct type, and the predictor of malignancies are if the size is more than 3 centimeter, if there is a mural nodule is present, and the pancreatic duct diameter is more than 10 centimeter. If these criteria they fit into, we may suspect the patient to have a malignancy, and already the incidence of malignancy told you it is 10 to 25% in the side branch type, and it is more than 50% there in the main duct type. The IPMN is other notorious thing that they may have a malignancy there may be associated with malignancy there in the other organs, and those organs may be a colorectal, gastric, or bile duct malignancy. Now the other condition is solid pseudo-papillary neoplasm. As name implicates, they are the solid tumors, and how they become cystic? When they become large, they have a degeneration occur there at the center, and that may form a cyst. It is more common again there in the female, and they are very large tumor. They become very large unless until they become symptomatic as such. The other lesions already I have told you is the cystic islet cell tumors, which may represent like an incidental finding. How these islet cells they are different there from adenocarcinoma. You can diagnose there on CT, they appear like a hypervascular lesions there and hyperdense lesions. Now the other rare varieties of the cystic lesions, first is the lymphoepithelial cyst. Basically these are the peripancreatic lesions, not the pancreatic lesions, but they are present in close relation to the pancreas, therefore they may be misdiagnosed as a pancreatic lesions. Autosomal dominant polycystic kidney disease may be associated with the cyst there in the pancreas also, and there rarely you can have a benign retention cyst. They are the means benign cysts, therefore there is no need to have any treatment to these lesions. Now if we get these lesions, how we should approach? Of course already I have told you, if we have these lesions, we suspect it is a pseudocyst, there may be a history of pancreatitis, and therefore the history taking is very important. The biochemical investigation can also help you out, and of course you will do a CT and MRI to diagnose these lesions. If we are not able to differentiate them on the CT and MRI, we do a EUS and US guided FNA and aspirate should be sent. Now how we can do it, like you can have both radial and renal probes which can aspirate, you can aspirate the cyst fluid, we can have a biopsy there from the nodule if it is present there, and those aspirate must be sent there for the cytology, viscosity, mucin, glycogen, enzymes, that is amylase and lipase, along with the tumor marker. Now cytology of course may not be very accurate in these patients. We all know that cytology, when we are doing it there from any fluid, they may not be so accurate, but viscosity will tell you exactly if it is a mucin secreting tumors. Already I have told you the two notorious tumor, that is the mucin secreting and IPMN, both are notorious, and viscosity is high in if they have a mucin. Amylase and lipase, the amylase is raised if you suspect it is a pseudocyst of the pancreas, and the CA here it is very important that differentiate, are we dealing with the mucinous tumors or we are dealing with a non-mucinous tumor, because already I have told you the mucinous tumor has a high malignant potential, and therefore we have to differentiate between the two. That can be differentiated based on the CA. Now the CA, when we talk about, normally what we know about the colorectal malignancies, the cutoff is taken as a 4 nanogram per ml, but here when we aspirate and we send the CA estimation, it is 192 nanogram per ml, not the 4 nanogram per ml. So it is very important to remember the cutoff is different here when we deal with the aspirate of the cystic lesions there from the colorectal malignancy. It's okay, although it won't differentiate between MCN means mucinous cystic and IPMN, but it can differentiate the mucinous and non-mucinous tumors. Now how we can differentiate, are we dealing with mucinous, are we dealing with non-mucinous? We can differentiate means taking into account all the investigations what we have done till now, along with the CA, that can give a best sensitivity, that to the tune of 91%. And of course if you take alone as such, the CA is the best one to differentiate between the two. Now how we are going to treat these lesions? Of course already I have told you the serous cystic neoplasms, they are the benign tumors, they are mostly less than 5 centimeter, they don't need any treatment, just we have a surveillance of these lesions, and they should be treated if we suspect a malignancy in these patients, which is very rare as such. But of course the larger lesions, symptomatic lesions, they should be treated with excision of course. So what happens, what kind of surgery we do depending upon the site of the lesions? If they are present in the distal, tail and body of the pancreas, we should do a distal pancreatectomy to these patients. As you can see here in these patients have a serous cystic lesions present there in the body of the tail of the pancreas. So we have done a distal pancreatectomy in these patients. When we are doing a distal pancreatectomy, we are operating a benign lesions, so we have to preserve the splenic vein which is there on the posterior aspect. The mucinous cystic neoplasm, already I have told you they have a malignant potential, and therefore we have to resect it out depending upon the site where they are present, whether they are present in the body and tail, distal pancreatectomy, or if they are present in the head of the pancreas, we have to do a pylorus preserving pancreatonectomy. Now here is the lesion of a mucinous cystic neoplasm which is present there in the body of the pancreas, as you can see here. And now since it is a very large lesion, it is important to have a control over the you can say a splenic artery. Once we have a control over the splenic artery, we have resected out. You can see this is a splenic vein, this is a portal vein which is there, this is SMV and the portal vein, and we have resected out this specimen. Now here is another patient with the mucinous cystic neoplasm. As you can see here, this is a huge mucinous cystic neoplasm which is present again there in the body and the tail of the pancreas. We have resected out the lesion. Now it is again, we are able to preserve the splenic vein which is present posteriorly. You can see there are lot many branches which are means we have ligated there, and the specimen means the pancreas has been divided there at the neck of the and this is the spleen is also preserved. So it is a spleen preserving distal pancreatectomy we have performed in these patients. So it is very important that if they are not invading, most of these lesions they don't invade this splenic vein, so we can easily preserve this splenic vein in these patients. Now the management of IPMN for the postgraduate, you can say again, it depending upon the site of the lesion we should do a resection, but it is very controversial to decide exactly. It's all because of the reason they are multifocal. So we can have 20 to 30% of the IPN, they are multifocal. So how we can decide exactly how much we have to operate? We take the help of the frozen section if they are available, and that decides exactly what kind of surgery we can do to this patient. And in these patients, sometimes we land up into doing a total pancreatectomy. Now the condition is a solid pseudopapillary cystic neoplasm. Just 1 minute more. So here is the patient having a solid pseudopapillary cystic neoplasm which is present there in the head of the pancreas. You can see this is the lesion which is present there. So we did a Whipple's there. So that is the pylorus preserving pancreatectomy we perform in these patients, and we did a gastroscopy here in these patients, and finally the hepatogenostomy. Another patients of a solid pseudopapillary neoplasm present in the tail of the pancreas. So it may be present both there in the body and tail of the pancreas, and we have done a, you can say this is a splenic vein which is evident there superiorly. So we did a distal pancreatectomy in this patient, and here is the specimen. You can see it is a solid component which is there along with the cystic degeneration. That is the solid papillary cystic neoplasm. So I conclude that the cystic lesions of the pancreas is common, and the differentiation between the pseudocyst and the neoplasm is very crucial. The most common type of pancreatic cystic neoplasm is the mucinous cystic neoplasm. We should evaluate these patients with CT, MRI or US and US guided FNA, and the CA is very important to evaluate, and the levels of CA is totally different as you can get there in colorectal malignancy. Thank you.
Thank you, sir. Thank you, sir, for the informative discussion on this very important topic. Now, I would like to call Professor Abhinav Arun Sonkar, sir, to felicitate.
Of course.
Any questions from the audience?
But these are very low-grade malignancies, and probably one should like to go for preoperative diagnosis in this particular case, and could have gone for enucleation if it possible. What was the reason for doing Whipple's procedure?
When we talk about the enucleation, I have never thought of, because these are the very huge lesion. It is nearly impossible to have a enucleation in these patients. Of course, you can do a conservative surgery when it is present there in the tail of the pancreas.
I don't know, I may be wrong, but 2-3 patients I've seen, they had small, they could be removed, and in one patient also we had to go for Whipple's procedure, but they are very low-grade malignant potential tumors, and if you make diagnosis beforehand, then probably you can go for it. I mean,
I don't have first-hand experience of enucleating
it's all enucleation also
these
written
lesions
there,
are
conservative
difficult, all
surgery
because
also
of the
written
reason if they are present in the head of the pancreas, they are in close relation to the duct. I don't know, Dr. Nag is there, Dr. Kaman is there, if they have any experience of doing enucleation in these patients.
Yeah, definitely it will depend upon the, I think, size and the nature of the tumor. And if we are talking about enucleation, I think the span, it will be a bit difficult. Span is pseudopapillary, the tumor, it is more kind of invasive kind of thing. It is, even though it is an indolent kind of behavior, so still it should be considered as malignancy. But if you come to, I think, cystic neoplasm, classical, serous and mucinous, you might have a kind of, encapsulated lesion, which is, I think, less than 3 centimeters or less than 5 centimeters away from the main duct. In those situations, I think, you can try a kind of enucleations. If it is, the preoperative risk factors are low, like FOCOCO guidelines, if you follow risk factors. If it is already a high risk kind of thing, I will go with a resection rather than a enucleation. But if I have got the low risk or a worrisome thing only, like, the cyst size is less than 3 centimeter, main duct is less than 1 centimeter, and there are like other worrisome factors
Sir,
are not there.
he want to know about the solid pseudopapillary neoplasm.
On a solid pseudopapillary tumor, I don't think there is a place for enucleation.
There is no place
of
for
course,
enucleation.
Dr. Sonkar might be having some his personal.
Dr. Nag, you want to add it on there, like you want to say something?
we had 2-3 different experiences.
Okay.
One, my earlier boss did enucleation, and he was, hell-bent on telling us. But there, I have seen books, even in Shackle for this Magothabram surgery also writes that enucleation is possible. These are low-grade potential, or they're benign also. There's a huge spectrum, just like lipoma, there's a spectrum of disease. And the malignant position is very less. Now, those where it is not possible to resect, you obviously do Vipul's procedure, and we also didn't publish it in BMC case reports also. My question was, is it possible to, do this thing?
Enucleation as such.
Enucleation sometimes, because
basically,
in this case we could make diagnosis, and then there is another case where we did operate the patient. The whole portal vein and I think mesenteric artery vein was enclosed in that. I did not have expertise to do resection and anastomosis or porcine graft or PTFE graft, so I did refer to my friend Shailesh Shikhan. I did that. So these are few conditions where we understand it's not actually possible. But my question was, if it is, I remember I get to point what you are saying, but you also want to say something.
Actually, 2-3 points are important. One is the what is the case, whether it is benign or malignant.
solid
If there is
pseudopapular.
suspicion of malignancy, then two things have to. It should be removed in toto with a proper margin. If it is possible by preserving duct, then that is fine. Otherwise, anyways, in head region, we have to do pancreaticoduodenectomy. That is my.
So, in nutshell, what I feel like as a postgraduate, you should go ahead with the idea exactly. We have to resect out tumors because they have a low malignant potential, but they have a malignant potential. So, of course, what Dr. Sonkar is saying, of course, you can do a enucleation, but that too restricted to a few cases. We won't accept as such because in the literature we also when we go ahead and see. Most of these cases they are treated with the formal resection in the form of pancreaticoduodenectomy rather than doing a enucleation. Of course, case reports are there. Maybe Dr. Sonkar has experience of doing so. Maybe in few cases one can do so. But normally, if we talk about the literature, it is recommended that we should have a formal resection in these patients in the form of pancreaticoduodenectomy and distal, you can say pancreatectomy. So I think if any other questions there from the any audience.
Thank you, sir. Sir, kindly come up on the stage to felicitate, sir. Thank you, sir. Our next talk is on the topic benign esophageal disease by Dr. Pankaj Kumar, sir. He is Associate Professor in the Department of General Surgery, KGMU.
Good morning, respected teachers and dear students. Today, I have been allotted a topic of benign esophageal disease that I will try to cover. Esophagus, as you know, is a tubular structure lying in a posterior mediastinum, extending from neck to abdomen. It commences from C6 to T11, and length is around 25 to 30 centimeter. It enters into the abdomen through the esophageal hiatus through the T10, which is separated by aorta by the median arcuate ligament. Histologically, it is distinguished from other structures of the alimentary tract by the lack of serosa. And there are two distinct pressure zones are there in esophagus. One is the proximal, that is called as the upper esophageal sphincter, and another is the lower, which has a low pressure and is called as the lower esophageal sphincter. So, before going into this benign disorders, we should understand the this basic structures, that is the sphincters, that is also contributing to the benign disorders. It is involved in the swallowing process, upper esophageal sphincter, and it comprises the cricoid cartilage at ventral border and the cricopharyngeal muscles. And it is measured about 4 to 5 centimeter, and pressure is around 60 millimeter of mercury, On other hand, the lower esophageal sphincter is to prevent the reflux of the gastric content into the esophagus, and release of the gases from the stomach is also a function of the lower esophageal sphincter. It is usually total length is it is around resting pressure is 6 to 26 millimeter of mercury, and be it any esophageal disorder, there are certain features. Most common is the dysphagia. A patient will have a minimal features, but most common is the dysphagia. It is the sticking of the food, and it, as the severity increases, the absolute dysphagia is inability to swallow the saliva. Odynophagia, chest pain, retroesternal burning pain, recurrent respiratory tract infections, regurgitations, weight loss, and sometimes hematemesis can also be seen in the benign esophageal disorders. Investigations which are being done are the plain X-ray, most commonly performed, then the barium or the gastrographin, either that is the contrast swallow. Upper GI endoscopy is one of the most important investigation for the diagnosis of the benign esophageal. Esophageal manometry for the motility disorders. 24-hour pH monitoring, it is for the diagnosis of the GRD. It has the different parameters, and the D-Mister score of 14.7 is considered as a diagnostic for the GRD. CECT and the endoscopic ultrasound may be sometime be needed in the benign disorder also. So if we classify the benign esophageal disorders, it can be categorized into the motility disorders, diverticular disorders, GERD, hiatus hernia, acquired disorders, congenital disorders. Most commonly is the tracheoesophageal fistula and the esophageal neoplasm, benign neoplasm of the esophagus. So motility disorder is usually the functional disorder in which there is either the pathology in the contraction and the peristalsis, or the pathology in the lower esophageal sphincter. That is the motility disorder. Okay, so it has been classified by the Chicago classification. That is the version 3 of the motility disorder. In this, it has been classified as the achalasia, which is here. Achalasia has been subdivided into 3 parts. Type 1 is when there is a median IRP, that is the interstitial relaxation pressure, more than 15 millimeter of mercury and 100% of failed peristalsis. These are the 2 criteria for the achalasia cardia. Okay, so when DCI is the amplitude into duration into length of the distal esophageal contraction exceeding 20 millimeter of mercury. So if it is the failed peristalsis, that is DCI less than 100, it is type 1. If it is DCI is more than 450, then it is type 3. And if it is 100% failed peristalsis with the pressurization more than 20% of swallow with the esophageal compression, that is type 2. So type 2 has the best prognosis from the surgical point of view. It has the best satisfaction rate. Type 3 is the least satisfied and the highest failure rate. And type 1 is intermediate, and it is usually advised pneumatic dilatation followed by the surgical as a second line. Sometimes there is another entity in which there is no peristaltic disorder, but there is a persistent lower esophageal sphincter IRP is raised. Okay, so that is the hypertrophic hypertensive lower esophageal sphincter. That is also a subtype of your achalasia cardia. Other disorders are the distal esophageal spasm. In this, the premature contraction with DCI more than 450 millimeter mercury into second into centimeter. Hypercontractile esophagus, also called as the nutcracker esophagus or the jackhammer. At least 2 swallow contraction with DCI more than 8,000 DCI. Ineffective esophageal motility is labeled as when there is a more than 50% of the ineffective swallow. You know the contractions are the primary, secondary and the tertiary contraction. Primary is initiated by the bolus, secondary is by the as a reaction to the dilatation, and third is the non-propulsive contraction. Fragmented peristalsis, if more than 50% fragmented contractions with DCI more than 50 millimeter mercury is the fragmented peristalsis. So these are the terms which were defined in the Chicago classification. So first we discuss the diffuse esophageal spasm. It is common in women, and usually the lower 2/3 is being involved, and present with the chest pain and the dysphagia. Regurgitation of esophagus, regurgitation of esophageal content and saliva is very common, and diagnosis is done by the radiography and the manometric studies. Here you can see there is a diffuse esophageal spasm is here. Usually the treatment is not very satisfactory, and it is mainly the non-surgical treatment in form of the nitrates, calcium channel blockers, anticholinergics, and sometimes this diffuse esophageal spasm present with the dysphagia. So in that, the Buji dilatation can be attempted with the variable satisfaction rate. On other hand, if patient is presenting with the regurgitation GRD symptoms, then you have to add the prokinetics for this patient. Nutcracker esophagus, also known as the hypercontractile or the jackhammer esophagus, with the hypertensive peristalsis or high amplitude peristaltic contractions associated with the hypertrophic musculature, and it is the most painful motility disorder. Present with chest pain, dysphagia or odynophagia, and usually here is also the treatment is the same in the form of the calcium channel blockers, nitrates, antispasmodics, right? And for the lifestyle modification, you can advise the patient to avoid the hot and the cold meal should be avoided to prevent the stimulation of the contraction. This is the term which I was mentioning apart from the achalasia cardia. This is the hypertensive lower esophageal sphincter, also called as the esophageogastric junction outlet obstruction. Differs from achalasia by the evidence of effective peristalsis. So if there is an effective peristalsis with the raised IRP, then it is the hypertensive lower esophageal sphincter, present with the dysphagia, chest pain, heartburn, and sometimes regurgitation. It is diagnosed by the manometry. Esophagogram shows delayed emptying and the narrowing of the G junction, and treatment is with the endoscopic dilatation and the surgical intervention. Surgical intervention is the second line of treatment for this type of patient. Now we come to the more common presentation which patient come to us in surgical OPD is the achalasia. Usually incidence of the 6 in 100,000. Pathogenesis can be the idiopathic or infectious, neurogenic degeneration, and it can be triggered by the stress, weight reduction, and associated Chagas disease. Most accepted theory is the destruction of the nerves to the lower esophageal sphincter, resulting in the hypertension of the LES and failure to LES to relax. That is the basic pathophysiology for the achalasia cardia. So classic triad of presenting symptom is the dysphagia, regurgitation, and the weight loss. And sometimes patients present with the initial symptoms of the dysphagia for the liquid first rather than solids. In other pathologies such as malignancy, there is the, to start with, it is for the solids, but here it can be the first is the for the liquid. In severe cases, aspiration due to the regurgitation can also happen. And remember, it is a pre-malignant condition, so it need to be treated, which can lead to the development of squamous cell carcinoma and adenocarcinoma in the middle third of esophagus. And one complication is the sigmoid esophagus is also been presented in the late presentation of the achalasia cardia. So this is the classical picture of the bird beak appearance here on the contrast swallow, and here you can see there is a dilated tortuous esophagus, a form of the sigmoid esophagus is there. So diagnosis is made by the one is your esophagogram, that is the contrast study, and the motility study. Lack of gastric air bubble is also a common finding. Manometry is the gold standard. Endoscopy should be done in all suspected cases of achalasia to rule out any secondary cause of the lower esophageal narrowing. And sometimes CA esophagus can mimic like a achalasia cardia. So that you have to differentiate by doing the upper GI endoscopy. Non-surgical treatment include medications, endoscopic dilatation for the short-term relief. In a surgical is the modified Haller's myotomy with the esophagectomy, and second is the esophagectomy in case of the megaesophagus or suspected malignancy. POEM is the endoscopic intervention which is being now recently has been taking popularity. POEM is the another option, but classically your Haller's myotomy is there, which can be done either by open, but that was done in the past. Now the laparoscopic Haller's myotomy is the standard of care. Diverticular disorders. Diverticular disorders include one of the more common is the Jankus diverticulum. It is seen in the Callien's triangle, usually seen in the old age. It is the false diverticulum, and it is the pulsion diverticula. Diagnosis is done by the barium esophagogram, and diverticula is seen in the posterior aspect, right? So this is the so this is the diverticula here. Another is the mid esophageal diverticulum. Okay, mid esophageal diverticulum. It is usually seen in the thoracic pathology, usually because of the traction diverticula. It is a type of the traction diverticula because secondary to the pulmonary disease. And manometry is advised to rule out any primary motility disorder, and primary treatment is the treatment of the underlying cause. If diverticula is more than 2 centimeter, diverticulopexy or the diverticulectomy can be done. In Jankus diverticula, there are the option of the endoscopic treatment and the surgical treatment. In endoscopic, surgical treatment is by the stapler technique or by the open technique, right? In open technique, the diverticulectomy is being done. In endoscopy, Dolman procedure is being performed, in which the septum between the wall of the esophagus and the diverticula has been divided, so that there is a wide mouth of the diverticula, so that there is not pooling of the food particle there. Another is the epiphrenic diverticulum, found adjacent to diaphragm in distal third of the esophagus within the 10 centimeter of G junction. It is called as the epiphrenic diverticula, and more common on the right side. Mid esophageal diverticula is also seen more commonly towards the right side. Associated with the motility disorder like diffuse esophageal spasm, eclasia or hypertensive ileus, and can also be the congenital. Can we continue further?
Exceeded the time. Just
Okay.
summarize and we can close.
We should sum. Okay, fine. Another is, I will take another 2 minutes with your kind permission. Thank you. Gastroesophageal reflux disease, most common benign condition, right? It is of a two type: acute, secondary to the alcohol, burns or the stress, and chronic. It is usually associated with the hiatus hernia. So long term complications include strictures, ulcers, metaplasia, dysplasia, carcinoma, and the pulmonary disease. Remember, this is the most common benign esophageal disorder, and it is usually, to start with, it is a lifestyle disease. So standard diagnostic modality include the pH testing done by the pH manometry, 24-hour monitoring, and score more than 14.7, Demister scoring of more than 14.7 diagnosed as a GRD and require the treatment. Esophageal manometry, video esophagogram, and upper GI endoscopy with the biopsy in a suspected cases. Hill's classification, you as a postgraduate you should know when you get a report from the endoscopist. So what to do in that? There are the 4 grades: grade 1, 2, 3 and 4. So grade 1 and 2 are basically considered as a normal, in which usually no surgical intervention is required, but grade 3 and grade 4 required the treatment. Okay, so grade 3 is the reflex, in which you may have a treatment for the GRD, but if it is grade 4, it is usually associated with the hiatus hernia. So not only for the this reflex procedure, anti-reflex procedure you have to do, but you have to also consider the treatment of the hiatus hernia also. Do the Colles gastroplasty, and you lengthen the abdominal esophagus by dividing the at the angle of his, and then you wrap it. That is called as the Colles gastroplasty. That is the another option for the short length esophagus. Right? Another is the Lynx, which is the magnetic endoscopy. Okay, so I will summarize it. Hiatus hernia is another acquired disorder. The Plummer-Vinson syndrome, Setesky ring, esophageal perforation is one of the more common presentation that you encounter in your emergency setting. Here is the score here, Pittsburgh esophageal perforation severity score, that you should consider, and you can note it here. If score is more than 5, then your mortality increase significantly. So I am not going into detail of this corrosive injury, tracheoesophageal fistula, that is the congenital, that must have been taught yesterday by the pediatric surgeon. And then neoplasm, usually it is by the cell type, epithelial and non-epithelial. Non-epithelial is more common in form of the leiomyoma, right? So these are the few benign esophageal neoplasm which are should be taken into consideration by treating the benign disorders. Thank you very much. Thank you.
So Dr. Pankaj will circulate your PDF in the group so that residents can read these
Sure.
slides. Yeah.
Thank you.
Thank you.
Sure.
Sir, I would like to call Dr. Ajay Kumar Pal sir to felicitate sir for his talk.
After these extensive lectures, we disperse 5 minutes for coffee break, and I request you all to please get back in 5 minutes. Thank you. So request some of you to please go and visit the stall. The press nobody's go.
Welcome back, everyone. Our next talk is on the topic chronic pancreatitis. May I invite H. Nag sir to kindly address the gathering. He is professor in the Department of GI Surgery at GB Pant Hospital, New Delhi.
ये ऐसे ही रहेगा, कैसे रहेगा? हाँ? Morning everybody. Thanks a lot to Professor Abhinav for the invitation and his team also. Chronic pancreatitis, I'll speak about only surgeon's perspective in brief. क्या है ये? अच्छा next हो जाएगा. Chronic pancreatitis pathophysiology is multifactorial. It is chronic progressive inflammation leading to irreversible changes to the pancreas. It causes acinar loss, fibrosis, it causes ductal obstruction, intraductal or parenchymal stone formation and neural changes also. So therefore, plain etiology distinct mechanism is also multifactorial. It may be due to ductal hypertension caused by ductal obstruction by the stones or stricture or stone and stricture both. Pain may arise due to nociceptive stimuli going to nerve fiber intraparenchymally located or peripancreatic location in the pancreas, and there may be related ischemia and central sensitization also occur in some patients with chronic pancreatitis. That may also plays role in the origin of pain, and head of pancreas act as a pacemaker of the disease. Etiology is multifactorial. You remember it by TIGAR-O. Toxic means toxic metabolic. Alcohol is the most common. Then tobacco, drugs, hypercalcemia, hypertriglyceridemia, etc. Other is idiopathic, genetic, autoimmune. Recurrent acute pancreatitis in some patients can also cause chronic pancreatitis, and obstructive causes like pancreas division tumors sometimes cause the chronic pancreatitis. Clinical feature, most common feature is the recurrent epigastric pain, usually radiating to back, and it may relieved by the postural changes. As it is a destructive disease, it causes exocrine insufficiency and presents with the steatorrhea, weight loss and other features of malnutrition. Endocrine insufficiency, because islet cell also located in the pancreas, so it leads to diabetes mellitus, and depending upon the chronicity and the severity and control of the diabetes, other diabetes mellitus related problems can also be there. It may also cause gastric outlet obstruction due to the large head mass of the pancreas, or due to scarring of the duodenum, or both. It may cause stricture formation, and pressure of the head mass can also result in the diagnosis. It may cause splenic vein and portal vein thrombosis and leads to portal hypertension and bleeding. Some cases may develop malignancy in long run, as it is a multifold increased risk for the development of malignancy. Investigation, usually blood investigation are of no use for the diagnosis of chronic pancreatitis. Ultrasound is also not much useful, because pancreas is retroperitoneally located, and there are so many factors that can obscure hinder the visualization of pancreas and pancreatic pathology. However, if observer is experienced and patient is thin, you may see calcification, ductal changes and other changes of the chronic pancreatitis on ultrasound. Diagnostic investigation is contrast enhanced CT, that will show atrophy, calcification, ductal changes and other changes, may be malignancy and pancreatic mass in the region of cyst formation, other complication related to the pancreatitis. MRCP usually used for the ductal anatomy. stricture and stone formation if needed, and it's complementary. You cannot replace CT, MRCP for the this thing. Usually CT will be required in our patient, because as a surgeon we are more comfortable with the CT, reading CT and planning surgery for with the CT. PET CT is the optional in cases with the suspected malignancy. If it is advanced malignancy suspected, you have to do PET CT also. Endoscopic ultrasound, usually intervention role when we are suspecting malignancy and we need tissue sampling. So we do final aspiration through the endoscopic ultrasound. Once we have diagnosed, then patient who are requiring a treatment, first line is usually medical management, and that is usually analgesic ladder which is proposed by the WHO is followed. You start with the non-opioid, then mild opioid, then strong opioids, and that can be supplemented with the enzymes. And you have to try to control the causative factor. Alcohol intake should be stopped, stopping should be stopped. Patient who fail to medical management, or patient who have non-dilated duct, single stricture in the MPD, dominant stricture in the MPD, or single or multiple stone blocking the MPD, or there may be stricture and stone both in the MPD. These cases are a candidate for endoscopic therapy, where you remove the stone, dilate the stricture and put on the stent. Some cases you may use ESWR for breaking the stone, and as of some studies by Rosenthal and other studies, response rate to the pain is 65%, and 25 to 50% may require surgery in 1 year or 2 years. Poor long-term outcome is also reported in some studies, and evidence is arising like early surgery is beneficial in patients with the chronic pancreatitis. So now what are the indications for surgery? Most common is intractable pain, around 80% patient this thing present with the pain, severe pain, and that is not relieved with the medical and endoscopic management. So that is the most common cause for the surgery or indication for the surgery. Other may be complication, bile duct stenosis, complications like gastric outlet obstruction, suspicion of malignancy, pseudosis. Some cases may present with the emergency like a bleeding, upper GI bleeding, and that may require surgery. Surgical procedures are divided into 3 groups. One is resectional, second is decompression, and third is hybrid. Resectional, 2-3 procedures. One is if it is disease localized in the head region, we will do pancreaticoduodenectomy. That may be classical or that may be Whipple's. That may be pylorus preserving. Other is the Beggar's procedure. Beggar's procedure is just resection of the head of the pancreas, and you leave the duodenum with the some parenchyma around the C loop, and then disease located in the distal part of the pancreas, body and tail, you do distal pancreatectomy, or in some cases involving whole body of the distinct pancreas, you may need to do total pancreatectomy. That is rare this thing, it is usually not practiced clinically. Decompression, you decompress the pancreatic duct, remove stone and do the side to side anastomosis between the pancreas and the jejunum, root loop of the jejunum. Most common procedure is the parting tongue, Rousseau procedure, or modified Pistos procedure. And then hybrid, you limit the resection. Head region resection is limited to the coring of the head of parenchyma of the head, and with the LPJ or lateral or longitudinal pancreaticogynostomy. Other modification is band modification, where you just resect the head and that is not dilated, though no then LPJ is performed in that. Then what is the surgical algorithm? You look for 2-3 things. One is duct size, dilated duct or not. Second is if there is head mass or not. What is the region involved? Is there any malignancy, suspicion of malignancy is there or not? Lateral or longitudinal pancreaticogynostomy is done in patient with dilated PD, usually more than 7 mm, there is no head mass, and so you open the duct on the course of duct, then you do side to side pancreaticogynostomy
It preserves parenchyma and preserves the pancreatic function. It relieves pain in 50 to 90%. Relapse rate may be 30%, 40% according to some studies after in long term. Phrase procedure, everything is same. You do head coring also. Sorry. You core the head here, remove the parenchyma, usually at the level of duct, up to the level of duct, and you do the pancreatico-jejunal anastomosis, and pain relief is equivalent to the relaxational procedure like Beggar's procedure or this thing pills, and morbidity is less in this space. This is also called as modified duodenal preserving pancreatic head resection, this procedure. Beggar's is same like phrase, but here duct is not dilated, LPJ part is missing. You just core the head and do the anastomosis with the cored head. Whipples, you all know, if there is suspicion of malignancy and it is localized to the head region, these patients will have short history, significant weight loss. Any patient with chronic pancreatitis presenting with the recent onset change in the pain or recent onset jaundice, recent onset diabetes, and patient who have got head mass and significantly raised CA99 other tumor marker, there may be atypical finding like hypoenhancing mass in the head region, double duct sign, vascular encasement. These are the signs that indicate there is malignancy may be there, then you have to opt for the Whipple's procedure. Distal pancreatomy, this is limited to the distal part, body and tail of the region. Then you have to do distal pancreatomy. For the total pancreatomy, indications are very limited, and usually if it is done in the patient centers where islet cell transplantation is available. Now I am coming to the complication. First complication is bile duct obstruction that may result from due to the head mass or due to the stricture formation. If it is due to the head mass, then Fraisse procedure should be adequate. In cases where head mass is there, but duct is not dilated, you have to do Beggar's procedure. If there is suspicion of malignancy, you have to do Whipple's. If there is stricture is long, it will not be relieved by only resecting the head region of coring of the head. Then either you have to choose Whipple's operation or you have to do hepatico-jejunostomy along with the or without the pancreatic procedure. So HJ alone will be done in patients where pain is minimal, no head mass, no ductal dilatation, and no suspicion of malignancy. Another is duodenal obstruction. If it is by head mass, you relieve the head, core the head, it will be relieved. You do either Fraisse or Beggar's. If there is suspicion of malignancy, you have to do Whipple's operation. And if significant duodenal scarring is there, then you have to combine GJ with the other procedures. Additional procedure required with the GJ. GJ alone will be sufficient in patient with no pain, no head mass, and MPD is not dilated. GJ with Fraisse and Beggar will be required pain with gastric outlet obstruction, head mass and scarring, and MPD is dilated. WPT is required wherever there is suspicion for the malignancy, you have to do resectional procedure, either WPT in tail and body, you have to do other procedures. Some patient may have sinistral portal hypertension or left-sided portal hypertension that result chronic inflammation in the region of pancreas lead to thrombosis of the splenic vein, and that result in the isolated gastric varices, splenomegaly, hypersplenism, but LFT will be normal in patient. If you take pressure in the portal vein, main portal vein, it will be normal. So surgery will be indicated. All patients who had symptomatic hypersplenism, and if they are symptomatic for the pancreatic disease also, then pancreatic procedure will be combined with the splenectomy. And anyway, if you are going for surgery in patient with pancreatitis, if splenic vein thrombosis is there, you have to combine splenectomy also. Other patients are chronic pancreatitis with generalized portal hypertension due to portal vein thrombosis, compression by inflammatory mass to the portal vein. non-cirrhotic portal hypertension or chronic liver disease. Surgical option, basically major surgeries are this thing restricted in these group of patients because it is technically difficult, bleeding risk is high, and patient with CLD may decompensate also. So, avoid major pancreatic dissections. Bypass procedures are preferred like gastrojejunoscopy. Shunt is usually not indicated except in patient with the this thing EHPVO. WPD only should be done if malignancy is suspected and you are planning portal vein dissection if needed. Pseudocyst, same. Pseudocyst can be drained along with the this thing duct drainage. You can combine, same loop can be used to drain the cystic duct. If pseudocyst is communicating with the PD, then it will be drained by the this thing will be treated by the drainage of the MPD, and some cases resectional surgery is required. This is a case presented with a 25-year-old lady presented with the pain for 2 years and exocrine insufficiency, weight loss, examination, blood examination, ultrasound was normal, showing this thing pancreatic duct, dilated pancreatic duct on the this thing MRCP, same finding is confirmed on the CT that was done at our place, and then we did the pancreaticojejunoscopy in this patient. Another this thing case is chronic calcific pancreatitis with 55-year-old lady with pain, weight loss, exocrine insufficiency and endocrine insufficiency. There is the large head mass in this region with the dilated pancreatic duct. So, this is a classical case, there is no suspicion of the malignancy. So, this is a classical case for the fresh procedure. You put ports like this, then approached lesser sac through the gastrocolic omentum. You lyse the adhesion, expose the, this is the adhesion, these are the adhesion between the this thing stomach, duodenum region, this thing pylorus region, that is these are being released by ligature. Now we are using harmonic. This is the lower end or inferior border of the pancreas. You have to expose the pancreas well, then you have to divide gastroepiploic vein because it will be almost in the way of your course of opening when you are opening the pancreas to open the duct. This is the lower border that is marked by, this is the this thing middle colic vessel area, and now you open the duct, then extend that on the either side. On the head side usually up to the around 1 centimeter or 1.5 centimeter from the this thing duodenum. In the tail side also same. Sometimes it bleeds from the gastroduodenal artery or branches, and you can secure it by suture ligation and then complete the duct opening. It is again bleeding. If you are inexperienced in early part, if you are doing opting for the this thing trying laparoscopic LPJ, then you should either call for help or you open and do it. As you gain experience, you will be able to do with the everything on the laparoscopic this thing. Now it is controlled. We are taking one more extra suture. It's okay. It's last. Thank you. You can continue. You can see the this thing. You can continue.
Thank you, sir. That was a wonderful talk. Any questions from the audience?
Yeah.
Or localizing the duct at times becomes difficult. Are there any tips for that?
Actually, 2-3 tips. Most best is the in open. We do needle aspiration or ultrasound guidance. I am not this thing comfortable. I don't know how to do endoscopic ultrasound or ultrasound. So I usually do I open duct. Usually duct will be located more close to the superior border. So I'll expose the pancreas. I'll locate anatomical landmark like where the hepatic artery is there at the superior border, then where complete superior border is there. Then I localize inferior border of the pancreas. Then I localize the gastrocolic distinct joining area where the middle colic vessels are. Then more close, I think from the inferior border will be between 2/3 from the and 1/3 junction. Along the course of duct, I will try to across the duct, I will try to use diathermy or harmonic to open the duct. So some way usually it will open and pancreatic juice will come, and then I will go through the Maryland and dissect out and open on one side. But it is difficult sometimes. Sometimes you have to identify a major stone lying there in the duct. You focus that area and open. But ideally, you should use endoscopic ultrasound, and you should learn endoscopic ultrasound these days to do the major laparoscopic GI surgeries.
Because at times the difficulty in this process that if it is studded with the stones and there is calcific pancreatitis also, then it is very difficult to tell it, or even on the basis of palpation.
That's fine. You basically, if you are starting any laparoscopy, my suggestion is you keep a very low threshold for the conversion, and as you gain experience, you start persisting more, then you will gain more. But initially, our conversion rate for most of the distinct laparoscopic liver resection and LPG, it was around 30%. Now it is, I think it is less than 10%. It's still around 10% is there. I still, because we are training institute, so we keep a standard accordingly. We have to train resident also. Whatever we are doing, resident will also do the same. So better to keep safer for the patient.
I think laparoscopic ultrasound could be of help, some
Yes.
help also, if you have access to that.
That's good. This thing.
Thank you, sir.
Sir.
Good morning, sir. So you mentioned about sinistral portal hypertension.
Yeah.
Sir, for example, if a patient comes with recurrent upper GI bleed, hematemesis, and the cause is sinistral portal hypertension, which is a splenic vein thrombosis, which may be secondary to recurrent acute pancreatitis, is the management, will the management for this, the surgical management for this would be splenectomy or distal pancreatectomy plus splenectomy?
If a patient comes to emergency, it has got upper GI bleeding, the first thing is to resuscitate the bleeding, then take patient to endoscopy room and do the endoscopy and localize the bleeding, source of bleeding, control that. Then you evaluate cause for that. Bleeding may be due to the ulcer, bleeding may do if due to the varices. If it is due to the varices, then you have to look, you know it is portal hypertension. Then you know what is the cause of portal hypertension. It is left sided or right sided. Then you have to do ultrasound and Doppler. Mainly you will know how is the liver parenchyma, portal vein is patent or not. If it is not patent, replaced by, you know it is the extrahepatic portal vein obstruction. If splenic vein patent, superior mesenteric vein patent, and superior mesenteric and portal vein is patent, but splenic vein is blocked, then it is due to the splenic vein thrombosis. So because whole portal system is intact, only that person lies with the spleen or draining pancreas and the stomach, greater curvature of the stomach, basically cardiac fundus and all. That's why it is called sinister or left-sided portal hypertension. Major, it will cause bleeding, but it will not have any other complication related to the portal hypertension. If major causes are present, generalized portal hypertension are present, then patient management will be only just to minimum surgery as required to the symptomatic treatment of the patient.
Thank you, sir.
Thank you, sir. I would like to call Professor Jitendra Kushwaha, sir, on the stage for felicitation. Thank you, sir. Thank you, sir. Our next talk is on the topic Fistula in Ano by Professor Arshad Ahmed, sir. former professor at Department of General Surgery in KGMU.
And please ask questions also. The speakers want that you should ask them questions, not only Akash, but you can also. It may sound foolish to you, but please do ask questions. Or the speakers will start asking the question. I would request them to ask questions, or tell them what should be asked, or tell them what should be asked.
So good afternoon, everybody. First of all, I am thankful to Dr. Abhinav Sonkar, all my colleagues, Dr. Geetika, for giving me this opportunity to visit my department again and again. So it's really a very special feeling for me to come to this place where I have spent so much time with residents, with faculty, with students. That is my passion, and teaching and training, and we are still continuing. Moving out does not mean we have moved out of the hearts of faculty and department. I'm still there. And anal fistula is a topic. Sometimes this problem is actually very diverse. Anal fistula is a very diverse disease. Sometimes we get cases which are very simple, extremely simple. The treatment is a straightforward fistulotomy, 5 minutes, and sometimes there are cases which are very difficult. And despite several surgical endeavors, these patients are not cured, and these patients are running from one place to another place, and recurrences and bad disease, and sometimes it is made even worse after the treatment. So I'll not go in very long videos and all. I'll just tell you, because this is for PGs, so I will stick to the basics and tell you the simple approach. So anal fistula, basically most of them are primary. More than 95% are primary, and secondary are because of Crohn's, tuberculosis, or sometimes malignancy, sometimes post-traumatic, but most of them are primary fistulas. And primary fistulas have a they are cryptoglandular in origin. Cryptoglandular, I'll show you what. And some fistulas, anal fistulas, can have involvement of vagina, involvement of bladder, urethra, involvement of coccyx. So we call them as multi-system involvement fistula. So देखो भैया क्या हो रहा है, ज़्यादा प्रॉब्लम होती है लगा दीजिएगा, पॉइंटर है इसमें, फिर जा रहा है. Okay, so I told you that primary fistulas, नीचे वाले में लगाइएगा, इस वाले में, इधर वाले में, ऊपर वाले में नहीं लगेगा, इस वाले में. ये पॉइंटर काम करो. So this is the crypt here, this is the anal gland. So cryptoglandular infection means from the crypt, which is an opening, the infection goes to the anal gland, and this infection in the intersphincteric plane is actually responsible for, this is the initial event, and from there infection spreads to into various directions and leading to different types of fistula. That is why the primary fistulas are cryptoglandular in origin, and the secondary fistulas, as we discussed, can be because of tuberculosis, because of Crohn's, which is so simple and complex. This is a practical classification. Approximately 2/3 of anal fistula are simple and 1/3 are complex. So simple basically are those where sphincter involvement is less, only the lower part of the sphincter, that is the subcutaneous and superficial part, or rather you can say less than 50% of the sphincter is involved, we call them as simple fistula. Why? Because cutting that part of sphincter will not lead to incontinence. If you are, the aim of treatment in fistula is basically to cure the fistula, at the same time not to compromise the continence. So in that case, those fistulas which are involving only the smaller part of a sphincter, that is less than 50% of the sphincter, they are considered to be simple fistula, because you can cut that part of the sphincter, remove the fistula, and patient will not be incontinent. But if more than 50% of the sphincter is involved, then definitely if you are removing the fistula, in order to remove the fistula you have to cut the sphincter, then this can lead to various issues with continence. That is why they are considered to be complex fistula. इससे change हो जाती slide. So these are the various factors which are leading to complexity of fistula. First of all, this is a disease which basically spreads in various directions, in various planes, and there are three dimensions of the spread of disease. One, primarily this disease starts in the intersphincteric plane, and within the intersphincteric plane it can go in a craniocaudal direction or in a horizontal or transverse direction in horseshoe manner. So you can have a craniocaudal spread, it can lead to high intersphincteric space, it can lead to suprasphincteric space, because around the anal canal there are so many potential spaces and these spaces are interconnected, and the critical for fistula is intersphincteric space, because it starts in the intersphincteric space, it can grow within the intersphincteric space in a craniocaudal direction or in a transverse direction, and then it can also go to extrasphincteric place. Extrasphincteric place means it can cross the external sphincter and go to lateral gluteal region, go up to thigh, go up to intergluteal cleft area. So in the extrasphincteric region it can go to far off places, and you can find distal external openings as far as up to distal thigh or in the back. Then within the intersphincteric plane it can go cranially up to space of Ritzius, that is the retropubic space, and from there it can spread extraperitoneally to flank and abdominal wall. So these are the various ways in which this disease can spread in various directions. And the other part which can add to complexity is either not being able to find the internal opening, because internal opening is in a fistula is the place from where infection entered the intersphincteric plane. So it is critical in planning management to find the internal opening. So sometimes it is there but it is not found, and sometimes we get a high internal opening, which is either because of secondary fistula or it is iatrogenically created. So, and then as we said, other factors like Crohn's, tuberculosis or multi-system involvement can also make the situation more complex. So these are the various factors which lead to the complexity of disease. Goodsall's rules all of you have read in your textbooks, so we will not go to that part. It is not very accurate. Somebody to help with the, ये चला गया इसका फिर से प्रॉब्लम हो रही तो आप पेन ड्राइव से लगा दो ना, उसी में बार बार वो जा रहा है आ रहा है. चलो आ गया, आपकी जाएगा तो लगा देना. Now this is one of the classifications which is being most widely practiced, Parkes classification, which classifies fistulas into four basic categories, four broad categories: intersphincteric, transsphincteric, suprasphincteric and extrasphincteric. And then there are sub classifications. All these basic subclasses have their subclasses, because fistula is a very diverse disease. We get 50 patients of fistula, and each patient has a different type of fistula. So as I said, it's a very diverse disease. क्यों बात इसको निकाल लो जब चल रहा है तो, हाँ? कनेक्टर चेंज करने से ठीक हो जाएगा. Then you can see here that this is a intersphincteric fistula. It can be low, it can be high. This is a transsphincteric fistula. It can be low, it can be high. This is a suprasphincteric fistula, extrasphincteric fistula. So you can see that these are the four basic types, but there are multiple subtypes within these classes. But there is a deficiency in this classification also, because sometimes this is a stage 2 or type 2 fistula. This is a simple, but the type 1 fistula which is going up can be a complex. So the classification does not translate into complexity of disease, and planning of management does not totally dependent on grading of the fistula. So you have to consider so many other factors. There is another classification which is called as St. James University classification, and this is used by the radiologist. You send the patient for MRI and they write in MRI this is St. James class 4, St. James class 3, and this is simply extrapolated from the Parkes classification, so same as Parkes classification. Now in this picture I have tried to show you that what is the difference between a simple and a complex fistula. This is the sphincter complex, this is the inside of anal canal, this is the outside. Though this is internal sphincter, external sphincter. Same here you say this is inside, this is outside, and this is the MR picture. Now this is the pelvic floor area, this is the pelvic floor, puborectalis, deep part of external sphincter, this is pelvic floor. So this is the vertical height of sphincter complex. If less than 50% of the sphincter complex is involved, if fistula involves only lower part of a sphincter, then this is a simple fistula, because you can cut this part of a sphincter without repairing it. There is no need to repair it back. It will not lead to any incontinence. But if you cut this part of a sphincter, then either you need to repair it or either you don't cut it at all. Try to do a sphincter preserving surgery. So that is why any fistula which is violating this part of muscle is considered to be a complex one, and those which are violating only the lower part of muscle, that is the lower half or subcutaneous or superficial part of external sphincter, they are considered to be simple anal fistula. Now when a patient comes to you, how do you assess that what is the diagnosis and whether patient is having a simple fistula or a complex fistula? So you have three opportunities for assessment. First, in the OPD, when the patient presents himself to you in the OPD, you examine the patient. Then second is you can go for imaging. Imaging is not always required, but sometimes you may go for imaging. Some patients selectively you go for imaging. And then finally, when you operate the patient and patient is in anesthesia, maybe in saddle block, maybe in GA, and again you examine. So these are the opportunities where you try to know about the disease. First of all, when the patient comes in OPD, examination is very important, and because all the patients will have a very similar history, that there was an abscess ruptured, then there was discharge. Sometimes patient will come after recurrent surgeries. So when a patient comes after surgeries and he has a recurrent disease, always consider it to be a complex one. Don't think he was operated by a fool. Always think the disease was more challenging, more difficult. That is why patient had a recurrence, not because the surgeon was a fool. So perineal examination you do in all these cases, and in perineal examination sometimes you are able to pick up the cases which are very simple. You know that this is a very simple case, no need for further imaging or further evaluation, straight away I can post the patient to OT. So what you see is, if there is an external opening very close to anal canal, it means it is an intersphincteric fistula, because the external opening lies over the intersphincteric groove. So you identify the anal verge, which is here, the junction of hairy and non-hairy zone, and if the external opening is within 1.5 centimeter of anal verge, it is an intersphincteric fistula. If it is beyond 1.5 centimeters, suppose 3-4 centimeters or more, it is not an intersphincteric fistula. Then you see that from external opening up to anal verge, if you are able to feel a cord-like structure, it means it is a low transsphincteric fistula. So you identify intersphincteric fistula and a low transsphincteric fistula, they will not require MRI, straight away for surgery, rest all cases go for MRI. So this is how you take a decision in OPD, that whether I will do MRI, subject this patient for further evaluation or not. Low intersphincteric, and then you also put a finger inside and you can feel the whole disease within 2 fingers, one inside, one outside. So low transsphincteric, low intersphincteric, no need for MRI. If you want to do for academic reasons, the insurance people want it, the patient himself want it, go for MRI, otherwise you can omit MRI, go for straight away surgery. So digital examination, as I said, important. So in imaging, what imaging? Today MRI is gold standard as of now. I think I will get few extra minutes because of those lapses in the technical lapses. Okay. So X-ray fistulography is obsolete because it doesn't tell you anything about the relation of the disease with the sphincter complex, because that is what you want to know. So X-ray is obsolete. It will only tell whether the dye is passing into rectum or not. That is the only thing X-ray can tell you. So it's completely obsolete. Endoanal ultrasound, it has its limitations because it is operator dependent, and ultrasound sensitivity reduces as the disease goes away from the surface. So a disease which is close to perineum, close to mucosa, is picked up well by ultrasound, which is transperineal or transrectal. But disease which is deeper or in the supralevator areas or deeper away from the mucosa, it will be less, ultrasound will have less sensitivity. So you can see MR as of now is most sensitive, it gives you most accurate mapping of the disease as of now. So this is gold standard. So this is X-ray and ultrasound. So in MRI basically we go for 3 views. The MR section which is used today for fistula is called as stir image or T2 fat suppressed. So you have T1 images which are good for normal anatomy, but this is a T2 fat suppressed, because simple T2 will have disease bright, that is fluid bright as well as fat bright. So you suppress the fat and the disease stands out bright here and the fat is suppressed. So T2 fat suppressed images. So you have to order that MRI perineum or MRI perineum fistula protocol or a stir image, that is a T2 fat suppressed image. And here you have to see 3 views. One is axial, that will tell you about the transverse extent of disease. Transverse means this is the internal sphincter, you can see very clearly, this is the external sphincter. So you can see this is the intrasphincteric component of disease going in a horseshoe manner, and from here it is going to extrasphincteric disease. So this is outside sphincter, this is inside sphincter. So it's a transsphincteric horseshoe fistula. Horseshoe why? Because you can see this is going on both sides. So it is going within the intersphincteric space on both sides, then on laterally on both sides it is going transsphincterically to extrasphincteric plane. So it's a horseshoe transsphincteric fistula, but that is one view. The second view is a sagittal view, and the sagittal view will tell you that whether the anterior and posterior extents of disease. You can see this is the posterior intersphincteric space, and if you draw a line from tip of coccyx to anus, this will be anococcygeal raphe, superficial postrenal space, deep postrenal space, supralevator space. So you can see the you have to make a 3-dimensional picture of the disease in your mind, and that you can make only when you see the 3 and this is a coronal view, most important, because this will tell you the vertical extent of disease. This is the pelvic floor, here the puborectalis, and this is the anal verge. So this vertical line tells you that this is the sphincter length, and you have to see the relation of this disease with the sphincter. It is only in the lower part, it is simple, like in this patient it is in the upper part, so it is complex because it is involving the upper part of the sphincter. Now this is the basic MRI which is done in most of the cases, just 2-3 more minutes because that time was lost. So additional workup is required not in all patients, but in those patients where you are suspecting that there could be some other cause behind this fistula, like tuberculosis, like Crohn's disease. So in those patients you may go for additional workup, and that additional workup may involve a full colonoscopy including distal ileum, because in Crohn's disease there are ulcers in distal ileum, fecal calprotectin which is raised in IBD of course, and in order to rule out tuberculosis, if you are suspecting a CB naught or AFB of pus. Patients who have a recurrent disease with a compromised continence go for anal manometry to document continence, because the patient is already incontinent, you operate, that incontinence which was created earlier will also go in your account. So you need to mention that, you need to document it. In suspected urethral involvement, many patients with perineal fistulas, I sometimes discuss with Dr. Pava also, and he suggests me what to do. Cystoscopy, MCU are due to rule out urethral involvement, because fistula is a disease which can sometimes involve the surrounding. I told you that urethral involvement is not so rare, and sometimes the disease can go to abdominal wall, flank area, then you need to do a CT abdomen to rule out any pelvic involvement. So examination under anesthesia, basically you dye, inject dye, you do a fistuloscopy with a waft, and you just map out the disease completely. Treatment as far as concerned is essentially surgical. There is no role of medical treatment. Medical treatment is only as an adjunct, particularly or specifically when the patient comes with an abscess and cellulitis, you can give antibiotics. But in Crohn's fistulas and tubercular fistulas, there is role of medical treatment, there is role of anti-tubercular therapy and biological treatment for Crohn's, but otherwise in primary fistulas, medical treatment has a very limited role. Now surgery, what is surgery? One type of surgery is called as fistulectomy, where you remove the disease. Definitely in case of disease, if you are removing the disease entirely, then it will offer the patient maximum chance of cure. But in fistula, when you will go, because you are still a student, tomorrow when you will start seeing proctology cases, you will find that as we said, the disease is very diverse, the treatment providers are of different types, and their treatment modalities are of different types. More than 100 treatment modalities are available But broadly speaking, you should just 2 more slides, sir. Broadly speaking, you should know that first of all, for simple fistula, fistulotomy or fistulectomy is the gold standard. There is no doubt about that. All the practice parameters, a strong recommendation. For complex, you can either go for a fistulectomy. If you do a fistulectomy for a complex fistula, cutting more than 50% sphincter, repair it. That is called as fistulectomy with primary sphincter reconstruction. And the other way is without cutting the sphincter, try to treat them. Right? So do a sphincter preserving surgery, and sphincter preserving procedures are many. They keep on evolving and evolving and evolving. These are many techniques with strong and weak recommendation and the level of evidence there. This is the last slide, that if you are not doing a fistulectomy, one treatment I said fistulectomy. In fistulectomy, you remove the disease from inside out. The internal opening, the external opening, that one tract, 2 tracts, whatever the disease is there, you remove it. After removing the disease, either you leave the wound open, allow it to heal by secondary intention, or you repair the sphincters, or maybe sometimes you shorten the wound by partially stitching it. That is one treatment. The other treatment is, we without cutting the sphincters, we try to treat the patient, and this is the gray area because so many options are there. Now this is basically the principle of sphincter preserving surgery. Principle means when you are not removing the disease completely, remove the source of the disease. Remove the place from where disease is growing and spreading into different places, different planes, offshooting to different planes. So remove the hub of disease, and that lies in the intersphincteric plane. So the central disease elimination means you have to remove the disease from the intersphincteric space, and all the offshoots will dry gradually, and you have multiple procedures, lift, sloft, waft, laser, propis, so many options are there. And once you have removed the disease from the intersphincteric space, all the extra sphincteric, because that offshoots from the, maybe it is going to thigh, maybe it is going back, it is going there. So once you have removed the root cause of disease, the rest of the offshoots are going to dry in due course of time. So that was basically an approach in 10-15 minutes. I've spent last 15 years in trying to learn fistula. Still learning, and still I think I need to learn much more. So in 10-15 minutes it is not really possible to sum up the whole thing, but I have tried to give you just, I will not show any video here, not for you. You should just know the approach. So any questions from the audience, I will be happy to answer. Yes, please.
Good afternoon, sir. So you mentioned about Crohn's related fistulas. Sir, is it fair to say that in today's day and age, cutting ceton has no role in the treatment of high fistulas related to Crohn's disease versus draining cetons? Only draining cetons we can use.
See, as far as cutting ceton is concerned, cutting ceton, there is no scientific evidence in any type of fistula to advocate or to support the use of cutting ceton. See, cutting ceton does not preserve continence. So for a simple fistula, why to use a cutting ceton when you can cut it in a simple in 10 minutes? Why to cut it slowly and give pain? In a complex fistula, if you are cutting it, you can repair it at the same time. Cutting ceton will not offer you. So Crohn's fistulas, non-Crohn fistulas, cutting ceton has got no role, first of all. Draining ceton, yes. Draining ceton in 2 situations. One, when the patient comes with a sepsis, abscess is there, cellulitis is there, you want to drain the sepsis, you want to settle, you want the sepsis and inflammation to settle down, and then you want to operate, do definitive surgery for fistula. So during that period you can put a draining ceton. That is one. Secondly, in Crohn's, because the surgery should not be very aggressive, particularly if the fistula is very high, so you can, so that ceton which is for septic cases in presence of inflammation, abscess, that is only for short term. Means after 6 to 8 weeks, when the inflammation settles down, you do a definitive procedure and you remove the draining ceton. But in Crohn's fistulas, where the disease is very simple disease, you can operate, means you can do excision and all. But if the disease is very complex and you do some excisional procedure, then healing is delayed, or because it's a transmural disease, then definitely issues with continence will be there. So in those patients, you can start biological treatment and put a long-term draining ceton and let the biological treatment cure the disease, and ceton is there only for sepsis prevention. So of course draining ceton will be there, but for a long term, but no cutting cetons.
Thank you, sir.
Dr. Ajay, please.
And this lecture is evidence of your mastery.
No, No, sir, I've been learning a lot from you as well.
One question.
Sure.
Do you rule out secondary causes in all types of fistulas, or, and if yes, then what are the clues?
See, as I said that sometimes in OPD, the first thing is to take the history. If the patient is having a recurrent disease means operated multiple times, operated several times, different modalities have failed, then definitely this is a complex case. I will, from history itself, patient has come as a first case, fresh case, then you don't know whether it's a complex or simple case, then you do physical examination. In physical examination, some fistulas are very simple. The external opening you can see, the internal opening you can feel, and or you can also feel the tract. Sometimes there's a chronic fissure, and behind the chronic fissure there's a simple fistula. So these are not the patients where you will subject them. Even MRI can be omitted. Today the practice parameters say that there is selective role of MRI. So in very simple cases, in OPD, you know, it's a very simple case. I can operate, maybe sometimes even in local anesthesia we used to do here, our residents used to do here. So those cases definitely we don't go. Whenever we excise anything, we always send for histopathology. That is a rule. Whenever you remove the fistula tract, but preoperative evaluation, extensive evaluation is not required in those cases. Then cases who are complex cases, which are not very simple, MRI is the basic prerequisite as of now. MRI perineum is something that we will do in all those cases, barring those very simple cases where no MRI is required, all the cases. Then after MRI and disease, extensions of the disease, if on examination we find that there is a opening which is high up, which should not be there. If on MRI we see supralevator, translevator extensions, on openings are multiple, serous discharge, undermining edges. So those involvements, sometimes there are areas, nodularities within the anal canal, sometimes anal stenosis is there in Crohn's disease. So in those cases we go for additional workup, and that additional workup slide I showed you, that depending in which direction we are suspecting tuberculosis, so the best investigation would be an RT-PCR, CB0 or AFB. For if we are suspecting towards IBD, we will go for a full colonoscopy including distal ileum evaluation, fecal calprotectin, and if required CT enterography. So that is how we proceed. If we are suspecting involvement of coccyx, we will do investigations for that. If urological involvement is there, we will involve a urologist in the evaluation. So, and gastrophysician, of course, whenever we are suspecting IBD, we involve a gastrophysician right from the very beginning. So these are the clues, basically clinical findings and imaging, that gives you clues whether you should go for further. And sometimes you are clueless in pre-operative evaluation, and intraoperatively you encounter in situations. Sometimes mucinous adenocarcinoma is found intraoperatively. The appearance looks very much like pre-operatively imaging, looks like abscess. It is intraoperative, you finding that whitish, cheesy, whitish jelly-like material, and you find this could be, and you send it for frozen section, and you find it is malignancy, and you stop for the dissection, and you just tell the patient, now we'll wait for a complete histopathology, and then accordingly we'll send you to oncologist. So at different stages you can always make decisions.
Thank you so much, sir. Fantastic lecture, sir.
Thank you.
Thank you, sir, for simplifying such complex topic for us in short duration. I would like to invite Professor H.S. Pawar, sir, to felicitate, sir. Thank you, sir. Our next talk is on the topic laparoscopic management of CBD stone by Dr. Vikas Singh, professor in the Department of Surgery at RML.
Very good morning to one and all out here, and thanks to Dr. Gitika for having me out here. दो चीजें. You have been sitting since morning. I understand that this is for the postgraduates, but we are looking at the postgraduates with more confidence so that you actually help us in managing the patients, not just the file work, the understanding part of it. I will not be delving more into theoretical part. It is going to be touching down on the practical so that once you are in the operation theaters, you can understand exactly what is going on inside. That is what my topic shall be. Chala do bhaiya. Lap CBD stones management, that is what we are looking at. We all have been seeing laparoscopic cholecystectomies in the OTs, and that is what most of, right from the first year we get to see them. And the only aim out there is removal of the gallbladder. But as a postgraduates, we are being taught that there is something known as critical view of safety, the Rouvier sulcus, R4U line, and multiple other things. What we are not shown at that point of time is to delineate CBD, because that is not required. But jumping from lap chole to lap CBD requires just a bit more of knowledge and your patient's work in terms especially of anatomy and whatever instrument or armamentarium you're using, that part of it. So just for a couple of theory classes, 8 to 15% of the patients with symptomatic gallstones have concomitant CBD stones, and that is well known. So that is what we are looking at on the first ultrasound and the LFT part. If at all there is any type of a previous history of a jaundice or patient has LFOS which is on a higher side, then we go in for one more investigation, that is one MRCP. And that is the clinching part, that decides whether we are going to go in looking for the CBD or we are supposed to focus only on the gallbladder pathology. Because if we do not treat the CBD stones, if at all there are, then that can cause obstructive jaundice, which we know a bit of management also of. Apart from that, the more dreadful complication is the gallstone-induced pancreatitis, because that goes out of our hands at most of the times. भैया जी, अब तो सही है हमारा. हाँ, I was told pen drive में ले लीजिए, तो मैंने मैं pen drive में ले लेता हूँ. And the ascending cholangitis. I told that once those complications start to happen, then we are looking at ICU beds, and that is not under our purview most of the times. भाई साहब, यहाँ से कर लेते हैं. So we all know that at some other point of time, we may or may not have seen open CBD exploration, because that was done as a routine in our times, but nowadays it is less often seen by the residents and being done also by the consultants. Then came our gastroenterologist friends, they came into the picture, some of the surgeons also, and everybody was pushing in for ERCP. That is what everybody was saying, that any CBD stone, let it be handled by our gastroenterologist, abled friend. But what we do not understand is that they were from the medical background and we were from the surgical background. And that's why it came in as a two-stage procedure, that you go in for ERCP within sphincterotomy, and later on, maybe second day or the third day, as soon as you have a OT, you can go in for a completion or a cholecystectomy, lap cholecystectomy. But in that again, we are depending not only for the removal of the stones, we are also expecting that pancreatitis will not ensue in the coming time. That was what was the most important underlying factor. But came the era of laparoscopic surgery and let's say the return of the general surgeon, and with the laparoscope in our hands, we delve into a concomitant management of cholecystectomy with CBD exploration. So that's what I'm batting here for. Because the indications for lap CBD exploration is concomitant stones of gallbladder and CBD stones, failed ERCP, because we are the ones who are going to get it success, 100% success in such cases, and the patient preference. The one line I have not written academically, surgeon's preference as well, depending on the expertise and the surgeon's preference. Surgical techniques, we all know transcystic is also there, but for my personal experience, if you ask me, there are very few limited cases in which we can go in through a transcystic, because what we need is better armamentarium. We need a flexible choledocoscope, a dilated cystic duct, and then to maneuver it, and maybe a Fogarty as well, so that we can remove that slipped stone from the gallbladder into the CBD only, not something which is above the line of the junction where the cystic duct joins, because if at all it is above it, we will not be able to remove it through the transcystic approach. So there are multiple prongs to it before saying the transcystic can also be done. Apart from that, the most common that we all perform is choledochotomy. That is the CBD exploration that we are looking at. During that CBD exploration, I'm jumping to one slide ahead, that what is important is, as was in open, we all have seen, and maybe in MBBS times we had been the instrument viva, the Desjardins forceps and the Beggs dilators. They were being utilized. They are no more being used because less of open, and we do not use the Beggs dilator now. But what is more important out here is, we need to have 100% confirmation under visualization in terms of the choledoco clearance of the stone. That is the must, and that can be achieved by multiple parameters. Intraoperative cholangiography, if you have fluoroscopy with you, yes, definitely you can still do that. Second is endoscopic or laparoscopic ultrasound if you have in your OT, because that is again one more piece of higher end of armamentarium. But what we always go in for is choledocoscopy, and that can be done by multiple things. It can be a flexible choledocoscope, a flexible cystoscope, or a ureteroscope, or a nephroscope also. So rigid or flexible, whatever is available, because unless and until you have that, lap CBD exploration is a big no for that. Clearance rates, I have written 85 to 95, that is as per the literature which says, but it will variate again as per the surgeon's expertise and the patient profile as well. Hospital stays significantly shorter. What I have written is, if you go in for concomitant lap chole with CBD, then the hospital stays shorter in respect of all other modalities of treatment. That is what I am referring out here to. Complications, again, variable. When I say variable, it is dependent on multiple factors, that are you good enough with the armamentarium? Did you have good enough armamentarium? And what did you do during your intraoperative period? Depending on that, the commonest complication which is said to be as bound to happen is mild bile leak in the initial post-operative period. Let's say a couple of days or so, there might be, because watertight meticulous closure may not be achievable at many times. So this is the pictures that you must have seen, the CBD, because in India, this is what we see. Not just one stone, it is studded with stones, and that is what we come across. So this is what we are looking at, the whole of the extrahepatic and intrahepatic biliary system dilated with one or maybe multiple stones coming in. Another picture, you can see multiple filling defects in the CBD, and the CBD is dilated. Out here, point to be noted is that we are supposed to ensure how much is the maximum diameter of the CBD that we'll be talking about. What does that mean? This is the usual picture of the port placement, the normal lap chole ports, 3 or 4 ports, whatever you decide. The point which is important is this epigastric port. If you are placing it in a conventional manner, then this epigastric port might be a bit lower. But because you are planning it beforehand that I am going to use this particular port for lower part of the choledocus to be visualized, that's why this has been placed a bit higher up. And through this, you can easily go in through the CBD in the lower part. This is the tract. That is the reason that is much higher up in the epigastric region. Rest 3 ports are similarly as in lap chole. So we are, in case if this is lower down, maybe you will be needing to have in one more port in alignment with the CBD, but at the highest part in the costal margin. And from there, you can go downwards as well, because this is what I'm looking at. If you notice, in my right hand, I have the rigid nephroscope, and that is going from the epigastric port. And what I'm trying to do, and you can see the camera which is there out here, and this is the nephroscope. going from the epigastric, and I'm trying to see the lower part of the CBD, which is the most important part to be seen, and that has a curvature, so that has to be negotiated very rightly. So your dominant hand must work if you are using a rigid scope. Okay. I will just rush through this. भैया मुझे चला लेने दो. इसमें कर्ज वो दे दीजिए मुझको फॉरवर्ड करने के लिए प्लीज. हाँ बेहतर. Because this is the usual picture that you get across. भाई साहब मैं करूंगा. मुझे फॉरवर्ड करने के लिए चाहिए यहाँ पे कर्सर सर. चला ही गया. Anyway, let the main one run. कोई बात नहीं. Don't worry, I will manage. This is the second case. What was I was going to show in that? The last part of it, that was the putting in a T-tube and the closure. That is what was being shown in that particular image. This is the usual picture that you come across. We have cleared the gallbladder. We have put in the clips, but we do not divide it. That is very, very mandatory. The reason being, we want CBD to be pulled up so that duodenum stops riding on top of it. The supraduodenal part has to be cleared. The point to be ensured out here is, do not try to damage a branch of a gastroduodenal artery which can run at the same point. So it is whatever you are doing, rule number one has to be done under visualization only. That is very, very important. It is very important to know the diameter of the CBD and to delineate, because the reason being, with this monopolar hook or a bipolar or maybe a harmonic or a cold knife, any of the themes can be utilized for placing a choledochotomy in the supraduodenal part, at least 1 centimeter, and it has to be done midway between medial and the lateral border. It is not supposed to be in an oblique fashion or going more towards medial or lateral. Try to be in the midway and starting just from the supraduodenal part, and at least 1 centimeter to begin with, so that you do not struggle. Another one more trick at times, that you need to have a bag inside. Suction in your left hand so that unnecessarily biliary spillage can be minimized. It will be going in, but still it is supposed to be minimized. One more point, if you notice, all the adhesions from the undersurface of the liver of the omentum have to be taken out. The reason being, whatever the stone spillage and the bile spillage happens, that should not engulf lot of omentum. So if you keep your hepatomorisson spout clean, it is going to be easier later on to have a clear area. So this indigenous bag is there, and again, if you notice, what I am using is a bi-action grasper. When I say bi-action, it has a meaning to it. At times we have a habit of using crochet also, but crochet is a univalve and it opens only on one side. But this is something which opens on bilateral side, and it is always easy to go in the middle part of the CBD, dissect the walls or split the walls and catch hold of the stone. But if it is only on one side, then you are going to traumatize more onto one side only. That's why a grasper, and that to a double action grasper, is easier. At this point of time, one more point to be understood is that whatever you are trying to do, your spatial orientation and your haptic feedback is a must, because aim is removal of the stones, but even more further aim is try to do no harm. As Department of General Surgery at KGMU also has non-primum nocere. So that is the first thing which it's supposed to be taken care. So whatever the stones are coming in, 1 centimeter to begin with, you can increase depending on your comfort or depending on the size of the stone which you are trying to remove. So that's why you start with 1 centimeter and then you can increase as per your comfort. So till the time you are doing it, the larger bits of stone, you can use it. Later on, the suction plays a good part in something known as hydrodissection, because these stones are also light-weighted stones. So once you flush it with saline, they start de-logging from their places and they come in the central part. And then it is always easy. Plus, it also helps in washing away of all the concretions, whatever has happened, or the sludge back into the duodenum. This is a tedious process, but this is what must be ensured. And why I'm saying the haptic feedback or the tactile feedback is important, so that once you are going in, do not just catch hold onto the stone and remove. So with an instrument with no ratchet, it is supposed to be held gently and it should come out gently. If it is not, you need to visualize it, that whether it is biting into some of the mucosa of the CBD or not. Once you complete, and if you notice again, without much sideward movement of the CBD walls, your instrument must go inside, so that unnecessarily tractions on the walls should not be made. So that these points are very, very important while you are trying to go in. And if you notice, the CBD is getting taut because of the traction on the gallbladder. So that while doing this, it should not bend down and it make your life difficult. This is from the umbilicus port that we are trying to put in. You can see the stomach out here. So this is from the umbilicus side that the nephroscope is placed, and I'm trying to go in the upper part. So if you give 1 centimeter, the chances of having it filled up with the saline are easy. So this is the upper part. Under good pressure of the saline, you can see the upper part and the confluence, the primary and the secondary confluence, depending on. The only point is that you need to be steady. The other camera must be shown on the CBD and the nephroscope, so that you are not giving a tractional forces while trying to maneuver into the upper part of the CBD. And then from the epigastric port, we try to go lower down. And if you notice, this is the oblique track that I am going in. The reason being, it can all flexible, it can always be straightened out to see the lower end. And this, the check cholecystoscopy has to be done. So what you are seeing is mild mucosal edema, and this is how it looks like. So once you give in multiple suggestions of all the washings, this is how it should look like. It is not mandatory to go through the sphincter of Oddi into the duodenum. At times it is feasible, at times it goes as well, but it is not a mandatory step. Mandatory step is so that you should be able to see the lower end, and beyond that, a black halo can be seen. So that black halo is usually the duodenal part, which gives in a shining. Once you have confirmed under visualization and recorded it that things have been cleared off, then you can close it. Again, the point of contention comes, should we put in a T-tube or an endobiliary stent or do a primary closure? So now the recent advances or the recent literature shows that in most of the cases, if there is no stricture down below, then you can always, and you have visualized the lower end, which does expand on pushing in saline, you can always, and you have cleared off, you can do a primary closure with PDS or with Vicryl. That meticulous closure can be done and a drain placement can be achievable. But in case if you are hesitant enough, you can always go in for an endobiliary stent or a T-tube. The only thing is, again, you will be needing a patient to come back after 2 to 3 weeks to remove or get a check cholecystoscopy or a cholangiogram. Because this is what you achieve at the end. So this is not gallbladder stone, these were the CBD stones which were removed. In case if you have a T-tube, this is how the T-tube is supposed to be. The only thing is it increases the morbidity in a patient. And you need to keep your patient at least for 5 days and then ensure that the patient goes home with in situ and comes back properly and you get that. But those 9-10 days, unnecessarily, why to keep that? So primary closure is very much achievable. Because in case if a T-tube is in situ, then this is what we are looking at, that this is how the picture should be at the end of 10th day. That it should be filling up with no filling defects, and the dye should reach into the duodenum, delineating the mucosal pattern of the duodenum wonderfully. If this is the case, that means now the time has come to remove your T-tube very safely. Thank you all.
Thank you, sir, for that insightful session. Any queries from the audience?
Dr. Vikas,
Sir, morning.
I think the case, the video which you showed, you had operated. So the nice lecture and very fine surgery also.
Sir, thank you.
I think, can I ask how much since laparoscopic stone removal from CBD now is a well-established technology.
Sir.
Many people you are also doing, and very famous surgeon also.
Sir.
With humble,
Sir.
I would like to know your total number of cases which you have.
Lab CBD?
Yeah.
Something around, I would say around 50, sir.
50.
Yeah.
So largest diameter of the stone and the nick which you have applied on the CBD, largest nick.
Usually like the maximum which it had at around 2 centimeters. But the rest of the CBD was not 2 centimeters because time was not permitting me, because if one more management which is supposed to be done, if the diameter is more than 2 centimeters and it is studded with stones, then you can remove as much as you can, seeing the patient's comfort, and later on convert it into a lap choledochoduodenostomy and go back.
Right.
So you do not need to clear everything right from up and down. Yes, you need to give in time 20, 30, 40 minutes, and then maybe if it is more than 2 or 2.2, then you can always have one more checklist, and that is choledochoduodenostomy in the same sitting.
And what are the usual, you told bile leak is usually. Any other complication during the procedure?
Most of the times it is the bile leak, because the meticulous closure, no matter how good you do, it always leaks in for a couple of days to start with. But if you have cleared off everything in the hepato-Morrison's pouch, then it drains out easily. Most of us have also a habit of that not cleaning up, because we are looking only at the CBD, not looking at omentum which is stuck. And all the stone particles and the sludge, everything lodges on that, and that causes infection later on.
One last question. Either in the literature or your experience, long-term follow-up, whether stricture develops in the CBD after laparoscopic CBD exploration or
Sir, God forbid, I have not seen. Yes, I have not seen. The only thing is, at times what can happen is, if you have not evaluated a patient well, number one. Number two, evaluated in the terms, let's say, previously there had multiple episodes of stone slippage. You were not able to see the lower part of the CBD very clearly. Maybe there was an inline stricture which was already in the place, and you closed it. Then patient will come back maybe with one more primary stone formation in the CBD itself. That is one. Number two, at times while giving in the sutures or doing a CBD closure, if you are taking too large of a needle, maybe let's say a Vicryl 2.0 or something, and you are taking bigger bites of the CBD. And if you do that, what happens that you make already a stenotic part in the supraduodenal. So if you are doing that, that can again result in the due course of time a partial stricture. But what is more important, the way that it happens is that stay in the midline from the medial and the lateral aspect, and ensure that you take a smaller bites with a fine size needle, so that you do not distort the CBD. If those things are taken care, less likely that it is going to have a CBD stricture later on. Automatically, you are going to delve with the laparoscope in any of the CBDs which are at least 1 centimeter in diameter. 8 to 10 millimeters, I would take a word of caution, and I will take the help of my gastroenterologist friends, able gastroenterologist friend rather than anyone. And later on, if it is 1 centimeter or more, and I have a flexible choledocoscope or a ureteroscope, I will go in with a lap CBD.
Thank you. Fantastic. Thank you so much.
Yeah, thank you. Thank you. Thank you.
Thank you, sir. I would like to invite Dr. Pankaj Kumar, sir, to felicitate sir on his talk. Thank you, sir. Our next talk is on the topic liver transplant basics by Dr. Lileshwar Kaman. He is professor in the Department of Surgery, PGI Chandigarh. We welcome you, sir.
Thank you, chairpersons, for your kind introductions, and ladies and gentlemen. At the outset, I'd like to thank Dr. Sonkar and Dr. Nanda for inviting me for this prestigious meeting here. So today I'll be speaking on basics of liver transplantations. The purpose is not to make you an kind of expert in liver transplantation after hearing these lectures. And this is mainly an overview of liver transplantations. I will not be going into the nitty-gritties or technical details of liver transplantations. So my purpose is to maybe ignite a kind of spark in your mind so that you can think of taking up liver transplant as a career options. So with that, the session overview, as I said, I'll be discussing about the history of liver transplant at a glance, mainly world and India in particular, to understand the various nomenclatures like donor, graft, and technique of liver transplantations, and of course a bit of technicalities and post-operative course like what can happen, what are the outcomes. The history of liver transplantations. The history of liver transplantation is started in 1950s with mainly canine experimentations. Initially, it was thought that it is a fiction, then it became an experimentation, then it has become a reality, and it has become a success today. And this was mainly attributed to two persons. One was Thomas Sturgill, the father of liver transplantation in USA, and of course Sir Roy Khan from UK, that is mainly from the Cambridge. Then the landmarks, and if we look at the early setbacks and learning from the mistakes, 1963, Thomas Sturgill first performed the liver transplantation in Colorado, Denver. Then he did 3 liver transplantation. Initially, he did on a 3-year-old girl with a biliary atresia. In fact, in the first patient, he could not enter the abdomen, and the patient died intraoperatively because of bleeding. And 3 patients died, and he had a kind of voluntary moratorium for some time to introspect and develop maybe a better technique. And at the same time, in Europe, mainly in UK, Sir Khan was also trying to do the transplantations. And ultimately in 1967, Dr. Sturgill performed the first long-term survival liver transplantations. The patient survived for 400 days. And next year, 1968, Sir Roy Khan also performed a liver transplant in UK. Then the long march continued from that time till date, and Sturgill moved from Colorado, Denver to Pittsburgh, and that has become the Mecca of liver transplant surgery. And most of our generation surgeons were kind of, not exactly if you cannot say trained, but they were influenced by Sturgill, and people have visited his centers. And of course, after that, the most significant, one of the most significant milestone was the development immunosuppression like the cyclosporin in 1980s that has made transplantation easier. And of course, after that, then the Brazil, Raja and Strong in Australia, they started doing the living donor transplantations for pediatrics group. Then it got disseminated to the Asian countries like Japan and Hong Kong, and it became a kind of disseminated and a success story. Coming to the Indian story, in 1994, the Parliament approved the Human Transplantation Act. Then after that, it became easier for liver transplant to get disseminated, and we have to give credit to Dr. Sain and Dr. Rajsekhar. They were the first person to do living donor liver transplant and cadaveric liver transplant in India in 1996. Then it became a clinical and a commercial success in India. In fact, we have become one of the most prolific country, liver transplant doing country after USA and China. And in fact, in 2022, we did 4,000 liver transplantation. That is kind of, really a kind of success story. But the problem here is, as I look at the thing, we are working in government institute. That success story has not been, we are not able to produce that success story in a government sector. And we are training people and training the resident upcoming surgeons. That is the need of the hour. That is in fact, that should be one of the objective of disseminating and starting liver transplant program in tertiary institute, especially institute like KGMU, BHU, IGMS Patna, and all these tertiary center. That is our responsibility. I think for the next generation, we have to leave behind that kind of legacy. Then indication of liver transplant, there are various indications are there, like chronic liver disease, decompensated cirrhosis, then acute liver failure, complication of cirrhosis, liver cancers, cholestatic condition like PSC and PBC, pediatrics condition like biliary atresia. Then how do you do an allocation model? I will be mainly speaking on disease donor liver transplantations. In PGI, Department of General Surgery, we do mainly cadaveric liver transplantation. We are not a very, very high volume center, but we do around 8 to 10 liver transplantation per year because of various logistic and restrictions and other things, but that is not excuses. So allocation model for disease donor is done according to the MEL sodium score. That is the model for end-stage liver diseases. This is a numerical scale ranging from 6 to 40. And the calculation is used by, the calculation is done by using bilirubin level, creatinine, INR, and sodium level. And this is a kind of, the score, accordingly, higher score indicates a urgent surgery for liver transplantation. So you put them on the waiting list and you calculate the, the MEL score, then accordingly you allocate the available, donor or liver that way. Then the MEL score of 15 or higher is generally give the maximum benefit if you are, weighing against the risk of liver transplantation. So 15 is the index number or the score. So once the patient achieves that 15 score, you put the patient on the waiting list and you do the calculation accordingly and allocate the liver. Then other key terminologies in liver transplant, it depends upon the source and the destination of the graft and the implantation technique. It is the DDLT, it is a disease donor liver transplant. LDLT is the living donor liver transplant. And in future, maybe lots of research is going on definitely because it is a donor shortage. The supply and demand is, great imbalance is there. So we are not able to take donor from the human. Then we are thinking about, maybe your xenograft that is from the animal, especially from the pig. There has been case report last time also, you must have read in a newspaper and media, the kidney transplant and liver transplant from the pig. They have been surviving for months. So it may become now it is like a fiction, experimentation. But maybe 10 years down the line, it will become the norms. So hopefully that kind of thing happen. Then what is orthotopic and heterotopic? Of course, orthotopic is you put the neo liver in the native place. You take out the liver from the right hypochondrium and put the liver there. But heterotopic is you put keep the native liver there, but you are putting another part of the liver in another part of the abdomen. That is a kind of auxiliary kind of thing. Then implantation technique, whole liver graft. Definitely that's a classical cava replacement, piggyback. Mainly we do piggyback nowadays because cava-caval anastomosis technique is not done very commonly. 90% of the liver transplant, DDLTs and whole liver graft is done by the piggyback technique. And of course, if you are doing an LDLT like split liver, hemi-liver, reduced graft, you can do with kind of, this is another kind of technique is used. And this is just a pictorial demonstration of what is heterotopic and kind of orthotopic liver transplantations. Then more terminology in relation to liver transplants, warm ischemia and cold ischemia time, and organ preservation. So these things are kind of terminologies that we use during liver transplantations. And according to disease donor liver transplant, there are two types of disease. DVD with DCD, that is donation after cardiac death. Also, that can be those organ can be utilized for various organ transplantation, including liver transplantations. So the procurement sequence of event and concept of ischemia in DVD, the patient is declared brain dead and he is taken to the OT, and there are two phases of dissections is done. One is warm phase and another is the cold phase. Warm phase is before the cross clamping, and once the cross clamping of the aorta is done, then you have to do a cold phase. It is a hurried thing, and you have to perfuse the whole system, and then you take out the organ. And in DCD, it is a controlled DCD. DCDs are also again divided into kind of this is a classification system of DCD is a Maastricht classification. That was a consensus meeting in 90s that happens in Maastricht in Netherlands. So they have defined and they have classified that various group of categories of DCDs accordingly. Mainly it is the control or uncontrolled. If it is a kind of control, if the patient is in ICU or if the patient's DVD is declared already, this patient is ready, in that kind of controlled situation, you can take the organs. All the organ can be procured. But say it is an uncontrolled kind of thing, the patient has come to your emergency surgery OPD or emergency medical OPD, and there they had a cardiac arrest. And in that situation, if your logistics permits, you can take the maybe some of the organs. If it is not heart, or it is not lung, or if it is not liver, at least kidneys and corneas and other thing can be taken. So this is another way of looking at the thing. Currently, of course, DCD is not the standard of care in the India at least, but worldwide, it is the numbers of DCD donations and transplantation is increasing. Then again coming to the warm and cold ischemia, there is in warm ischemia definitely there is no blood circulation, cells switch to anaerobic mode and loses all energy stores, cellular integrity is compromised. On reperfusion, they may not be able to regain their functions. So your idea or your aim should be to decrease the warm ischemia time as short as possible. But in cold ischemia, it is a necessary evil. Like, you have to harvest the liver and the organ, you have to keep it for some time, then only you can implant. So it takes time, definitely, but it has got some advantage over warm ischemia is, of course, the coldness will limit the metabolic demands, and the preservative solution can give some substrate and correct the osmolality and pH, and all advantages are there. And if you reperfuse the liver within that time period, 5 to 6 hours, livers are standard, cold ischemia time is around 6 hours, we consider it. And the liver is a very sensitive organ for that matter, but kidney can withstand that CIT maybe up to 24 hours, 12 hours is the standard. So various, like heart may have a CIT level of around 4 hours. So this kind of things are there, that understanding has come there, definitely, so it is helping in our transplantation process. So these are the, some kind of steps of doing a kind of the donor harvesting procedures. like identification of the vessels are mainly important, supra IVC, infra IVC, and the arterial system, portal vein. This is very important for that matter. And the cold phase, definitely aorta is cross clamped, then you start the perfusion through the kind of aorta or the iliac vessels. Then for if you are taking a multi-organ harvesting like pancreas also, then dual perfusion might have to be given. Otherwise, in liver, single perfusion is also okay. As these are the few pictures of intraoperative pictures of our own patients that we harvested. And preservative fluid is another component of your liver transplant technique, definitely. So you have to get used to this kind of thing. They are specialized solutions to use to flush, cool, and store the donor liver till the time they can be implanted and after explantations. So mainly the UW solution, University of Wisconsin solution is the gold standard that we use more frequently in liver transplantations. And another is the STK solution, that is histidine, tryptophan, and ketoglutarate. That is also another fluid that we frequently use. And the recently ZL1 and Celsors are being used in other solid organ liver transplant, especially they use, the cardiac people use the Celsor in heart transplant. Then another advancement, the recent development and evolution happened in the transplant scene is the machine perfusions, especially in liver transplantations, because previously what you used to do is you used to keep that harvested liver in a static cold saline, and we used to preserve that for 5 to 6 hours or whatever was required for the transplantation. But there is a recent development of machine perfusion. You would keep that liver in the machine and you perfuse with normothermia or hypothermia, and keep the liver maybe up to around 24 hours. So the role of machine perfusion, another important thing is that it can give you a diagnostic and therapeutic role also. You come to know the, you can predict whether this liver is going to work or not. That kind of thing you can predict. And therapeutic, of course, you can repair the damage that is incurred during the storage, during the harvesting process, and all this thing can be done. And you can buy time. As I said, you can go up to maybe, now they are claiming that it can be preserved up to 24 hours. And that will, logistically, it will be kind of very advantageous position, because then you don't have to do in emergency surgery. You can plan it as an elective procedure. So you have got all the logistic ready and you can do that surgery. Then harvesting from liver donor is just like hepatectomy. Whatever part you want to take, you can take that. But before surgery, you have to make a kind of imaging, good imaging evaluation of the donor, and the anatomy has to be done. So that is important. These are the different types of LD graft. And the recipient side, that explantation, of course, the recipient hepatectomy is one of the most challenging phase of your liver transplantations, and it can be done by two methods, actually, cava preserving and cava replacement. Of course, cava preserving is the piggyback technique, and the strategy is to reduce the kind of bleeding during the liver transplantation. Explantation time is the temporary venovenous or a temporary creation of a portocaval shunt, or a use of cell saver to preserve the cell during the bleeding phase. Then back table preparation of the graft. One, you have taken out the liver organ and you prepare and you are explanting, and during that time you synchronize with the recipient surgeons, and then you start the back benching. There you prepare the fusor or organ for implantations. Then implantation relatively, definitely it is easier in DDLT than the LDLTs, and the outflow reformation for DDLT is classical. As I mentioned, the classical cabo-cable anastomosis that is not very commonly done nowadays. We do piggyback mainly, and in cases of LDLT it is more difficult. Then this is one of the pictorial demonstrations of the that anastomosis of the cava outflow. Then comes the inflow. reconstruction, that is the mainly portal vein. This is end-to-end, portal vein anastomosis. Then coming to the arterial reconstruction, it is the Achilles heel of liver transplantations. And it comes in various permutation and combination, various donor abnormalities or donor size diameter mismatch can happen with the recipient the liver. So those all things can be kind of managed if you are a good vascular surgery experience. This is another important thing you should have if you want to pursue a career in liver transplantation. You should have good vascular anastomotic technique exposures, and good vascular surgery exposure has to be there. It is a liver transplant is mainly a vascular anastomosis. 3 vascular anastomosis will decide your outcome or fate of your liver transplantations. Then coming to the biliary reconstruction, it is another very simple looking in comparison to the whole context of the liver transplantation, but it can be a, really problematic. Stricture, ischemia, because of the harvesting process, because of the preservation process can happen. So you have to be very careful. Most of the time we do end-to-end bile duct, anastomosis. But in, in cases where you might have to do a hepaticogynostomy Roux-en-Y, especially indicated like PSCs, primary sclerosing cholangitis. In those situations, you cannot leave behind a native CBD as much as possible. That is the exercise. And coming to the graft functions, once you've done all the anastomosis, then you can, in fact, evaluate your graft function intraoperatively, like usually on table. Well, the best method is whether the bile is coming from the upper part of the urinary, the harvested liver or not. Golden bile should start forming. So once it is done, that means it is kind of, indications that your liver is good. And of course, the clot will start forming, lactate will come down, the anesthetist will say, okay, lactate is down now, and liver should look pink and it should be supple and soft. That means you know that your liver is working. Then post-op courses, key things to watch out for. Of course, the main important thing is whether your liver is functioning or it is a non-functioning. So if it is functioning, you will come to know with hemodynamics, liver enzyme, trends of bilirubin, the level of lactate, coagulation profile, INR, and renal parameters, and of course the conscious level, whether you are able to extubate the patient on the 3rd or 2nd days of your post-transplanting, definitely. And there are various reasons of dysfunction and non-functions are there that you can evaluate, and you can accordingly manage the patient. And other post-op courses definitely start immunosuppression. Intraoperatively, we give methylprednisolone 500 milligram to 1 gram definitely. Then on the next day, we start with triple drugs like steroid is continued. I'll take just 2 slides or 3 slides. Then you start 3 drugs, and mainly steroid, CNI, and anti-proliferative. CNI is mainly the calcineurin inhibitor. Tacrolimus is used most commonly. We use tacrolimus, and anti-proliferative is the MMF. And of course, the other prophylaxis, like any major abdominal surgeries, we give prophylactic antibiotic. Protection against CMV is very important. Gencyclovir that can be started after around 10 days. And of course, you have to protect against the pneumocystic carinae and opportunistic organs like so you have to give cotrimoxazole, usually given alternate days. And antifungal might has to be given very early phase. And technical complications, hepatic artery thrombosis or stenosis may be a very difficult situations, and that can lead on to graft loss. Portal vein thrombosis and stenosis can be managed definitely, and biliary leak and anastomotic strictures can be also managed. Non-anastomotic stricture like ischemic cholangiopathy, they can happen late, and retrieval-related ischemic insult may be the cause of this kind of situations. So I don't have any concluding slide. I want to keep this idea, or keep this kind of your philosophy going on in your mind. And my request will be, think about a career in liver transplantations. It is not easy, very labor intensive, and it is a very demanding areas. But as I already mentioned, in India, especially in private sectors, this is a clinical and a great commercial success. So you can make money also for that matter. Yeah, thank you. Thank you for your patient hearing.
Thank you, sir, for simplifying transplant concepts. I would like to call Professor Abhinavan Sonkar to felicitate sir on his talk.
Oh, yes, sir. I've got a question here. Can I answer? Yeah.
Good afternoon, sir.
Yeah.
Sir, I wanted to ask. You have mentioned India is the third on the list of number of liver transplants as of now.
Yeah, yeah.
Sir, as compared to US and China, where I think the procedure is a lot more streamlined
Yeah.
as compared to India. Sir, is it fair to say that the ethical issues surrounding this field of transplant are still a major deterrent in a way for young surgeons to take up transplant surgery in India? Are the ethical issues in India a matter of concern to take up transplant surgery?
Can you be more specific? What kind of ethical issues you are talking about?
So, for example, I heard on the news a few months back that there was a transplant surgeon. He performed the surgery at a private hospital, and the next thing he knew he was locked up for some reason that he was not supposed to do, or somebody filed a complaint, and the things surrounding this field are still unclear, I feel. That's what I wanted to ask.
No, by and large, more or less, these things has been settled because of the TOHAEC, and now it is a TOTAEC, transplantation of human organs and tissues. We have 94. It was actually, we have to give credit to our former Prime Minister Rajiv Gandhi. He was the initiating in liver transplant, at least in 94. The TOHAEC was formally passed in the parliament. Then in 2014, again it was kind of, some kind of amendment has been there. And see, everywhere there will be black ships. You cannot control everything, but by and large, ethically see, there is no ethics issue there. But definitely, it is a kidney also, all those kind of things happen. But in liver, at least it is less than kidney there are. So I don't think that is an ethical issue. That is mainly more about the demand and supply. Because our culture, Indian culture, we are not kind of, the supply and demand of, donor and the recipient. It is a mismatch is there, that there is great disparity. That is one. We are not, doing that. This is our success story is mainly LDLT, But, in USA or European country, you see, there is mainly the DDLT, 90% DDLT, 10% LDLT. The reverse is true for our Asian countries and especially in India. That is the thing. And moreover, the training. The main problem is training and starting the liver transplant because it is a logistic is enormous. Yes, you cannot imagine it. In a normal, medical colleges or institute, we do, right, you have seen, we are talking from fistula in NO to anal hemorrhoids to liver transplantation. So general surgeons are burdened with this kind of, situations. So that's why we are not able to focus in government sector, tertiary centers. That is the problem. Mainly it is being done in a specialized center like Medanta, Apollo, but we have to give them credit. We have to appreciate that. They are doing excellent work. That have to realize. Now our emphasis should be to bring that kind of model, at least not that model, at least some kind of replications in the government institute, especially tertiary center like KGMU, BHU, IGMS Patna, or New Delhi AIMS, or PGI Chandigarh, Zipmar. That is that. And then we have to train the, the upcoming surgeons, surgeons in training. We have to inspire them. We have to give them the kind of, first-hand experiences, and we have to inspire them. Then only I think this will change. And this is need of the hour. The society need it, and I think we are going in that direction. That was the whole idea.
Yes.
Yeah. Thank you.
Thank you, sir.
Thank you, sir.
Okay, sir. Okay. Thank you so much. Appreciate always.
Thank you, sir. We are now moving to the panel discussion on CA gallbladder. Before that, may I ask the residents if they want a coffee break or should we go to the panel straight away?
अच्छा अभी तो CA गोल
Move to the panel?
चलिए आपका टाइम
Okay, thank you.
आपका टाइम है oh my god sorry
Moderator for the panel discussion is Dr. Vishal Gupta. He is professor and head in the Department of GI Surgery at AIIMS Bhopal. And our esteemed panelists today include experts in gastrointestinal and hepatobiliary surgery. The first one is Dr. H.S. Nag sir, professor in GI surgery at Sir Gangaram Institute, New Delhi. And Sir Dr. Dileshwar Kaman, professor in surgery, PGI Chandigarh. Dr. Puneet, professor in the Department of Surgery at IMS BHU. And Dr. Anshika Arora ma'am, chairperson in surgical oncology at Chandan Hospital. Welcome you, sir, everyone.
कहाँ रखना
I would like to invite Dr. Chering Tandok, additional professor in the Department of Surgery at PGI Chandigarh, to join the panel discussion. Sorry, sir.
So can we start? Yeah, good afternoon everyone. And I am Dr. Vishal Gupta. So I am going to moderate this session. And hello, am I audible? Am I audible? Echo now. So am I audible? Right. So we will try to make this panel discussion more interactive, and I expect residents to get involved in this discussion, and they can ask any question related to this presentation or any other question besides the topic which is covered here with. And because this is a broad topic which was given to me, carcinoma gallbladder, and we know that it is a very extensive topic. There are so many things to be discussed, and it is very difficult to discuss each and everything about the carcinoma gallbladder in this 45 minutes of session. So what I tried to I have tried to cover only important aspects that all the resident should know without going into any kind of controversy, to avoid making them more confused than what they are at present, right? So to begin with, just a background regarding the carcinoma gallbladder. We all know it is the most common biliary tract cancer, and it is the 6th most common GI tract malignancy. And as we all are aware, northern India is the hot spot, like many other countries, Asian and South American. It is difficult to detect in its early stage because symptoms remain non-specific, and sometimes it mimic other benign pathology, most commonly the gallstones. Patient, they usually present late, and when they present in the advanced stage. And the carcinoma gallbladder, we know it is an aggressive malignancy. Recurrence is common despite having the potentially curative surgical resection with R0 margin.
And at present, we all know that surgery remains the only potentially curative treatment for the management of carcinoma gallbladder. So with this background, we will start with the first case scenario. So she is a 56-old female resident of rural area in the Prayagraj, Uttar Pradesh. She had pain in the right upper quadrant in the abdomen for 3 years. She was diagnosed with gallstones 2 years back. Largest stone was 2.5 centimeter. Initially, she was treated medically. She was advised cholecystectomy, but she refused at that time. And for the past 3 months, I think you are not able to see this thing. That is a problem. I think we can, maybe we can just, but you will have some problem, I think. Maybe we can change the position. It would be convenient because. So for the past 3 months, she had severe anorexia, increasing pain abdomen with significant weight loss of 6 kg. Ultrasound was repeated, and that showed a gallbladder fundal mass of 2 by 2 centimeter. There were multiple large nodes around the common bile duct, and there was a liver as well and mild ascites, and it was suggestive of advanced gallbladder malignancy. So with this case scenario, I would just like to ask panelists, what are the different established risk factors for development of carcinoma gallbladder? So Dr. Nag, can you please start?
I think one you mentioned already, gallstone is the foremost, and basically I think milieu for the both gallbladder cancer and this thing gallstone is the same. It's the same population who develop that, but cause-effect relationship is still not established. Others are that like Salmonella typhi carriers, abnormal pancreaticobiliary duct junction. These are the usually accepted these things. Smoking, alcohol are lower down the line.
Dr. Puneet, sir?
One is age, females, I forgot, female, fatty female, the same, that applies for the gallstone, it applies same for here. It is 3-4 fold more common in the females than males.
Now you have given, I'm audible here. You have given a case scenario here when we talk about as such the age is not the independent risk factor as such, but of course we all know that for all malignancy age is the independent risk factors. So the elderly female presenting for a long standing history of gallstone, that to a size of 2.5 centimeters. So it has been seen that in the studies if the stone size is more than 3 centimeters, the chances of developing malignancy is 10 times basically. So size of the stone is also important risk factors there for the carcinoma gallbladder. So here you can say a large stone which is present for a longer duration is an independent risk factor there for the carcinoma. And apart from that, we can see the ultrasound report, there is a fundus mass present 2 into 2 centimeter with the paraortic, lymph nodes around the CBD. And there is SOL. So presence of SOL doesn't mean anything. There on ultrasound, we have to evaluate them further with the CT to see exactly whether it's a hemangioma, because as such the SOL may be a hemangioma also.
No,
so
I
we don't think that
at this stage just we are talking about the risk factors.
Risk factors, yeah. So I think apart from that, I won't feel like there is any risk factor. Of course, the patient is from Prayagraj, so we must remember as the endogenetic plane is the risk factors there for carcinoma gallbladder. I think these are the enough risk factors present in this patient to say.
Sir, you want to add any other risk factor with regards to gallbladder cancer?
If we think about, of course, already has been described by kind of both the speakers. Otherwise, environmental factor that has been described by Professor Nag. And other things like, if you look at the thing pathology wise, like, porcelain gallbladder is another risk factors definitely. And gallbladder stone associated with polyps, especially if it is more than 1 centimeter. So those are the things that has been described. Of course, they are standardized. They has been described in the textbook also, and they has been validated by the large cohort study, especially from our country also. And I think Dr. Nag's group has, they were the expert in fact for cancer gallbladder, and they have published lots of publications. So they are already established.
So any other panelists want to add any other point? Any residents want to ask anything regarding the risk factor for gallbladder cancer or ask any question? So just to compile regarding the risk factor, we all know that there may not be a single factor which is responsible for the development of gallbladder cancer. It may be a multifactorial etiopathogenesis which is underlying there. It may be a combined effect of chronic infection, inflammation, environmental factors, as well as the genetic susceptibility. So, we know that not all the patient having gallstones develop malignancy. It may be a just chance association. It may be some underlying chronic inflammation induced by the stone, which leads to increased risk of gallbladder cancer. So, gallstones, we know it is the chronic inflammation, large stones more than 2.5 to 3 centimeter. Porcelain gallbladder, sir has mentioned 7 to 15% risk of malignancy is there. Then one important thing is the anomalous pancreatobiliary duct junction, because there is a long common channel leading to increased risk of pancreatic juice being refluxed into the biliary system, and that may lead to gallbladder cancer if CBD is not dilated, or sometimes there is a dilatation of the common bile duct resulting in the development of cortical cyst itself, and which itself is a risk factor for the malignancy. Then you can have a large polyp, especially if it is more than 1 centimeter. Then there are certain other chronic inflammatory processes like inflammatory bowel disease, ulcerative colitis, primary sclerosing cholangitis. Then we have certain dietary factors like mustard oil, some factors related to soil or water pollutant. We don't know exactly what are those things. Then chronic typhoid carrier or salmonella infection. So, these are the some certain risk factors which may be associated with the increased risk of gallbladder cancer. They may not play alone, they may act in combination with each other, so that only certain patient will develop gallbladder cancer. So, coming to the second case scenario, we have young female 35-year-old. She had lower abdominal pain with discharge per vaginum. Ultrasound was done, ultrasound whole abdomen and pelvis. There was a small uterine fibroid. At the same time, the sonologist found an incidental finding in the gallbladder. There was a single non-mobile hyperechoic lesion which was attached to the posterior wall of the gallbladder. Size was 11 mm, and there was no post-acoustic shadow. Gallbladder wall was otherwise normal, you can see, and CBD liver was normal. So, what's your impression, sir?
So probably only a single non-mobile hyperechoic lesion. It could be either a polyp also. The size is also less, but still the wall thickness is around 11.2 mm, which is significant. So probably I would investigate this patient further.
So it was the size of that lesion, that is 11 mm. Wall was otherwise normal.
Okay.
So you can see this is the lesion, and wall is otherwise normal. There is a just focal lesion on the posterior wall of the gallbladder.
So the patient is asymptomatic, so it could be probably a simple gallbladder polyp. So I will make her further evaluate based on this finding. And
so the next question is whether you want to get the CT scan, MRI, or repeat ultrasound. Dr. Puneet?
I think, Vishal, in my opinion, the Doppler may be a good investigation to see exactly the vascularity, because that will ultrasound is a good investigation to evaluate the gallbladder and gallbladder lesions as such. So if someone has put a simple Doppler to it, it may be more informative rather than being directly going for CT. So the patient is having ultrasound, one just put a Doppler to it and one can assess exactly is it a polyp or it is a stone which is attached there. Of course, there is no acoustic shadow to it, so better to have a Doppler attached before we can go for CT or MR.
Dr. Nag, would you like to get Doppler or?
Doppler can suggest this thing, but all these patients' size is more than 1 centimeter and appears more flat than if you see the ratio horizontal to this thing, horizontal and vertical ratio. The most likely this thing vertical this thing ratio is very less. That will be less than 1. If it is less than 0.7 and more, then chances of malignancy are, even if it is smaller than 1 centimeter, if polyp is there, they appear more like a solitary polyp and there is no acoustic shadow, and I would like to do a CT abdomen in this patient to characterize this lesion further, and then go ahead. If there is suspicion of malignancy, then we will take out the gallbladder.
So, sir, you would like to get the Doppler or CT scan or anything else?
I will get a CT scan here, definitely, even though she is asymptomatic. This is a single non-mobile hyperechoic, and that is there is no acoustic shadow on kind of the ultrasound. So right. Here we cannot ignore the the diagnosis of polyp, and if it is a polyp and in a female patient,
This
There
is the
also,
CT scan which was
more
done.
than 1.1 centimeter. Definitely. Also, CT scan has been done, I think, here. So you can see the polyp on that is vascular kind of, vascularity is there, like a hyperechoic kind of thing. So I will, until and unless proven otherwise in further, I will consider it as a polyp and a potential for CA gallbladder, and I will treat her accordingly.
Right. So how will you manage this case? Sir, will you observe or you will go ahead with the surgery?
I'll take out the gallbladder. It depends if it is north region, high incidence of gallbladder. If it is south region, it may depend.
No, just based on the findings.
Based on the finding, I'll take out.
Because this was the incidental finding, right?
I'll take out.
So you will go ahead with the surgery.
Suspicion
Dr.
of the
Puneet,
even if it means to the preventive cholecystectomy, I'll go ahead with that.
So now I can say that in this patient the surgery is indicated as such. Any polyp more than 7 or 8 mm, I think is a case where we should all try to intervene as such, because the incidence of malignancy, it has been said that the polyp which is more than a centimeter, the incidence is high. So in this patient, of course, it is very much indicated to have a surgical intervention done. Now I think, can I go?
So the next question is, what are the indications of surgery in incidental gallbladder polyp?
It's okay. Now, first thing is like what surgery is to be done in these patients. I think we should discuss first that, and then we can discuss about the incidental.
Yeah, I think first we will start indications of surgery, then what is the surgery which is to be performed.
So of course the incidental carcinoma gallbladder, first thing is like, I want to say, when we say it is an incidental carcinoma gallbladder.
No, it is an incidental polyp.
The incidental
it
polyp.
It is an incidental polyp, same scenario.
Incidental gallbladder polyp. Yeah, if any polyp which is more than a 8 to 10 centimeter millimeter, we should always go for
8 mm or 1 centimeter.
10,
what is your
centimeter.
cutoff?
10
mm.
10 mm.
I think accepted is the more 1 centimeter or more, but there is evidence is coming. Even some unfavorable features are there. Even 7 centimeter maybe. Like I told earlier, if it is horizontal, vertical to horizontal ratio, if horizontal is more than the vertical, then that is one reason. Then vascular pattern. So there are so many things, but for you I think it is fine. You should remember if it is 1 centimeter or more. The answer for
so
you.
One is the size criteria, 1 centimeter or more, and second
is the vascular pattern.
Second is the
vascular pattern.
Irrespective of size.
Irrespective of size, even if the vascular pattern is basically, if your size is less, then you have to consider 2-3 factors. Like if horizontal, it is solitary, this thing, not polypoidal lesion, flat kind of lesion, and vascular
pattern. So it is a
pattern
sessile or pedunculated?
Sessile or pedunculated, and vascular pattern is also matching, then chances are more, then risk is more, you have to take it out.
Any other factors, sir?
Associated stone there. Yeah, you can go ahead, sir.
So another, two things are there, like, the one thing is associated with abnormal pancreaticobiliary duct junction with a polyp. If it is associated, then they indicate there is an indication for phylectomy. That is a definite indication, I think, that you have to take it out. And the size you were talking about,
size we have already
size
mentioned.
is already mentioned by Dr. Nag, I agree. 6 centimeter more or 1 millimeter or 1 centimeter, that is there. And of course, if it is associated with, say, but this particular patient doesn't have any association. In general, the porcelain.
Any other
porcelain gallbladder or
porcelain gallbladder itself is a risk factor for malignancy.
Definitely,
so
but if it is associated with this kind of situation, then you might have to take it out. Yeah, yeah.
Any other factor, madam? You want to add any other?
Along with this GB polyp, if there is any associated wall thickening of the gallbladder, then probably it need to be further evaluated.
Right. So there are multiple factors which can help us in deciding the role of surgery or indication of surgery in the presence of any incidental gallbladder polyp.
Another thing is the tumor marker. I think
let's see what literature suggests regarding the because if we decide that this patient is not going for the surgery, then we have to think how we have to follow up this patient. What should be the modality, what is the frequency, and how long we should follow this patient. because this becomes very, very important. Patient will ask you the very simple question, I am having this polyp which was detected on the ultrasound, whether I should go ahead with the surgery or no. If you say surgery, then patient will ask different other question. If you say surgery is not required, the next question definitely patient will ask, then what next to be done? After how much time I should get the repeat imaging, and then how long and how frequently. So let's see what the literature suggests. So the simple criteria for the management of incident gallbladder polyp depends on three major things. One, whether it is symptomatic or not symptomatic. If it is incidental, then you have to see for the size and then associated risk factors. So what are the different associated risk factors? Again, age is important. Patient more than 50 years, presence of associated gallstones, Indian ethnicity, male sex, associated other pathology like primary sclerosing cholangitis, and then sessile polyp, especially if it is more than 4 mm at the base and there is a focal wall thickening. So these are the certain risk factors which are associated with increased risk of malignancy in any gallbladder polyp. And based on these all criteria, we can just decide what are the different combinations. So suppose gallbladder polyp is more than 1 centimeter, if it is symptomatic, you go ahead with cholecystectomy. If it is between 6 to 9 mm, there are associated risk factors. These are the different risk factors. So if it is 6 to 9 mm with risk factor, go ahead with cholecystectomy. Polyp 6 to 9 mm, no risk factor, follow up. Less than 5, risk is very low, follow up. Even with the risk factor associated, less than 5, no risk factor, follow up. And how to follow up? Different strategies have been described. You simply follow up with the ultrasound, maybe at 6 monthly interval, later and yearly, but up to 3 to 5 years of follow up is required. During the follow up, what you have to see, if there is an increase in the size of the polyp, that becomes very important. So if patient is otherwise asymptomatic, it is incidental, but during the follow up size increases, it means there is some problem, patient should undergo cholecystectomy. Now coming to another case scenario, 45-year-old female, pain abdomen for 2 years, there was ultrasound which showed gallstones, gallbladder was otherwise normal, patient was planned for laparoscopic cholecystectomy, and during the cholecystectomy, surgeon had this finding. So based on this, I just want to ask all the panelists, these are the different options. So I will start with Dr. Puneet. Yeah, ma'am, you want to say something?
Sir, I wanted to say that I'm not a medical oncologist, I'm a surgical oncologist.
You are a surgical oncologist?
Yes,
I am
yes.
really sorry because I was told that medical oncologist. So what's
sir,
your opinion?
If this patient was with me, then probably we could go ahead with biopsy, frozen section.
Probably because you are a surgical oncologist, this patient was taken up as a gallstone disease. Unlikely this patient will be with you.
So if the patient
the patient was sent to you with this finding. Or suppose there is a general surgeon who is doing the laparoscopic cholecystectomy, and during the procedure, this was the finding.
Yes, sir. So if this patient was being taken up for cholelithiasis, just for lap chole, by a general surgery person who was not prepared for a radical cholecystectomy, then they can do two things. One is they can document all the findings, not take the biopsy, close it up, and then further evaluate the patient later on with cross-sectional imaging or refer if they cannot. Second thing they can do is, yes, take a biopsy, document the findings, and then close up the, do not do cholecystectomy basically.
Right. So you have mentioned two things, right? Biopsy and no biopsy. So in which situation you will suggest for biopsy, and which situation you will suggest for no biopsy?
If it is only a GB mass and there is no mental disease,
finding, actually. This
there are no
finding.
mental mets, nothing is there, then I think they can close up without taking the biopsy, because it may be a T2 or a T3 lesion which may be looking like a mass. And then if we take a biopsy, there is a chance of seeding and upstaging the disease, because anyway we are not going to do the surgery, the treatment, radical surgery right there and there. So we can close without the biopsy. If the disease is looking little extensive, maybe a T4 lesion or mental deposits are there, in that case they can do the biopsy for documentation.
So biopsy from where?
Biopsy, sir, both should be done ideally, a mental deposit as well as the GB mass.
So how will you get the biopsy from the GB mass?
If it is a T4 lesion, sir?
No, what is the method? It is a true cut biopsy or it is a shape biopsy? How will you take?
So during the surgery,
during the procedure, yes.
During the procedure, as it's if it is easier to take with the cautery or with the scissors, they can do it.
Any apprehension of bile leak from?
Yes, there
your
is always
biopsy site?
apprehension for bile leak, sir. Yes, that's what the first thing I would say is avoid doing the biopsy, close it up, do the workup, and then we can come back to
Right.
it.
I think it is a very important message from the general surgery point of view. If you see such kind of lesion, then avoid taking the biopsy. You can take biopsy from a lesion which is away from the lesion, away from the gallbladder, especially if there is some metastatic deposit in the liver or peritoneum or maybe in the omentum, right? Sir, out of these all options, what will you suggest?
First thing is there are multiple problems in this scenario. First thing is at tertiary care center we usually
What
don't
will you suggest as a general surgeon? See, we are talking about
For
the
general
residents.
surgeon.
Ultimately, they are going to do practice at least for some time as a general surgeon.
Actually, patient has got only ultrasound at this stage. This thing answer is just to close this up and refer patient to this thing. There is no need. Needling has not to be done at any this thing. Any biopsy, if somebody want to do, then that will be the cholecystectomy with wedge resection that you can't do. And that too also there are so many problems. If you want to opt for that, then patient has not given consent for that. Patient is already under anesthesia, you can't take out the tube, then take the consent. Patient may blame you. If it doesn't come out the malignancy, then he will say, why did you take this is the problem. So first answer you take this thing.
So all of you agree that
document
first
that
option is
stop
not the
this
viable
thing.
option.
That is best option.
No, continue with the laparoscopic cholecystectomy.
No.
So you
stop.
All of you don't
Abandon
agree.
the surgery
Open
and
cholecystectomy. Open cholecystectomy.
Open cholecystectomy I will not recommend.
No. Biopsy and closure.
No
already
biopsy.
mentioned.
No biopsy.
Abort the surgery and refer.
Abort the surgery and refer.
As a general surgeon point of view, I think this
Abort
will be
the
the
surgery and
most
refer.
safest. Radical cholecystectomy at this stage. Suppose this patient was being performed at tertiary care center, at your center.
Actually, medical legal problem is still persisting, but if we try to do, then we have to explain, take the consent from this thing. Then at least if you are efficient, at least do the ultrasound there. There is intraoperative ultrasound to assess the liver and other area. There are no metastasis in the liver. Then you do this thing, cholecystectomy with liver wedge. If it is not possible with the laparoscopy, then you open. If it is, there are so many inflammation in the Kylat region, you can't safely detect. There is risk
You are
of bile
trying to
leak.
say suppose expertise is available, then you can go ahead with the
Go ahead
radical
with the
cholecystectomy.
wedge is anticipated this thing extended cholecystectomy and
But you
send
will
it
have
for
to get
frozen.
the frozen at the same
Get
time.
the frozen
But
there.
again, ethical issues and medical issues,
Yeah, that will
medical
remain.
legal issues
That will
right.
remain.
And any other option?
There is another thing, like if you are in the best of the centers, you are talking about the tertiary center, like our centers, PGI. Like in these situations, like, yeah, we have to kind of find out if there is any metastatic disease or not. The options of anticipatory radical cholecystectomy is here. If you are expert and if your logistics are okay. But
first thing-
before that, you have to make sure, because only ultrasound has been done in this.
Yeah, mostly, see,
So
when you take up the patient,
there is
only
whether
ultrasound
the
is done.
infiltration of the liver, the contiguous infiltration, or there is any non-contiguous lesions are there, not metastatic we are talking about. We have to rule out before that, because
So how will you do that?
Yeah, the
we have to
intraoperative
make-
ultrasound. Yeah, we call up
I-
the ultrasonologists and they come to our OT, like they're next door to our
But
OT.
with pneumoperitoneum created and already we have a ultrasound pre-operatively maybe a few days back, right? So a percutaneous ultrasound.
No, not percutaneous. I am telling intraoperative ultrasound.
Intraoperative.
You
But
open
that-
the patient,
that-
conversion.
But that will
There is
rule
no
out
doubt
all
about
other
that.
metastasis.
Pardon?
Will that rule out all other metastasis?
No, all other metastases. Otherwise,
Means
logically,
extra-abdominal?
if you say what are the areas where gallbladder metastasis, lymph node and the liver mostly, and peritoneal and other things,
So
the
at
diaphragmatic
tertiary care
surface,
center,
you can
you-
see macroscopically.
So at tertiary care
Yeah.
center, when the expertise is available,
Yeah.
you want to go ahead with the surgery.
Radical cholecystectomy, anticipatory or whatever. But this should
Radical
not be taken so lightly also. In non-dilated this system or other things, so that can have some consequences you might have to face. So those things has to be taken into
So
consideration.
it may not be a very straightforward answer.
Yeah, it is not a straightforward answer.
Right.
I
For
think
going
one
ahead
point,
with the going ahead with the radical cholecystectomy. Right.
one point is only case I think for the FNAC if this appears advanced. Cases where you might be giving the neoadjuvant chemotherapy, you have taken up, calcite involved, CBD appears, and there are multiple lymph node in the porta, maybe N1 disease, or T3, T4 disease. Those cases you may put on needle. If it is malignancy, anyway it is advanced. If it is non-malignancy, there is no harm.
But having such an advanced disease detected as a surprise intraoperatively is a bit uncommon, because
It
these
is
are actually
uncommon,
the
but it may occur in the general surgical practice, because this scenario will not be there with your center and our center,
ultrasound,
because this ultrasound was not done properly. This scenario हम बोलते रहते हैं कई बार रेजिडेंट को, ये मरीज की किस्मत होती है वो कहाँ गया, किस अल्ट्रासोनोलॉजिस्ट या किस सर्जन के पास गया. He is not able to see thick gallbladder and all. Our ultrasound.
So many things may be missed on
incidental gallbladder
preoperative
cancer is basically it is histological surprise at tertiary care center, and these are referral which we are getting from.
So let's see what is actually recommended. So in it is not. It is not not exactly.
Sometimes it is a part length 4 or 5 days kind of thing. So it is not necessarily that it is a kind of priority. So empyema and mucosal has to be also.
It is more looking like a, see, this is just one picture, but
Sir, I just wanted to say one thing.
Yeah.
That with going ahead with radical cholecystectomy without a cross-sectional imaging may be a little disadvantage to the patient final outcome, because that is the main treatment for CAGB.
see, going ahead with the radical cholecystectomy, I understand your concern. The problem is there are multiple other complex situations, other complex problems, from ethics to some other things. For example, you go ahead with the radical cholecystectomy, right? And post-op, definitely you will get the CT scan, because there was no CT scan pre-operatively. And there are some other lesion away from the gallbladder in some remote area in the liver, maybe in the segment 8 or segment 7 or 6, or maybe in the left lateral.
Yes,
Then
so
it becomes a very
exactly my
difficult
point.
situation to explain to the attendants why
so
you
message
have.
should not go to the residents that we should go ahead
Yeah,
with
that's
radical
why.
chole without
Yeah.
the imaging.
So for the residents, this is a very simple recommendation from the NCCN guideline. If you see such kind of situation, you face with some kind of situation, you feel it is a gallbladder mass, you have prepared for, you have taken up the patient for the simple laparoscopic cholecystectomy, it is better to defer the case and refer to some specialist center, right? So intraoperatively, what you can do from your side, you can simply do the complete staging laparoscopy. At least I think that you can do from your end without any doubt. You explore the remaining abdomen, look for any distant metastasis on the diaphragm, in the pelvis, in the peritoneum, in the omentum, elevate the liver from other ports, look under surface of the liver. So you can do a very good staging laparoscopy, you can document, you can take the pictures, and then simply refer the patient to some other centers. If there are multiple metastases, you can see on the liver, diaphragm, pelvis, omentum, you take as many as biopsy as feasible, possible and safely, and then with all documentation refer to some other center, right? Or at least you can get a very good triple phase CT scan in the post-op period to have a sufficient staging. And with that you can send the patient to some other center, but don't try to go ahead with the very aggressive kind of surgical procedure at that point of time. So this is a very simple advice: defer and refer. Close the patient, do the proper staging, document, and then refer the patient to some other person who is expert in dealing with gallbladder cancer. So this patient, actually this patient was referred to us, we went ahead with the radical cholecystectomy, but it was xanthogranulomatous cholestatis. Another case scenario, 50-year-old female, patient had pain abdomen for 1 year, patient was otherwise healthy, patient underwent laparoscopic cholecystectomy for gallstones, surgery was uneventful, surgeon did examine the specimen, gallbladder was apparently normal, patient came after 1 week, she was doing well, but on histopathology there was adenocarcinoma. right? So with this background, I would just like to have an answer. What is an incidental gallbladder cancer, ma'am?
So by definition, incidental gallbladder cancer is when on imaging like ultrasound or whatever imaging and during the surgery of lap cholecystectomy for cholelithiasis, nobody had suspected that was an abnormal gallbladder in the terms of malignancy. And the surprise comes once the histopathology report is available to the surgeon. That is the definition of incidental gallbladder cancer.
Any other definition, sir?
I think this is the most accepted. Some definitions involve intraoperative this thing detection.
Like the
also,
previous case
like
scenario.
the previous case. That is the thing. But
So
this is the classical definition. This is the actual true incidental, because if you have done proper imaging, thorough imaging, then incidental gallbladder cancer will not be there, because thick wall gallbladder atypical finding will be dissected. This thing detected by a good ultrasonologist.
So anything else you want to add?
So, sir, the paper you have quoted by Dr. V.K. Kapoor, sir has suggested that incidental CAGB is basically the surprise finding of the histology, and whereas other finding that was the previous one, it is unproved or unsuspected malignancy.
So it may be a missed or unsuspected. But what is more important, that you have to open up the gallbladder after taking it out. If you don't open it, you can miss those findings, right? So the again incidental is purely as an histopathological surprise, but at the same time, if you find some lesions during the surgery or after taking out the gallbladder and opening the specimen, they are also considered as an incidental gallbladder cancer. So what other information do you think is important for further management planning in this scenario?
So we get a lot of these patients, second opinions also, as well as for management. So there are two basic things I want to know. One is regarding the histopathology, and second is regarding the steps and findings of the surgery. So if we start with the steps and findings of the surgery, I would like to talk to the surgeon to find out few things. One is whether they use the bag or gallbladder was removed through the port, which port, whether they used
So
a bag or not.
why this point is important?
Sir, it is important because there may be some seeding, especially if it is a advanced malignancy. Even if it's not advanced malignancy, there are chances that seeding may be present in the port site. So that is why. Number three, I want to know
how
whether
that seeding will happen. What is the mechanism? Just for the residents, because if you see these incidental gallbladder cancer, right? As mentioned, apparently there was no growth on gallbladder when it was opened up. Only histopathologically it was identified. So what is the mechanism with which it leads to seedling of the
Yes,
cells
sir.
in the port site
Yes,
or
sir.
incision site?
Yes. So sometimes what happens is when we are dissecting, there may be bile leak from the cystic duct on the distal aspect of the cystic duct. That means on the gallbladder side, and sometimes that can also have few cells in the bile. Malignant cells in the bile, which can be actually transferred through the bile
Right.
into
So it is the contamination of the port site or surgical site with bile, which contains the malignant cells. Because a small malignancy which was detected on histopathologically, it is very unlikely that it has gone beyond the serosa, it has perforated the serosa. So it is not the tumor which has come in direct contact with the tissues, it is the bile containing the malignant cells which has contaminated the port sites, implanted cells, leading to recurrence later on, right?
So, sir, few things I was saying. So, one is which port, whether they use the bag. Another one is bile, there was bile leak or not. Fourth, whether it was a difficult surgery, how long did it take, the duration of surgery, because that can give us some clue regarding the T stage or other things. Then the second important thing is histopathology.
So what is the important points that you would like to see on the histopathology, because you
again-
have the report?
Yes, again histopathology, three things. One is the cystic duct node, whether it is positive or negative. Number two is the margin, the cystic duct margin. Number three is the T stage, whether it is T1A, T1B or whatever after that.
Dr. Nag sir, you want to add anything?
I think ma'am has mentioned all other factors that surgeons, what we need to know, was there any bile spill? That was not there. Was there any stone spill? Then what aspect is, if it is T2 and beyond, T2 we would like to know whether it was on the hepatic side or it is on the peritoneal side. Lymph node madam already told. then further staging will be done.
Sir, any other point?
Yeah, you were asking about the mechanism of port side
No,
metastasis.
just asking the other
yeah,
information
port
that
side, no, the mechanism we are not yet done.
Okay.
Basically, that is not only the bile spillage, it is the chimney effect of laparoscopy, basically.
But I think that has not been proven, the chimney effect.
No, whatever, but that is a logical thing. Yeah, that will implanting your,
But I think port side, this we will discuss again.
Yeah, okay, fine. So that was right. Other thing is the most important thing is the T staging, definitely. All the gallbladder fissure, course of actions will depend upon your T staging. If it is beyond T1A, that means T1B up to T3, everybody will.
So I will come with the management part.
Yeah, management.
So at this stage, for the residents, suppose they see such kind of case. So what are the important information which they need to know or seek in the report or from the surgeon, because this information is very important for the further management planning, right? So one is the T stage, right? And it becomes very important because you get the report, sometimes they just mention it is adenocarcinoma, nothing more than that. And it becomes very difficult to now know what is the T stage. For that, you have to get the biopsy report, reviewed at your center from a good pathologist. You may have to get the slides and blogs from the original pathology center, then get it reviewed at your own center to have an assessment of the exact T stage. Even if they have mentioned as a T1A, it is better to get it reviewed at your own center, because just a minor change from T1A to T1B is going to make a major difference in your further line of management. So it is better to get the biopsy report reviewed at your own center. Then margin status, as mentioned by one of the panelists, cystic duct margin is important. Then cystic node status. Very commonly we don't take out the cystic node along with the gallbladder in the simple cholecystectomy, but if it is there, then you have to look for what is the status of the node in terms of malignancy. Then any other points they have mentioned, bile or stone spillage, and then it was removed in bag or not, and whether it was a total cholecystectomy or it was a subtotal cholecystectomy. It is very, very important. So if you see malignancy after subtotal cholecystectomy, there is a very, very high chance that it was a difficult cholecystectomy because of which subtotal cholecystectomy was done, and then very, very high chance that there is a residual malignancy, even if the biopsy suggests it may be a T1A, right? And then you have to read the biopsy report starting from the gross. If you see the gross mentioned by the pathologist, they will write 5 by 4 centimeter gallbladder, or they may write multiple small bits of tissues received. So it is better for us as a surgeon to read the entire pathology report starting from the gross, microscopy and the final impression, because that will give you a multiple information, whether the entire gallbladder was removed, whether it was removed in piecemeal. If it was removed in piecemeal, even if the operative notes are not mentioning it, then you have a strong suspicion it was a difficult. There were multiple stones spillage, bile spillage, and the prognosis or the further line of management definitely is going to get affected. So when will you consider completion radical cholecystectomy in incidental gallbladder cancer?
So if the histopathology suggests of T1B more than staging more than T1B, then probably the patient will require completion radical cholecystectomy.
Any other indication besides the T1B and more T stage?
Apart from T stage, we have to look at many other things.
Right.
I would include T1B also in completion radical.
So one is T stage, right?
T stage. Then we have to, as I said, the margin. If the cystic duct margin is positive, then the candidate may be for neoadjuvant. If the cystic node is positive, but our imaging is not showing other positive nodes on cross-sectional imaging, still the patient may be a candidate for neoadjuvant chemotherapy. So in
so
my...
you will consider not surgery, neoadjuvant.
Neoadjuvant and then...
Okay.
I think
any other...
In this case, one is T stage, you have to discuss. There are other factors. You have to decide whether do you want to, if it is T1A, there is T1A, no bile spill, no stone spill, gallbladder was intact, there is no need to do anything. If it is T1B or advanced any disease, bile spill, stone spill, it is going to go for neoadjuvant therapy first, then you have to do surgery. If you are sure there is no bile spill, there is no stone spill, T1A, T2, I take up for surgery straightforward. Any patient with T3 disease, for T3 disease means if you have violated the plane between the gallbladder and liver, it is usually going to the liver. So you have breached the plane, there will be always be seeding, and as T stage increases, residual tumor and dissemination and lymph node metastasis incidence also increases. So T3 will go for neoadjuvant. Any residual tumor there showing activity will go for neoadjuvant. T4 anyway goes for neoadjuvant. So one, we have to segregate patient ki what are the patient will directly go for the surgery and what are the patient go for the neoadjuvant. And I think NCCN indicates if it is T1B beyond, all patients should go for this thing PET CT also.
So right, so we can just summarize that there are certain deciding factors regarding the decision making for further management. It is the T stage, you have to know the T stage, margin status of the cystic duct, nodal status, suppose cystic node were removed, whether it was positive or not, and the intraoperative bile splash. And based on this NCCN guideline Dr. Nag has mentioned, it says that if it is a T1A with negative margin, with negative node, if cystic node was removed, you can simply observe these patients because simple cholecystectomy is adequate with around 100% survival at 5 years. So nothing more to be done. And this is a very important because just to have an observation, you have to be 100% sure that the histopathologically stage was only T1A. And it becomes very difficult sometimes to differentiate between 1 and B. If there is any doubt, it is better to go ahead with the compression radical cholecystectomy. On the other hand, if you have a T1B, T2 or T3 or node was positive or margins were positive, they have suggested for completion radical cholecystectomy. If cystic duct margin was positive, you add common bile duct excision because there is a high possibility of residual disease in liver or nodes, as sir has already mentioned. So if you have decided for the reoperation, what is the best timing? How early and or you will wait for some time? As soon as it is diagnosed within 4 weeks, 4 to 8 weeks, after 12 weeks?
I think some evidence available if it is
what is your choice out of these all 4?
Actually, when it comes to our center, usually patient have waited a bit more. It depends more on the
suppose
stage.
Patient has just come after a week with the biopsy report. It is
if
a
it is
different thing that
resectable, in practice I don't wait for this thing if we are not giving neoadjuvant therapy. If T1, T2 I told earlier, N0 we are taking
we have
for
decided
surgery.
for surgery. Then we have just want to know what is the best time according to you.
As per literature, it is I think 4 to 8 weeks or more than at least 6 weeks should be waited, and that because there may be occult metastasis.
So
that
you want
may
to wait
appear.
for 6 weeks?
Practically I don't wait, but anyway, literature says that.
Sir, this is definitely a controversy right now. It's not decided which is the best time, but definitely, as sir also mentioned, in advanced T stage, we should wait longer because we should not do futile surgery. We should do the neoadjuvant chemo. But in very early T stage, margin negative, node negative, we can operate early. So,
sir?
I will agree with that. If it is a very early stage and margin negative and lymph nodes are negative, as early as possible. But if it is beyond T2, definitely, you give chances to the biology of the tumor to, express.
So based
Sometimes
on the,
there is self-selection. That is
factor.
the reason why Dr. Nag was telling the current literatures, say 4 to 8 weeks.
So based on the risk factor, you will decide whether you want to go ahead
definitely.
early,
If it is
or
early
you
thing,
just
it is a clean laparoscopy surgery as early as possible.
Actually,
just to
one
summarize,
other thing you have to consider level of the evidence available. Only level evidence is this thing level 3 evidence.
So
there is no
if you see
level
that
evidence.
ideal time, we don't know. There is no consensus like we had, and you can do at the earliest opportunity. So any role of neoadjuvant chemotherapy, I think already we have mentioned, but again going through the literature, it is not very clear. It may be considered in case of bile stage or subtotal cholecystectomy or advanced T stage. Any role of port side excision? How many of you will do port
I
side
think
excision at the time
it has
of
been, it is clear now it is part of
No.
disseminated disease. So only
So
I
no
think
role of port side
no
excision,
role of
routine.
port side excision.
Then another scenario, 55-year-old male, patient was evaluated for pain in the right upper quadrant, 3 months with no history of jaundice. Ultrasound, there was gallstones with gallbladder mass in the fundus, 2 by 3 centimeter. No significant intra-abdominal lymphadenopathy, no free fluid. Now, what should be the workup of this patient in terms of image, tumor markers, what is the role of MRCP and what is the role of PET CT scan. So, in terms of image, what is the optimal staging imaging modalities?
Probably CECT chest with abdomen and pelvis would be sufficient for this patient right now.
I think everyone will agree with this. Right. What is the role of MRCP? In which situation you will get the MRCP?
MRCP in cases of carcinoma gallbladder occurring in the neck region, then probably I would prefer for MRCP to differentiate it with the perihilar cholangiocarcinoma. Otherwise, in fundus and body, there is no role of MRCP as such.
Any other indication?
Abdominal pachypapillary duct junction you can find out there. Then there may be indications for bile duct excision in that situation.
So jaundice, I think if patient is
that
having
is
jaundice,
enough.
then you can add with the MRCP. And what is the role of this tumor markers? I will just summarize.
Sir, when we are suspecting CAGB, upfront CA19-9 and CEA can be done. CA19-9 and CEA can be done.
Timer.
Baseline should be done for the follow-up, but they don't have any diagnostic value for this thing. They are prognostication for that, or supportive value you can say.
I think there are many other things to be discussed, but I think time
Role
is
of
up.
PET CT.
Role of PET CT scan at present, I think the guidelines they are suggesting that routinely it is not indicated. Only in the locally advanced case when there is a yield is high, you can get the PET CT scan. Otherwise, routinely it is not indicated. Or when you are planning for the neoadjuvant chemotherapy, then you can have it for the proper assessment to response to neoadjuvant therapy. So any yeah, there are two things. One is the borderline resectable lesion, locally advanced, and second is the unresectable lesion. So there is some debate in terms of definition of the borderline resectable, because it also depend on the from the surgeon to surgeon how much extent of the tumor with surrounding viscera can be resected. But unresectable means if the major vascular involvement is there, especially the common hepatic artery along with the right hepatic or left hepatic artery, or the main portal vein along with the right or left portal vein, or there is a extensive frozen Calot's triangle, hepatoduodenal ligament, multiple adjacent viscera involvement. So they come in the category of locally advanced unresectable tumor. But in terms of involvement of for example just common bile duct or the right hepatic artery or the duodenum or the colon or the stomach, for some it may be still resectable. There is no clear definition what is locally advanced borderline resectable or locally advanced disease per se. But I think in all locally advanced scenario, now suggestion is there for the neoadjuvant chemotherapy to have a better biological assessment of the tumor. So any question, any doubt from the residents?
It doesn't upstage the disease. The staging still depends on TNM, but it definitely is a risk factor. So we usually consider neoadjuvant chemo in these patients. It's a poor risk factor.
Or at least if you don't want to go for the neoadjuvant therapy, there is a strong indication for the staging laparoscopy before radical resection, because there is a higher possibility of your peritoneal dissemination. Any other question? So we conclude this session, and I am really thankful to all my panelists for the wonderful discussion. Thank you.
So now I would like to call Professor Abhinav Arun Sonkar to felicitate Professor Vishal Gupta sir and Dr. Anshika Rola ma'am. Ma'am, thank you, ma'am.
We'll now break for lunch and then we'll join back here at 3 for a session on role of minimal access surgery in HPV surgery.
Welcome back, everyone. Our next topic is role of MIS, minimal invasive surgery in hepatobiliary surgery, preserving oncological principles by Dr. Chering Tandup, additional professor in the Department of Surgery, PGI Chandigarh. We welcome you, sir.
Good afternoon, everyone. Welcome back after a hearty meal. So, first of all, I am grateful to Dr. Sonkar and Dr. Geetika for giving me this opportunity. I am Dr. Chering Tandup. I am additional professor in the Department of General Surgery, PGIME at Chandigarh. So, as we know that minimal invasive surgery is no longer new in hepatopancreatobiliary practice, the real question is today is not whether we can do minimal invasive surgery, but when we should, for whom, and at what oncological cost. The talk is about preserving the oncological principle without any compromise. So, the main message of my talk will be that minimal invasive surgery is just a technique and oncological surgery is a philosophy, and when these two conflict, the oncology or the philosophy must always win. We must never let the approach overshadow the oncological principles. So, how to define the equivalence in HPB surgery? For minimal invasive surgery to be acceptable, it must match the open surgery in every aspect of oncology, such as an R0 margin, proper adequate lymphadenectomy, station-wise lymphadenectomy with zero tumor violation, and the overall the disease-free survival as well as the overall survival should be equivalent to the open surgery. And one thing that every surgeon should keep in mind, that early conversion is not a sign of failure, but it is a sign of a good judgment. So, why minimal invasive surgery and what does it has to give to us and to the patients? So, when done correctly, it definitely reduces the blood loss, where the patients have fewer wound complications, they attain early mobilization and faster functional recovery, faster bowel movement, faster mobilization, ambulation. And the most important thing, that patients which require further adjuvant therapies, so they can get early initiation of adjuvant therapy can be started in such patients, and of course a shorter hospital length of stay. But these benefits always come with the learning curve and the risk of catastrophic error in selection of the patient. So, the gains of minimal invasive surgery are real, but only when the oncological discipline is well maintained in such cases. So, coming to the evidences, what does evidence have to offer to us? Because all our practices are evidence based. So, first of all, that not all the HPB organs, the liver, pancreas and the biliary system, the evidence is not uniform across these, and so there are well established guidelines and evidences for laparoscopic or laparoscopic liver resection in selected cases, and also for minimal invasive distal pancreatectomy. But for major hepatectomies and for difficult anatomical location of the liver, such as posterior superior segments, the data are still evolving and are mainly the center dependent. Similarly, the case with the robotic procedures, the more and more data are coming, and same is the case with the intrahepatic cholangiocarcinoma. But the minimal invasive surgery in cases of gallbladder cancer or perihilar cholangiocarcinoma still rise in the controversial or a gray zone, and similar is the case with the laparoscopic pancreatodudectomy. So, we will study this in the further slides. So, liver. So, liver surgery is where the minimal surgery has matured the most, and we have now the structured guidelines, and level 1 evidences are also there, and it is now considered as standard for peripheral segments, for left lateral sectionectomies, and also for the parenchymal sparing colorectal liver metastasis resections. So, this is a European guideline, the Brescia published in Oxford Journal in 2025. This is the Brescia internationally validated European guideline. So it is one of the most comprehensive European guidelines on minimally invasive surgery, and it integrated both the laparoscopic as well as the robotic approach. It was developed by using multi-round Delphi consensus, and this guideline provides almost 137 evidence-based recommendations, and across the 8 domains. These domains include the terminology, the standard terminology, the indications, the patient selections, the procedures, how the surgeon should be trained, the outcome, cost, as well as the sustainability. So laparoscopic, they concluded that laparoscopic liver resection is preferred over the open surgery for selected patients with hepatocellular carcinoma, as well as the patients of colorectal liver metastasis, and where the expertise is available. And the robotic liver resections, they have also shown to have a comparable short-term and long-term oncological outcome in experts centers. They also emphasize that on the training, on the structured training, the center expertise, as well as the step-up mastery. They laid emphasis that technical feasibility must not override the patient safety. This guideline also provided some standard terminology, such as what is laparoscopic liver section, what is laparoscopic assisted liver section, what is robotic liver sections. So this may further help in uniforming the research and benchmarking the guide data. So now coming to the next is the Oslo Comet trial. So Oslo Comet trial is basically a laparoscopic versus open resection for colorectal metastasis. It was a randomized controlled trial, and this trial changed the conversation. It showed that the laparoscopic parenchyma sparing liver section, it reduces morbidity without compromising the oncological outcome. This trial legitimized the liver minimally surgery, not anecdote, not registry. It is level 1 evidence. So this was a trend changing trial. In cases of hepatocellular carcinoma and with the cirrhotic background, liver surgery, minimally surgery does adds value. First of all, it reduces the trauma to the patient, and which then further leads to less decompensation, less ascites formation, and maintains the transplant candidacy pathway in such patients. But still, the oncology priority should be kept in mind with maintaining a R0 resection status. So in complex liver cases where posterior superior segment resection as well as the major hepatectomies, these demand a vascular advanced skills such as proper exposure, proper vascular control, and hemorrhage readiness should be kept in mind, and it should be converted early if the safety or the margins are at the risk. So as the literature is advancing, so is the tools that help the surgeon. So there are certain tools that protect the oncological outcome in cases of minimally invasive surgery, such as laparoscopic ultrasound, which helps in planning the resection margin for deep margins also, and it is a real time imaging. Another thing is the ICG fluorescence, which helps surgeon a lot in cases of liver resection for proper demarcation of the segmental anatomy, as well as for difficult dissection, the bile leak detection also. Then maintaining a low CVP strategy by asking your anesthetic team to maintain a low CVP, which is also done in cases of open liver resection. Then Pringle readiness, same as the open liver resections, and the specimen contaminant. So the resected specimen should be properly bagged in a bag so as to prevent spillage and tumor spillage as well as the port site contamination. These tools protect the oncological quality, but they are not optional. They should be used in a mandatory in all cases of liver resections. Coming to the pancreas, so pancreatic surgery is where the evidence demands restraints. So the biology of tumor in the head of pancreas as well as in the left-sided pancreas, the tumor biology is different, the clinical presentation is different, their route of spread is different. So is the surgery for them. So distal pancreatectomy and pancreatiodunectomy are fundamentally different surgeries and different and the evidences also are different for both of them. Minimal invasive surgery, minimal invasive distal pancreatectomy is well supported by the evidence, but for pancreatectomy, caution is required, and it has a steep learning curve, and the training is very critical for this. So, coming to the minimal invasive distal pancreatectomy, so what does the evidence say? So, this diploma trial was published where they compared the minimal invasive versus open distal pancreatectomy for resectable pancreatic cancer. It was an international randomized non-inferiority trial, and they showed that the minimal invasive distal pancreatectomy is non-inferior to open distal pancreatectomy in cases of radical resections rate in patients with resectable pancreatic cancer, and they also showed that patient had improved recovery and reduced the length of hospital stay, but which is a secondary outcome basically. The primary outcome was the oncological safety, which was well proven in this trial. So, this is a high quality evidence supporting minimal invasive surgery, but of course with a good selection of patient. Then Dutch trial, Dutch people conducted a trials called as Leopard trial, where they also studied the minimal invasive versus open distal pancreatectomy, and it was a patient blinded randomized controlled trial. So, it was conducted in the 14 centers, and they also concluded that left sided pancreatic tumors which received the patient that received the minimal invasive distal pancreatectomy has reduced time to functional recovery as compared to the open distal pancreatectomy. Although the overall rate of complication was not reduced, but still MIDP was associated with better quality of life and less delayed gastric emptying, and there was no additional cost compared to the open pancreatectomies. So, another trial is still still being in the process by the Japanese group of people by Naoki et al. And the abstract was published in the BMC Cancer in 2024 by the name of Lapan study. There they also are trying to prove the non-inferiority of minimal invasive distal pancreatectomy as compared to the open pancreatectomy, and if they are able to demonstrate this, so they would also be validating its short term advantages and the long term clinical efficacy of the MIDP. So, pancreatectomy, so this is one of the most important slide of this presentation. That this trial was also being conducted by the Dutch people, and the question was that can we do it laparoscopically, pancreatectomy, but can we do it safely and oncologically in a programmatic way. So, this trial was stopped early due to a higher 90-day mortality rate in laparoscopic PD arm, and it didn't show any significant improvement over the open pancreatectomy. The benefits were not sufficient to justify the increasing risk in the trial setting. So, basically the pancreatectomy requires a careful patient selection, and it has a steep learning curve. So, higher expertise and higher training is further needed for performing a safe pancreatectomy with a good oncological outcome. Then coming to the advances in pancreatic minimal invasive surgery. So, robotics are the new system, though they are also robotic may help with the reconstruction and reduce the complete conversions, but evidence still must be interpreted carefully, and the learning curve and the selection bias influences the outcome of such cases. Coming to the biliary tract cancers, when the biology trumps technique. So, if the liver rewards technique, so biliary cancer punishes the misjudgment, and biology dominates here. So, gallbladder cancer and the perihilar cholangiocarcinoma are the gray zone of minimal invasive surgery. So, but the feasibility exists, but still the long term oncological equivalence is unproven in such cases. And the gallbladder cancer is, as you know, is a biologically aggressive cancer with a complex lymphatic spread. So, minimal invasive surgery may be considered only in the highly selected cases in expert center, and outside this context the open surgery still remains the oncological standard in cases of biliary bile duct perihilar cholangiocarcinoma or the gallbladder carcinoma. So, why this gallbladder cancer fall is controversial is because of the risk of bile spillage, the tumor risk of tumor spillage leading to peritoneal dissemination. Then there is mandatory en bloc resection, wedge resection segment 4 or segment 4B and 5 resection with the proper station regional clearances in appropriate stages, and the port site metastasis, though it is rare, but still it can lead to a catastrophic failure in cases of GB cancers. And the current standard is that highly selective application of MIS should be done in gallbladder cancer, and in expert center only with a strict zero perforation discipline, and immediate conversion readiness should be kept in mind with the surgeon. So coming to the gallbladder literature, cancer literature, so this is a article published in surgical endoscopy where they have studied the minimal invasive open radical pancreatic cholecystectomy for GB cancer. This was a 30-day national quality improvement program analysis, and they have shown that patient who underwent minimal invasive surgery had fewer days in hospital, but and after weighing the MIS group has significantly fewer blood transfusion and super SSI, and they stated that MIS is possible but only in very selected cases such as of T2, T1B or T2 cancers. This is the Indian data published by Dr. Anil Agarwal. So there they have studied the outcome of minimal invasive radical surgery, and it was a retrospective study, and around 222 patients were studied in this, including this study, and they have concluded that minimal invasive surgery can be performed in gallbladder cancers, and they have shown to have a good overall survival as compared to the open radical cholecystectomies. So intrahepatic cholangiocarcinoma, the data is still evolving, and it is not yet it does not have yet level 1 evidence. So ICC is basically an aggressive primary hepatic malignancy, and invasive surgery including laparoscopic and robotic surgeries are increasingly used in resection for ICC, but these approaches demonstrate a faster recovery and less blood loss, but still the patient selection is critical, and evaluation of patient anatomic and oncological resectability must be kept in mind before performing such minimal invasive surgery for intra-ICC. So perihilar cholangiocarcinoma, it is the most technically demanding biliary malignancy, where minimal invasive surgery are reserved. So Guimaro et al. From Italy published a systemic review in Cancer Journal, where they studied the minimal invasive surgery for perihilar cholangiocarcinoma. It was a systemic review, and they reviewed the short term and the long term outcome of the patient. Their data, they interpreted that data are still immature to disclose the superiority of minimal invasive surgery in cases of perihilar cholangiocarcinoma, though it reduces the hospital stay, it reduces the patient, it improves the patient recovery, but still the data is at a very premature stage to suggest the superiority of minimal invasive surgery rather over open surgery for perihilar cholangiocarcinoma. So the greatest danger in HPB minimal invasive surgery is not the lack of skill, but it is an indication creep. So technology must not drive the indication, rather the evidence and oncological principle must remain the paramount. So MIS should be chosen only when the oncological endpoints can match the open surgery and nothing less. So practical how to preserve the oncological principle, basically it requires a proper simulation training, then mentored cases by a senior professor or senior consultant, then surgeon should practice it independently, and the continuous auditing makes a surgeon more and more better. So this is my last slide. So to conclude, minimal invasive surgery in HPB oncology cannot be judged by access alone. It must be judged by oncological integrity, and MIS is technique and oncological surgery is the philosophy. R0 margins are totally non-negotiable. So adequate lymphadenectomy is mandatory, and zero spillage is the standard. Survival equivalence is the end point. The future of HPB MIS in our country must be evidence governed and volume sensitive, and should be biology driven. So thank you.
Thank you, sir, for your practical and structured review in minimal invasive surgery on hepatobiliary surgery. I would like to invite Dr. Pankaj Kumar, sir, to felicitate sir for his talk. Next, we have panel discussion on bile leak, and moderator for the session is Dr. V.K. Kapoor, professor in gastrointestinal surgery at MGMCH Jaipur, and panelists are Dr. Shabi Ahmed, professor in the Department of Surgery at MLN, Dr. Vaibhav Srivastav, professor and head, Department of Surgery, MLNMC, Dr. Ashish Singh, additional professor, GI Surgery, SGPGI, and Dr. Rahul, additional professor, GI Surgery and SGPGI. We welcome you, sir.
मेरे स्लाइड नहीं है उधर दे दीजिए इनको. So boys and girls, I think once you become a qualified general surgeon, one of the most common procedures that you will be performing will be cholecystectomy, and today in majority of the cases it will be a laparoscopic cholecystectomy. It's supposed to be a very routine, simple operation, but I always say that your threshold for a complication in a so-called routine and simple operation should be very low as compared to a major operation. If a patient is undergoing liver resection, pancreatic resection, esophageal resection, they are mentally prepared for a major complication, even mortality, but not after a lap chole, because you yourself tell them, आज सुबह ऑपरेशन करेंगे, कल आप घर चले जाओगे, एक हफ्ते में अपना काम करने लगोगे. But unfortunately, if a bile duct injury happens, all this gets twisted and it creates problems. So today we will discuss just a few aspects of bile duct injury. We will not be able to cover the entire topic. So I have an eminent panel with me who have fairly large experience with biliary surgery. And what I have done, that on your behalf, I have framed some questions which are practical questions, and I would request, I have already requested them to give practical answers which will be of use to you when you start doing lap chole on your own. So my first question is to Dr. Ashish, that we've done a lap chole, and as would happen in majority of the cases, we haven't placed a drain. Now on the next day before you want to discharge the patient, how do you suspect that there is something wrong and it could be a bile duct injury?
Sir, first of all,
you want to show the slides or okay? No, you have. See, this is very important. Before you discharge the patient, most of the patients would be ready for discharge on the next day. You have to be very, very careful that when should you not, what are the early suspicion or symptoms and signs that there may be something wrong. And the dictum is something wrong after lap chole is a bile duct injury and bile leak unless proved otherwise. It's very important to have a very high index of suspicion. ये ले लो.
first of all, actually, as you mentioned, sir, it's a suspected bile duct injury. Probably, what is the problem? Like most common problem is bile duct injury. You are feared of after laparoscopic cholecystectomy. So one should know what is the normalcy. Normalcy is like if patient should get better hour by hour, patient should have less and less pain every hour by passing, and next day patient should be able to get discharged. He should be taking full normally. And then, like as you mentioned, there was no drain. So what problems you can assume? What will happen? Either the duct is ligated or there is a leak which may collect in. So what you expect is some irritation into the peritoneum or a block. So expected path, I told you, and any deviation from this normalcy, like if you feel patient is having any problem, any pain which cannot be ascertained by like your routine examination, patient is telling like this pain is, as your assumption, it is not getting fit into normalcy, then you should suspect. And there should be very high suspicion in like highly difficult cases. And in case there was difficulty on table, it was acute cholecystitis, there was a bleed, you tried to control, and in those cases you should be very very like conscious about this possibility, and then you should investigate. So as I mentioned, like there may be, usually it may be early presentation or late. Most of the time it is early presentation, where the failure to thrive, like as mentioned, patient is not tolerating orals. He is having pain which cannot be attributed to a normal scar site pain. Or if there is any vital sign changes, like if patient is having tachycardia, which is more than 100, or is having low grade fever, he is not feeling well, he is tachypneic, or there is explainable tenderness or abdominal distension, you should always suspect bile duct injury. And in late cases, it is like bilioma, there may be tenderness, or in blocked cases, blocked CVD, there may be jaundice and like sequelae of those, or patient may be septic because of biliary peritonitis or like collection. So in all these cases, you should suspect bile duct injury. It can be simplified like patient is not getting better. You have anything alteration in the path of patient's normalcy, then you should always suspect there is some problem and you should investigate.
So this is very important. The patient should be absolutely fine subjectively, and objectively when you examine the patient, all the vital signs and the abdomen should be absolutely normal. This is what is expected 24 hours after LAF coli. If any of these conditions is not fulfilled, this patient must not be discharged. She must remain under your eyes. You must re-examine after some time. If it persists, then you should investigate. Now, what investigations to do and in what order? Dr. Rahul.
Sir, I also made a slide, but I'll usi mein hoga, sir. Can I?
Yes, sure.
So, if you suspect anything, say as Dr. Ashish said, if there is deviation from the normalcy, then the first thing which you order is labs. Labs includes basically the hemogram and the LFT. That is most important to look for is whether there is rise in counts, whether there is any deviation in the LFT. So that will suggest that there is some problem with the bile duct, whether it be stone or whether it be a bile duct injury. And apart from that, if these labs show any deviation, then you can think of doing an ultrasound, or you can order the ultrasound along with the labs if you suspect that there is high likely chances of bile duct injury. If there is a drain in situ and you see bile in that, so if there is a bile in the drain, then obviously there is bile duct injury, and in that case, first of all, you will do an ultrasound to look for if there is any other collection which needs to be drained or addressed. And if there is none, and the patient is afebrile, then you can continue with the, then you can go ahead and ask the patient if he is passing colic stools, or if there is a aryl tube in situ. If there is bile in the aryl tube also, then that means that there is some continuity maintained. Then you can order an MRCP. If there is no collection on ultrasound, then you can do an MRCP in an early phase as well. And if there is MRCP is to be done to look for if there is a continuity in the CBD is maintained or not, if there is any stone in the distal part of the CBD. In that case, you can go for early endoscopic interventions. So, and then the other situation will be if the patient is running fever, there is abdominal pain, or the patient has plus minus jaundice, or jaundice is there, then you can suspect that there is a bilioma, if there is, then in that case, you first do a labs ultrasound, look for the collection, to try to drain those collections, and if you are not able to, come to a conclusion on ultrasound, then you can do a CT scan as well. And CT scan is imperative in cases in which there is evidence of blood in the drain. If the patient is running fever despite the drain draining bile, and if you suspect, so can I go a slide back just to show them? So if there is a suspicion of if the drain output is very high, in all these cases CT angio is important. And if there is melena or there is a HB drop in labs, then you should always order a CT angio in all these cases to rule out if there is any major vascular injury in there. Then the third is, if you have a high suspicion of duodenal fistula, if the bile which is coming in the drain is dirty colored bile, or it contains something which the patient has eaten, then you suspect a duodenal fistula. Then in that case, you can confirm it by drain fluid amylase if the food is not coming out rightly. Or second thing is, you can do a CECT with oral contrast to delineate the fistula if it is there. So this is how you investigate a case of suspected bile duct injury or obvious bile duct injury. And if the patient develops jaundice a few days later or few weeks later of an laparoscopic or an open cholecystectomy, then you should always be suspicious, and you should always review the histopathology to find out if it was CAGB or not. And once you have reviewed the histopathology and it is benign, then you can always go ahead and do an ultrasound followed by an MRCP to see the site of stricture and the extent of stricture, whether or in if the patient is fortunate enough, then he might be having a CBD stone which is lodging down in the lower part of the CBD, which can be tackled by endoscopic techniques. So this is how you investigate bile duct injury or suspected bile duct injury.
So very important points made by Dr. Rahul. As I said, if the patient is not absolutely all right 24 hours after lap chole, don't discharge the patient, re-evaluate. If the problem persists, investigate the patient. Basic minimum investigations would include an LFT and an ultrasound. But if your clinical suspicion is high, if the patient is not doing all right or is worsening, even if these investigations are within normal limit, ultrasound does not show a collection, is not a adequate evaluation because of obesity, gaseous distension, whatever reason, do not stop at that. If you have a high suspicion, even if ultrasound does not show a collection, go ahead, as Dr. Rahul said, with cross-sectional imaging. Whether you do CT or MR is your choice. Both have advantages and disadvantages. As he said, and as we know, that it could be bile duct injury, but it could be a duodenal or even a colonic injury. So in that case, a CT is more helpful because you can give oral as well as rectal contrast. Also, he mentioned CT angio. If there is any suspicion of hemobilia, hemobilia means jaundice, melena and pain. So the earliest manifestation would be melena or a fall in hemoglobin. If you suspect that, then CT has the advantage that you can do a CT angio, which will evaluate the vascular injury also. On the other hand, MR has the advantage that it does not involve any radiation. Most of these patients will be young women, you do not want to expose them to radiation, and the fact that you can get an MRCP. Now, MRCP at this stage is not to delineate the biliary anatomy, because although we are not going to discuss that, but early repair is usually not indicated. It is to find out if there is a stone in the CBD, because if there is a stone in the CBD, that bile leak will not stop unless that stone is taken out. So that becomes an indication for early endoscopic intervention. So both have advantage and disadvantages, but what I want to tell you that if you suspect that the patient is not doing well, even if ultrasound does not show a collection, go ahead and do a cross-sectional imaging. It may be normal, which will be a good finding, but you will not miss a collection. So these are few things which you have to keep in mind, and only if these investigations do not show that there is a bile duct injury or a bile leak, then you are reassured, and then maybe you can discharge the patient. Let me at this stage only tell you that when you discharge the patient, even if the patient is all right, you must clearly tell the patient that if in the next 7 days or 2 weeks anything happens, anything means headache, backache, chest pain, whatever, please come to me first. Once I will see you and check that nothing wrong with the cholecystectomy, then I will refer you to a physician. Because if it is the other way round, suppose it is bile leak and patient has some vague non-specific symptoms and goes to a physician, he or she will never be able to suspect or pick up a bile duct injury, and the patient will develop all the consequences, and as happened in one of our cases, the patient may even die. So, make sure that all this is mentioned in the discharge summary and told, mentioned for your protection, told for patient safety, that anything happening after cholecystectomy in the next 1 week, the patient should first come to you and then go to any other specialty. So, that is very, very important. So, now we have investigated, and suppose the ultrasound, or if ultrasound was normal, CT or MRI, whatever imaging we did, it shows a collection. So, once we find a collection, I will request Dr. Shabi to tell us what to do with it.
Now, after just to add on the previous question, the famous saying when we used to have the round with sir, that the next day if the patient is not smiling and he smiles you back, he has got some problem. That the first suspicion everyone should have, that there is something wrong. High grade of suspicion is very important. So, just to add to that, and if there is a collection, let us say found on ultrasound. Now, this collection needs to be quantified. This collection, is it a small collection, is a large collection, is pressing upon organ, or it is near the hilum associated with the GB fossa, or it is widespread generalized peritonitis kind of ascites, biliary ascites. This has to be quantified, number one, and it has to be correlated, what you know as the clinico-pathological correlation, that what is the status of the patient. This patient may be having a small collection with no sign of sepsis, very well eating and normally. So, this goes into a small subset of patient which is known as the conservative approach, and it may resolve spontaneously, but with a big caveat that if the patient is very much stable, no evidence of sepsis, and the patient is not at all like having signs of biliary injury, it may be a minor leak from the subhepatic duct, or maybe a little bit of a loose clip or something, but all collections have to be investigated, quantified. I don't jump on that, say that do an immediate PCD, that is the ultimate. So, depending on the size and the location of the collection, these collections have to be managed in two ways. Number one, either you put in a percutaneous drainage, there is bile in the collection, to resolve that collection and reduce the intra-abdominal sepsis. Number two, define ongoing bile leak. There are two big this thing of any intra-abdominal, whether this has been innocuous kind of a leak which will subside by itself, or this leak along with management of the bilioma requires additional intervention in the form of an endoscopic drainage, which can be, again, I think is the next question. Yeah, okay, so I'll not go on that. So basically we have to tackle this collection in a small subset conservatively. It has been advocated in certain papers, but majority of it needs to be drained at the earliest, and they have to be drained ultrasound guided percutaneous biliary drainage, and simultaneously many people after an early this thing for an early ERCP. I think that's I'm not going on that. Otherwise, many people have this in tandem, that you do the drainage and go for that confirmation of the ongoing leak.
So, be very cautious and careful about the words which Dr. Shabi used, that a bile, a collection, we do not know whether it is bile or blood or whatever, because if you do routine ultrasound after every cholecystectomy, in majority of patients you will find something in the subhepatic area, but that does not necessarily mean bile. So, he said very importantly that if the patient is all right, so if the patient is all right, and it is a small collection which you are seeing on ultrasound, you may wait and see what happens. But if the patient is all right, we won't do an ultrasound, isn't it, unless you are doing it as a routine. So, the very fact that we ask for an ultrasound means that there was something wrong, and then if you find a collection, as he emphasized, that this has to come out, because bile is a very severe irritant of the peritoneal cavity. It can cause very severe peritoneal reaction, may not be generalized peritonitis, only in the subhepatic area or perihepatic area, but it causes severe peritoneal inflammation and then infection, because most of these patients have bacteremia, and then systemic sepsis, then multiple organ dysfunction, and then death. And this is again what happened in one of our cases at SGPGI, because a very small collection was missed or ignored. So, bile has to be removed. Now, he mentioned ultrasound guided PCD. Dr. Shabi, suppose in my hospital ultrasound guided interventional radiological intervention is not available, or they are not able to approach it. Are there any other options to drain this bile?
Then the other options is that a relook laparoscopy. So, you go in using the same incision, you just open it up. Let us say this scenario is on day 3, no problem, you can ask your anesthetist to give a anesthesia as before. It will be a short and quick. You have to convince the attendants, get consent, that you have to relook, put in a scope. That is the easiest and fastest method, and you locate the bilioma, drain it, lavage till the effluent is not bile stain, and put in proper drainage. This can be done easily without any intervention. This thing.
Yeah. So, very important, not all hospitals, not all setups.
And I did not add the laparotomy part, because now, because most of the these leaks can be managed laparoscopically through same incisions. Otherwise, even if you don't have that expertise and think that there is tented peritonitis and all, go for a laparotomy.
Yes.
Drain it and make a controlled external biliary fistula. That is the aim at this point.
So, on day 1 after a lap chole, re-laparoscopy should not be technically difficult. You open the same umbilical incision and very carefully, very gently, very cautiously introduce the telescope. Now, you can introduce it bluntly also without any using the trocar, and do a re-laparoscopy, and at re-laparoscopy you can drain. In fact, some people think that re-laparoscopy is better because you can approach all quadrants. So, even if there is bile spill in all the 4 quadrants, you can handle it. So, you have to keep that in mind. If that is not possible, you have the option of a re-laparotomy if you have a strong suspicion, or if you have already diagnosed a biloma. And the AIMS group also advocates that you open the epigastric port in the ward itself and put a finger gently and explore that area. Very likely that if a biloma is there, it will show up in the wound. But now we are discussing a situation we have already detected the biloma on imaging. So, my next question is to Dr. Vaibhav, that either there was a biloma and we drained it as Dr. Shabi advised, or for whatever reason it was a difficult gallbladder, we had put a drain, and either the drain or the PCD is showing bile, which we have drained, the biloma. Now, the next step, as Dr. Shabi said, because what the PCD or the drain does, it is evacuating the bile from the peritoneal cavity and preventing peritoneal and systemic sepsis. But you have to stop the ongoing bile leak also. So, the method for that is endoscopic stenting, but when to think of that, when to do that, what is the philosophy?
So, sir, as you have rightly said, that once we have put in a drain, that is draining bile. So, if a patient is stable, condition is okay, we can wait for a few hours or 1 or 2 days. No need of going for any intervention. But provided you are properly patient is admitted with you and you are monitoring the patient. If supposing the vitals you see that they are deteriorating, or in other words the patient is not responding clinically and patient is deteriorating, in that case we will have to think of some intervention. And also if we are suspecting, like if a retained CBD stone which we have missed, or maybe some minor bile duct injuries, Strasbourg A to D injuries, even in that case that is an indication for early intervention. Now what will be this early intervention? It can be either only a sphincterotomy or a sphincterotomy plus a stent placement. That will depend on the condition of, but we must address this, and we will put in a most of the times we are doing sphincterotomy along with stent placement. In certain special conditions,
where like if supposing patient is cirrhotic or coagulopathy is there, in that case we will not like to do sphincterotomy. We can simply put in a stent, or another option is we can also put in a nasobiliary stent, but in that case the problem can be that ongoing leak that will also be addressed, but for the patient it is technically difficult to.
So again, 2 points, 2 words which Dr. Weber mentioned. Patient should remain admitted with you. Please, please do not discharge this patient for patient's sake and for your own sake also. See, bile duct injury is a complication, but mismanagement of bile duct injury is negligence. So if you can show that you manage the bile duct injury properly, in most cases you will not be held responsible. But if you have a bile duct injury, you do not detect it, you do not suspect it, or you mismanage it, then an expert like one of the panelists, if they are called by the consumer forum, they may say that no, you were negligent. So it's very important. So patient should remain admitted with you, and the second word he used, monitored. Now this patient requires close monitoring, both clinically and investigation wise, to see how the patient is progressing. Now as far as timing of endoscopic intervention is concerned, there are 2 approaches, as Dr. Weber mentioned. One could be very early intervention, that you have drained the bile and same time, following that, same day, next day, you drain the bile duct by placing an endoscopic stent. There are others who follow a little conservative approach, that okay, I will keep a watch on the patient, how much bile is coming, is it gradually going down. If it is gradually going down, it may be a cholecystohepatic duct injury, it may be a cystic duct leak, it may be a lateral injury which probably would decrease and stop on its own, or you go for early stenting if you have good expert endoscopist available with less endoscopy related complications. The advantage of placing a stent is that it hastens the closure of the bile fistula. So if without stent, fistula will take 2 weeks, if you place stent, it may close in few days time. So that is the biggest advantage. But then we know that the injuries to the main bile duct can be either partial, that means lateral, or they can be complete. Now, if there is a complete injury, obviously you can't place a stent because the 2 ends are disconnected. So that brings us to the next question, which I will request Dr. Ashish to address, that in a case where we have suspected, we found a collection, we have drained the biloma, now what should be the approach? Should we go for an MRC first, or should we go directly for ERCP?
So, actually, sir, before taking a call whether MRC or ERC first, we should know what are the pros and cons, what are our targets, why do we want these investigations. So first of all, target is to map the biliary system, where is the injury, is there any injury, and if it is, what is the injury. And secondly, if possible, can it be managed this time. These are the targets. Then MRC and ERC have their own pros and cons. MRC, like it's a like investigation which doesn't subject this patient to any radiation, and it can be easily done. And the best part is it gives you entire biliary map, full liver. So where it is important, and like as I mentioned, and second thing is cons. If you consider it cannot, it is just a diagnostic tool. It cannot that time tackle that problem. Whereas ERC, it's a like it gives you biliary mapping, but has its own problems. Like if there is a cutoff, as sir said, the dye will not go to the proximal system. You cannot identify. Like in this diagram, if you see, there's a like cutoff at the mid CBD, and dye has not gone proximally, so you don't know what is the injury. You don't see any proximal biliary system. Likewise, in this image, if you see, the dye is leaking proximally, and you can see only the left ductal system. There is nothing you can visualize onto the right ductal system. So probably a duct has been excluded. So that is the problem. You cannot see the entire biliary map. So that is why, like if you consider these two situations, And obviously this is an invasive investigation with its own problems like pancreatitis, duodenal perforations and all. So if we consider these two situations, sir, next slide. Okay. So like what should we do? As I mentioned, this will not give you entire map. So in our in this scenario, ERC should be conserved only for those areas where you suspect a very minor injury, like type A injury, where it is like leak from the gallbladder bed or a cystic duct blowout. In those cases only. And how will you suspect this? This comes from your intraoperative assessment. Suppose it was a very difficult cholecystectomy and you are very sure that if there is a bile leak, it is from the cystic duct stump. It was a very difficult stump. You had to like close it with sutures, and or sometimes you could not close it. And in those cases, you can suspect and you can subject this patient to ERCP. Otherwise, the golden rule is for all patients, get an MRCP. Then if required, you can go for ERC.
Actually, it also becomes a more theoretical discussion, because most endoscopists today, when we refer them a patient with bile leak for an endoscopic intervention, most of them do want and do ask for an MRCP as a roadmap.
If you permit me, the
yes,
same.
please.
We had sent for CP, they'll say get MRCP.
Yes.
Now this dilemma has to be solved. As you rightly said, if you ask your medical colleague to do an ERCP, they invariably send the patient to MRCP. Question is that which is first, ERCP or MRCP?
So in all cases, it's as a rule, even if there is a cystic duct blowout, if you get an MRCP, it will not do any harm.
Yes.
So in that case, you will have at least a roadmap. Where is the problem? And in case there is a stone, you'll be in the CBD, you will also know that. So in case you are targeting, you think that it's a simple, like very minor duct injury, then also if you get an MRCP, there would not be any harm. But if you are very, very confident patient is stable enough, you can subject this patient to ERCP, but that comes from your intraoperative suspicion. If you had a very, very difficult cystic duct stump and you are very sure that that is the reason for bile leak, then only you can subject this patient for, you should subject this patient for ERCP. Otherwise, MRCP first. And likewise, like as sir has initially mentioned, like bilioma, for the patient, killers are in bile duct injury, that is sepsis or bleeding. So in case you delay the definitive treatment by few days or something, that is not going to take the life of the patient. So your first target is ultrasound, CT scan and tackling and like making this patient sepsis free. And if you even like once the fistula is a control fistula, then you can take time. This is not going to harm this patient in next 2 days or 3 days. You can prepare the patient and evaluate your like patient, and then you can subject for ERCP or something else what is required definitive.
So in summary, I would say if availability and affordability is not an issue, it is always better to get an MRC, because that will delineate the biliary anatomy, it will help the endoscopist. But theoretically speaking, if your complication rate of ERCP is low, there is no harm in doing an ERCP straight away also. If you see a complete cutoff, you know that a stent is not going to work. Now, some of these questions are actually endoscopy related questions, but I am forcing my surgical colleagues to answer them. So, next is Dr. Rahul. As Dr. Vaibhav also mentioned, that there are 3 approaches. One is that you do sphincterotomy alone endoscopically, or you place a stent, or you place an ENBD. So, what is your preference? Suppose we have drained a biloma, we know that it is a major bile duct injury from MRCP and we are referring the patient for ERCP. What do we ask for and why?
So ERCP is going to help only when there is a continuity in the CBD maintained, and or there is a stone in down below in the CBD beyond the site of injury. So both the approaches are fine, whether you do a ENBD or you put a stent. But there have been studies on ERCP with sphincterotomy alone and along with sphincterotomy with stent. So these are all retrospective studies, and you cannot draw a definite conclusion from them because they have been done by endoscopists as per the patient's presentation. So there was a study on 42 patients of laparoscopic cholecystectomy, injury following laparoscopic cholecystectomy, and 40 were cystic duct stump blowout, and 2 were duct of Luschka leak. So they did 36 patients they chose for ERC, endoscopic sphincterotomy and stenting, and 6 patients they chose for ENBD. And they found that the median time to heal was 8 days versus 12 days, 12 days for endoscopic sphincterotomy alone. So there was not much difference, so there was no difference in outcome, but you have to use your own, logic. So if you suspect that there is a lateral CBD injury, that injury is going to take time to heal, or it may heal with a secondary intention, then you better put a stent rather than just do a sphincterotomy. Second was whether do a sphincterotomy with stenting or sphincterotomy with ENBD. So again, ENBD is a problem for the patient. It is always a drainage procedure which is better than stent in technically in terms you can flush it. It will not get blocked. Even if it gets blocked, you have the option to flush and make it patent again. But the thing is that patient will have a wire hanging out of his or her nose, which is not very which is not a welcome thing. So ENBD can be used in when you are suspecting that this fistula or the bile leak is going to heal within 5 to 7 days. So it is, if there is a duct of Luschka leak or a cystic duct stump blowout, you can very well use ENBD because it will avoid having a second ERC procedures or endoscopic procedure. You can very well take out the stent once the leak from the drain is off. But stenting should be done again if you are suspecting that there is a lateral CBD injury for less than 1/3 injury, and that is going to take time to heal, maybe 2 weeks, maybe 3 weeks, maybe a month. So in that case, you should always do a stenting. So better than the ENBD.
So except for type A injuries, which is a minor injury, cystic duct or a cholecystohepatic duct, most cases will have a stent. The advantages of ENBD, as Dr. Rahul mentioned, that it can be flushed, you can do a repeat cholangiogram without endoscopy, and it can be removed by just pulling out. Another situation where ENBD is usually placed not in relation to bile duct injuries when you have cholangitis, and especially you find pus, suppurative cholangitis, that time most endoscopists will place a stent and an ENBD for initial flushing, which will be removed and the stent will remain in place. So now we have drained the biloma, we have placed a stent, and as expected, the bile output through the PCD or through the drain gradually decreases and stops. So Dr. Shabi, when should we decide or when should we refer the patient back to the endoscopist for the removal of the stent?
For the removal, I mean, let's presume it is the indwelling or what you call the endoscopic stenting, because we have also the ENBD as we've discussed. ENBD actually placed in those special conditions where you presume that the leak is, where we have decided that the leak is minor and in the periphery, and therefore this ENBD actually has got two advantages, that you can do a repeat cholangiogram and see that leak has stopped and can pulled after, as shown in one of the papers, 7 to 12 days. So that's a short stay and the patient is fine after that, the leak has stopped. So repeat cholangiogram. Second, if it is an endoscopic stent, which the normal indwelling stent is placed, in those conditions, the CT or MR finding should not be taken as a guide for removing the stent. Rather, the cholangiographic picture should show there is no leak, because it has happened that premature removal of a stent has resulted in re-leak and again biloma formation, because mucosal healing takes 6 to 8 weeks. So most of the centers follow this phenomena of removing the stent, that on an average it may be longer in certain special situations, and as I said, ENBD shorter, less than up to 10 to 12 days. Otherwise, mucosal healing, the bile leak or the opening or the trauma will stop in, let's say, around a week, that it may stop. Mucosal healing takes 6 to 8 weeks. So many centers follow that phenomena. So we have to ensure before removal certain criteria. Number 1, sepsis resolved. Number 2, bilioma resolved. Number 3, no ongoing leak. And the most significant way to demonstrate is a cholangiogram by ERC. Then only we remove it.
So the message is that you can remove the PCD or the drain if it hasn't drained bile for some time. You have done some imaging and it shows no collection. Patient is otherwise sepsis free, but don't be in a hurry to get the stent removed. There is no harm in keeping the stent. Is it right, a little longer rather than removing it prematurely, because otherwise you will have re-leak and recollection. So, that is the philosophy. Now, the last question is addressed to Dr. Vaibhav. As I mentioned earlier, that the SGPGI philosophy, and now it has been kind of supported by several societies, that the best time to repair a bile duct injury is a delayed repair. Delayed repair means at least 4 to 6 weeks after the injury, when the patient has recovered psychologically, physically, emotionally from the surgery and the trauma, has recovered septically from the bile leak, and the timing is adequate for repair. But there are certain exceptions when an early repair can be thought of. Again, I would say these are exceptions. So, what are those situations, Dr. Vaibhav, where we may think, and it goes without saying that all bile duct injuries should be repaired in centers which have experience of doing a biliary enteric anastomosis in the elective setting, for example, after PD, after choledochal cyst excision, after a CBD excision, as a routine, not once in a while, because it has been shown that best repair is done by a biliary center, by a biliary surgeon, not by somebody who does not do biliary surgery as a routine. So, even in the hand of a biliary surgeon, which are the situations where as an exception we can think of a early repair?
Sir, as you have already said that routinely we have to wait for at least 6 to 8 weeks before definitive repair, because we want sepsis to resolve and inflammation to settle down. But since we are talking of early repair, so what we mean by early repair? Supposing a patient is coming to you within 48 to 72 hours, at the maximum. So by that time inflammation has not settled in. So provided we know what is the nature of injury, if these are minor bile duct injuries, like if there is any leak from the cystic duct stump or duct of Luschka, or maybe just a less than 1/3 injury of the common bile duct, in that case within a time frame of 48 to 72 hours we can proceed. But still I will say, if you are working in a periphery, please do not hurry and do not proceed. It is better to refer a patient to a specialist hepatobiliary center. But if you are working like in KGMC or in a specialized hepatobiliary center, even over there within 48 to 72 hours you can go ahead and do a definitive repair as well. But beyond that point, please delay this surgery for at least 6 to 8 weeks.
So, the philosophy is that sepsis should not have set in, sepsis in the peritoneal cavity or sepsis in the biliary tree. Patient should be septically stable, hemodynamically stable, metabolically stable. Then within this time frame, as Dr. Vaibhav mentioned, it is as good or as bad as an intraoperative detection, where if expertise is available, you can do what is known as an immediate or intraoperative or a early repair. But by and large, that is for you to say in the exam, by and large tomorrow when you become a surgeon on your own, if you have a bile duct injury, as he said, as soon as you suspect, after immediate treatment which is possible in your center, with a detailed note, after explaining to the family, refer the patient to a center where all these facilities, all this expertise is available. Let them decide whether they want to go for an early repair or they want to wait for a delayed repair. I will conclude by saying that bile duct injury is not only a complication for the patient, it is complication for us also, because it is one of the commonest reasons for which a case is filed against a surgeon. And the ways that you can protect yourself are: number one, in your initial career, select your cases well, go for those cases which are likely to be easy. Number two, a good written informed consent mentioning the possible complication, because if you do not mention it, it happens, that means you hid the information. If you mentioned it, then you declared it. Third, if an injury occurs, documentation of the operative findings, preferably video recording, but at least detailed operation notes, initial management, whatever is possible in your setup, and after telling and informing the relatives, referral to a center after talking to the person to whom you are referring, so that the patient is entertained there and take care. If you do this, none of these experts will prove you or say that you were negligent. They will say it is a complication which occurs. As I said, it has occurred even in a center like SGPGI, it occurs everywhere, but if you managed it properly according to the guidelines, you will be safe. My email address is vkkapoor.india@gmail.com. There are guidelines recommended by SELSI, the Society of Endoscopic Laparoscopic Surgeons of India, for safe cholecystectomy and what to do in case a bile duct injury occurs. I think all of you should go through them and follow those guidelines. Abhinav, do we have time for any some questions from the students or? Okay. Yes.
In the algorithm, you know, there's one thing I think for the PG they should know, and it should be added about HIDA scan, because in some of the books and also papers they have some of the centers they have mentioned it as the first line. Availability now available in quite much centers, this thing, cities I would say. So, and there are specific situations where a HIDA scan will also be helpful in detecting bile leak, especially when the CT or MR picture are not very conclusive. In those situations, you can go for the planar images and the HIDA scan images to detect the bile leak. Otherwise, in also some of the books they say that post-operative the drain shows bile. Then even though it doesn't give you an anatomical roadmap, but sometimes it helps in detecting that yeah there is an active bile leak, and that can be located in best
Yes.
of the hands.
Students, any questions, any doubts? That is not a good sign. वो तुम्हारा काम है कल पूछना इनको राउंड में. Any panelist would like to add anything?
Like once we are doing a laparoscopic cholecystectomy, before clipping any structure, it is very important now to prevent bile duct injuries. Number one, that your critical view of safety, that should be, and only 2 structures should be entering the gallbladder. 1/3 of the gallbladder should be detected off the liver bed, and before clipping, ask your even your sister or your assistant, junior doctor, whether you are doing right or not. And before clipping, take a pause. Now it is recommended that before clipping, take a pause, rethink, and only then clip any structure. If you are clipping a cystic duct and if you feel like you are going to use 400 clips, be very cautious, because that can be a CBD or any vessel which you find before clipping. If it is pulsating, it could be a right hepatic artery, because normally cystic artery does not pulsate before clipping, it only pulsates after clipping. So if you find a pulsating artery, diameter of the artery is more or diameter of the duct is more, be very careful before clipping. Or
Yeah, very important points. Ashish wants to say something.
Sir, for initially, like in initial career, I'll just suggest don't go by like the experts what they do and what guidelines have come, like acute cholecystitis, severe cholecystitis, gangrenous cholecystitis. There's no problem, they could go in and they have done successful and safe cholecystectomy. Those are like in expert hands. For, as sir said, in initial period you should select your patients. All these patients in your career, if those come as acute severe gangrenous cholecystitis, don't go for cholecystectomy. Just manage them conservatively with PCCs if required, with antibiotics, and go in elective setting where it can be more easily done. So don't like invite any trouble in initial phase of your career.
Anything else, Rahul, you want to add?
And one more important thing, sir, before doing cholecystectomy, you should always have a good look at the LFT. If there is any derangement, don't refrain from doing an MRCP prior to the surgery. That will help you to delineate the anatomy and to rule out any CPD stone which is down below, which is a very common factor. Which CPD stones, as you know, all know, though they are asymptomatic, they can be present in almost 10% of the cases who have gallstone disease or symptomatic gallstone disease, in fact. So you should not refrain from doing an MRCP prior to cholecystectomy, if at all there is any derangement in lefty or you suspect anything like that. So this is important, and you should always do cholecystectomy after at least 12 weeks of acute cholecystitis or any complication in the gallstone disease. Complicated gallstone disease should be dealt with care.
Actually, theme was not safe coli, so we didn't go into these points. But Abhinav, I'll send 2 copies of our book on safe cholecystectomy, which now Dr. Vishal is joined and he will take it over. I will again request all the residents to please go through that book. There are very important tips, some of which have already been mentioned by my colleagues from SGPGI, which we always, Dr. Shabi also has a background of SGPGI, which we always say when we are doing a cholecystectomy. So these are small tips which we hope will help you to keep your cholecystectomy safe.
A wholesome panel discussion, I mean, better than a Sunday brunch. The idea is that these people should have asked
Sunday
the question.
brunch तो आपने खिलाया नहीं हमें.
They're not staying here. We would love to host you, sir. We would love to host you. He's a very senior teacher of teacher, and we have been blessed that we were closer to him for a certain period of time. My question to all the panelists and you is, sir, that there are gallbladder predictors of difficult cholecystectomy, different scoring system, RCLC, Command Hospital, Turkish, and then there is one more. I just forgot, slipped the name, and then that is Tokyo Guideline 18 and all that. How many times we normally in our own practice use it? I've not seen, I've talked to any number of people not
No, but as Ashish said, we may not be doing it, but these people tomorrow when they become
They should do
independent
it.
consultants, LFT, ultrasound showing a mildly dilated CVD, these are going to be difficult cases.
These are going to be
Single stone, large stone sitting at the neck of the gallbladder with some mild IHBRD, Mirizzi syndrome.
thickness of the gallbladder.
Thick walled
wall,
gallbladder is another complete entity. Multiple small stones in the gallbladder. These are all going to be difficult cases.
Just
So
to add
be
to
very
you,
careful.
one thing, I mean, obviously it is not safe cholecystectomy. You know, the British Society, they are not taking a zero incident injury to this. If you go in and find it that the things are difficult, come out. There is no problem. You can go in another day.
Yes.
The problem is that once we put in the scope, now we are bent upon it and we have this kind of thinking that we have to complete it.
Yeah.
No problem. You back out before you cut anything. And
The
that will be
surgical
the
ego should
safest
not be
day
there.
and you'll love that day. So that's one message to the younger generations. Number two, never be in a hurry to do a complete cholecystectomy. It may sound odd at present because we all understand the meaning of this. Do a partial cholecystectomy. And that is the best way and the most definitive.
I mean,
out.
partial
Mirz's syndrome,
cholecystectomy where the callous triangle is not
so
obvious.
many times I've gone in, believe me, I've gone in and done a completion cholecystectomy, hundreds of cases, and many have been done 10 years back, 15 years back. Now that sac also becomes as a gallbladder and there is a stone formation, reformation, and then it comes back to you. But still you escaped that 10 years. So that's another message we want to give it to you. So ये नहीं कि sister, don't run after that callous triangle. We are also in argument. I think Shrikant published this, and some of also say that we are against CVS. Why? In an effort to do CVS, you create more injury rather. Now this is something beyond your this thing discussion, but don't run after CVS. You get it fine, and most of the easy cases you create CVS. Where you want CVS, you cannot create CVS. That's also a very hard truth. Even Amirizis don't go for CVS. In thick-walled acute cholecystitis, you may not get a CVS. Rather, impacted stone, cut the stone, remove it, empty the gallbladder, look from inside. So many times I've seen inside, I don't know, sir, will tell, like, have you ever had that you apply a suture from inside this thing? Because many times I ended up giving a purse string from inside the mucosa rather than going and clipping there to save the bile duct. So these are the certain things. So CVS, again, take it with a pinch of salt. Running after cystic duct and clamping two structures, you'll get it in easier gallbladder. You never get it where you want it. Similarly, for I will comment about ICG. You see the ICG bile duct where it is normal, where it is thickened, abnormal, you don't get a You hardly have applied so many times CG, and I stopped using ICG. I mean, so your views, sir, I mean, he's the ultimate teacher of teachers, and so let's see what he says.
Thank you all the panelists. Thank you Abhinav once again for asking me. Thank you.
I sincerely thank our esteemed moderator and panelists for sharing their invaluable insights and real-world experiences. I would like to invite Professor Abhinav Arun Sonkar for felicitation.
Ram, Nizam, they're busy talking among them. Come all of you. आप भी आ जाइए, आप खाने के आ जाइए और ऊपर फैकल्टी में. आइए सर,
Sir is our teacher also. Let me tell you.
Thank you, sir. Before starting workshop on bowel anastomosis, we have a very brief talk on making life easier for people living with stoma by coloplast. Mr. Saman Trivedi, assisted by Akbar.
Very good evening to honored surgeons. I am Saman Trivedi. I am assisted by my colleague Akbar Alam Ansari, who is a BSc nursing colleague. So just a very short and quick session over the simplifying the life of ostomates. So first, what are the major challenges faced by the people living with the stoma? If you are agree with me, there is a leakage due to ill filling of the appliances, peristomal skin complications, difficulty in product applications, and difficulty in product removal as well. So if I dig down in the leakage due to ill fitting of appliances, we can see that ill fitting appliance allows output to seep out and cause a leakage. Creases or dips in the skin prevent the skin barrier or the base plate from snugly adhering to skins and leaving a microscopic or sort of very short canal sort of thing where the excoriation occurs because of the leakage of erosive effluent. So skin fold and the creases in the peristomal skin increases the likelihood of leakage between the stoma appliance and the abdomen. Peristomal contour defect and irregularities reduces the base plate's ability to attach, leading to leakage. So major peristomal skin complications are associated with the colostomy, ileostomy and urostomy. The most common cause, leakage of stoma effluent onto the skin, resulting in peristomal moisture associated skin diseases or dermatitis. So patient with an ileostomy have a more watery output with a highly alkaline and active enzymatic content that can be extremely toxic and irritative to the skin. Deterioration of the skin integrity due to prolonged exposure to body fluids such as urine, stool and sweat. And exposure of the feces, urine changes pH of the skin from acidic to alkaline as well. So additionally, the peristomal skin complications, the change to alkaline pH activate digestive enzymes presence in the feces, which can cause erosive skin. When the skin is exposed to the urine and feces, the pH around the peristomal skin area changes and increasing lipase and protease activity, causing an increase in skin permeability and reducing the skin's natural barrier function. So that may lead to further contact dermatitis or skin redness or itching, burning sensation. This is one something like what we are facing in mechanical sort of thing, like difficulty in product removal. Ease of the removal is judged by the force required to the removal of the adhesive from the skin. So changing appliance may cause pain, stress, irritating that may lead to folliculitis. Ostomy paste also can sometimes result in damage to the एपिडर्मिस और जहाँ पर म्यूकोक्यूटेनियस सेपरेशन हो जाता है उस पर्टिकुलर केस में ड्यूरिंग द रिमूवल ऑफ द अप्लायंस पर्टिकुलरली विद द फ्रेजाइल स्किन और वन रिक्वायरिंग फ्रीक्वेंट पाउच चेंजेस या जेरियाट्रिक पेशेंट हैं जैसे पीडियाट्रिक पेशेंट्स में हैं तो उसमें भी प्रोडक्ट रिमूवल में थोड़ा प्रॉब्लम आता है पोस्ट ट्रेवल में. सो फॉर दिस वी हैड इंट्रोड्यूस्ड बावा प्रोटेक्टिव सील. सो माय कलीग विल इज शोइंग अबाउट दिस. So normally मैम आप लोगों ने देखा होगा कि hope I am audible to all. So normally हम लोग जो सजेस्ट करते हैं कि प्रोडक्ट्स की जो बेस प्लेट होती है उसके इनसाइड पे पेस्ट लगाते हैं ताकि पेस्ट लगाते टाइम सीपेज का प्रॉब्लम ना हो. बेसिकली एडेसिव प्लेट में ही होता है. पेस्ट इज नॉट फॉर द paste is not for the adhesive is already inside the base plate. हम लोग इनर एज में लगाते हैं ताकि सीपेज का प्रॉब्लम ना हो, पेरिस्टल्सिस मूवमेंट की वजह से लीकेज ना हो. सो वी हैड इंट्रोड्यूस दिस ब्रावा प्रोटेक्टिव सील. नॉर्मली आपने ऑस्टोमी पेस्ट में देखा होगा देयर वाज टू थिंग्स. वन, एक अगर कॉन्टिन्यूटी ब्रेक हो जाती है रिंग की तो वहीं से लीकेज होना स्टार्ट होता है एंड दैट स्टार्ट टू द पेरिस्टोमल स्किन कॉम्प्लिकेशंस. सो दिस इज अ रिंग दैट इज moldable or flexible. You can place it directly to the stoma or filling the cavity irrespective of stoma size. So the continuity कहीं break नहीं होगी, उसकी वजह से leakage नहीं होगा इससे. So So second thing that you had already realized कि जो पेस्ट होता है that is a very hard and adhesive in nature. So एक बार अगर पेरिस्टोमल स्किन में गिर गया तो उसको साफ करना एक कॉम्प्लेक्स हो जाता है. तो दिस इज जीरो रेसिड्यू के साथ में है. सो पेशेंट के साथ 10 दिन तक वी हैव 90 days ऑफ ट्रायल कि ये डिसइंटीग्रेट नहीं हुई थी इन द वाटर. तो ऑन अ सिंगल गो पेशेंट 5-7 दिन बाद भी रिमूवल करता है तो आराम से ये निकल आएगा एंड विल प्रिवेंट द सीपेज of erosive effluent, so it will protect the skin to further excoriate. So Brava protective seal that I had already told that protective seal protects against the leakage and protects against the skin as well. Easy to handle, easy to apply, and एक sense patient को भी रहता है कि every time a single thing he had removed from a packed thing, so it will be sort of sanitized sensation भी उसको रहता है patient को. सो ब्रावा प्रोटेक्टिव सील इज़ वर्सेटाइल फिट. जैसे कभी बेंडिंग लाइन पर स्टोमा है तो वहाँ पर अभी आप इसको मोल्ड करके यू कैन फिल द गैप्स एंड स्पेसिफिकली विद सीनियर प्रोफेसर्स के अलाइनमेंट में या सर्जन्स के अलाइनमेंट में हम लोग अगर कैविटी होती है जैसे म्यूकोक्यूटेनियस सेपरेशन में तो वी कैन फिल दिस फ्रॉम देयर एज वेल. So Brava Protective basically 4 sizes में available है, depend on the needs of colostomy to urostomy. So thank you so much. This was exactly what I was looking for to launch you all. So thank you so much. Sure. So I will provide an adequate amount of sample for this.
थैंक यू. किसने बॉवल एनास्टोमोसिस नहीं किया है? KGMC वाले पार्टिसिपेट नहीं करेंगे, बाहर वालों के लिए ज़्यादा क्वेश्चन है, बिकॉज आज JR2 स्टार्ट डूइंग एनास्टोमोसिस. किसने बॉवल एनास्टोमोसिस नहीं किया है? द रेजिडेंट्स. You have not done bowel anastomosis. Which year are you? 3rd year. Which college? Well, have you assisted in a bowel anastomosis? Good. So we'll be giving you some few concepts, and what is the dreaded complication is leak, right? Everybody don't want their anastomosis to be leaked. So we'll be giving you some tips and tricks. Very thing छोड़ दे, बहुत सारी photos है पुरानी साल की. So leak. To prevent leak, what is the most important factor to prevent a leak apart from the surgical technique? Patient factor. So 90% of your leaks happen because you choose a wrong patient, or you choose a patient who is in a wrong condition to do anastomosis. So if you choose your patient or a perfect patient with a proper hemoglobin, with a proper everything, there are very rare chances, 1 in 100, that your anastomosis is going to leak or your suture is going to give way, provided you have made a good square knot or a surgeon's knot. So ये बढ़ाना कैसे होगा? Yes. So quickly, I will be giving only a brief thing. That whole lecture will be dealt by 3 new assistant professors. No, they are not new. They are new just in terms because they have just become faculty. They have much more experience than you all. So Amit, Dr. Karnik, Dr. Ansari, and Dr. Raj. So there are 3 there, and they will be teaching you or giving you some fine steps how to do a proper anastomosis. Most of you have assisted stapled anastomosis as well. Earlier in 2007, when Cochrane 20 years back published their first meta-analysis, which is the highest form of research evidence, they said stapled anastomosis is better than hand-sewn. And this meta-analysis created a problem. This meta-analysis created a shift from hand-sewn to stapled in the last 20 years. But now the data and new meta-analysis suggest stapled is not better than hand-sewn in terms of leak. It is only better in terms of reducing time for taking a anastomosis. Because if at all your stapled anastomosis is going to leak, the only thing that is going to save you is your hand-sewn anastomosis. So, and for a hand-sewn anastomosis, you are relying on a true surgeon's knot or a true square knot, not a granny's knot. There are 3 types of knot. One is granny's knot, one is a square knot, and one is a surgeon's knot. And as like most of the people, you will be knowing what are the difference between the 3. So leak we have discussed. So what Halstead said, if you follow this Halstead 6 principle in your anastomosis, there are no chances that your anastomosis is going to leak. If their patient is a perfect patient. What we say perfect patient? Hemoglobin is normal, not normal as a normal person, but above 8. Albumin protein is a right range, then your anastomosis is not going to leak. Then what are the 6 is, you should not leave any dead space. If there is a dead space, their bacterial growth will be there, sepsis will be there, your anastomosis sutures are going to give way. There should be careful hemostasis. If there is blood, it is a good culture media for bacteria to grow. You should follow strict asepsis protocols. Your anatomical dissection should be sharp. There should not be tension on any suture line. If there is tension on the suture line, the suture is going to cut through the mucosa or the submucosa or the muscularis mucosa. and you should handle your tissues gently. If you don't handle your tissues gently, then that they will be at micro level, there will be tissue edema, you will be either your suture knot will be too tight or too loose, and you will give, and end up having a dead space again, and then you will, your anastomosis go to leak. So coming to stapling thing, everybody has used a paper stapler, right? There's any person who has not seen a paper stapler? A paper stapler. Has everybody seen a paper stapler and used it? Right. What is a paper staple? It is a titanium U-shaped clip which after staple forms a B, or let's say half B. ठीक? Your surgical staple is same as paper staple. The only thing is your paper staple is made of aluminium alloy, your surgical staple is made up of a titanium alloy. And because titanium is inert, your staple is going to remain inside the patient's body. So it is made up of titanium and inert alloy, and it forms a complete B, which one of the faculty will deal with. So staple, same as you staple your paper, two leaflets of paper, in the same manner, two bowel layers are stapled by a stapler. So they will deal with how, what is a staple line, what are one row, two row or three row staple line, and how the staple works. So we have got some live tissue of goat with us. You can perform your square knot or a surgeon's knot on it. If you have any problems, if you want to question us about granny's knot or a square knot, we will demonstrate you there right away on the goat. Before that, these three people will tell you about the basics of a hand sew in one lecture, and in two lectures how to perform a good stapled anastomosis. We have got some staples as well, you can fire, and we will tell you what are the difference. There is nothing fancy about them. It's only when we say in a 2 stapled row or 3 stapled row, it looks fancy, but it is nothing fancy. It's pure common sense. You will see on the cartridge why we call them a 2 staple, why we call them a 3 staple, and it is pure common sense. It's nothing fancy about it. Anyone can use a staple. If you have used a paper staple, you can very well use a surgical stapler. The principles of a stapled anastomosis remain like hand swing only. So the first lecture Webber has to take. Thank you. So next PPT. Actually, we run this bowel stapling thing as a 1 day of 8-hour course at our institute. So this we are just trying to give you a brief overview in 1 hour, so that you get a hands-on on how to do a hand sewn and a bowel stapler anastomosis.
Okay, so I am Dr. Vaibhav Rajgopal. I am a assistant professor in this department. I will be dealing with the hand sewn anastomosis. That is the most basic anastomosis that everybody, I hope that most of you people would have done it, or at least assisted it. So before starting my lecture, I would like to emphasize on one thing, that be any kind of anastomosis in either colon, in the stomach, in esophagus or bowel, anywhere. Okay, the basic is that you have to keep the mucosa inside. Mucosa should not come out. Okay. Second is you should know the actual, that the right from the esophagus up to the rectum, the entire gut is having roughly 4 layers. The innermost is mucosa, after that you have the submucosa, then you have the muscle layer, and finally the visceral peritoneum or the serosa. Somewhere the structures are devoid of the serosa, but at most of the sites serosa is present. So in anastomosis, whether stapler or whether hand sewn, you have to basically focus onto the serosa and submucosal layer. Mucosa is not so much important to get incorporated into the anastomosis, because submucosal is having the highest content of collagen, and collagen and fibrous tissue is the only main thing that will help in healing of the wound. Okay, therefore you have to incorporate more of the submucosa in the anastomosis. Now be it stapler anastomosis or your hand swell. Okay, so now I would like to describe a little bit of theory regarding the bowel anastomosis. So under these headings I will be discussing the entire presentation: introduction of objective relevant anatomy, settings, instruments, suture and technical considerations and complications that will be more discussed in the hands-on workshop. Okay. So regarding the history, the word anastomosis came from the Greek word that means ana and stoma. It simply means that you have to bring together two ends and join them. Okay. And it can be done either in the elective settings or in the emergency settings. Most of the time the residents are doing it in the emergency settings. So you have to be very careful in what technique you have to use and how you have to make it meticulous so that it does not leak. Then it is not a very new procedure. The date you can see, for the first time it was performed in 1739. So it is a very old historic procedure, nothing very new. Anastomosis has been performed over the ages, over hundreds of years. Okay, and the first one was Duverger. So ultimately when you cut a bowel or if there is a perforation, it is actually a wound. So in body anywhere, if a wound heals, it will heal under those four headings only. The first one is the hemostasis, second is your inflammatory phase, third one is your proliferative phase, and finally you have the modeling and remodeling phase that takes over years or months. Okay. So what happens, the first one is the hemostasis. I have not described about the hemostatic phase over there, here because it's not so important. You are actually performing hemostasis on your own when you put the sutures or staplers. So finally what happens, when there is a wound, it will start healing by inflammation. In inflammation there will be recruitment of the neutrophils, lymphocytes, RBCs, platelets and all the cells that are present in the blood. They will finally release chemokines, interleukins and all the inflammatory factors that will help in healing of the wound. Okay. So after that comes So after that what happens when once the infection is gone away, if there is any kind of infection, then finally the monocytes will enter. They will start the healing response of the wound, and finally the fibroblasts will also come and they will lay down the collagen. Fibroblasts are basically present in the submucosal layer. Okay. And after that finally there is fibrosis and maturation phase that can last up to months or even years. Okay. So anatomy, I have already told you that there are four layers. From inside to outside you have mucosa, then submucosa, finally the muscle layer that can be inner circular and outer longitudinal. It is divided into two parts, and finally the serosa. So regarding the types of anastomosis, you can have multiple types. The most common that we perform is end to end. Then you can have end to side if there is some numeral discrepancy, or by your choice if you want to perform an end to side anastomosis, you can do it. Then you have side to side configuration. Okay. Then technique, it can be either hand sewn or it can be stapler. The only thing that difference between the stapling and the hand sewn, as the boss discussed it, is there is a difference of operative time, nothing else. Every other possible factor is exactly the same. All the leak rates, all the patient factors, surgeon factor, they don't matter whether you are doing it with the help of hand or with the help of a stapler. It doesn't matter at all. Then what kind of part of bowel you are taking into account, that is also it. So this I have already discussed. And this is the point that I would like to emphasize upon, that submucosal layer consists the highest amount of collagen. That is why you have to incorporate submucosa more. Mucosa will not give any strength, and mucosa actually it goes on turning over. Okay, there is always a turnover of mucosa. It gets, it is always getting replenished in the body. So you cannot take mucosa, more of a mucosa in the suturing. It will get replenished and it will fade away. Okay. So that's, now there are multiple factors on which your anastomosis depends upon the patient factor. Mostly a theoretical part. So patient factor that you already know, then surgeon factor, basically the technical factor, that is the surgeon factor. Okay. Then in patient factor you will be having the nutritional status, the albumin status, hemoglobin, presence of sepsis or not. All these factors will be included under the patient's factor heading. Then negative factors also, you know whether patient is on any immunosuppressants, or there is a high degree of septicemia, or old age, or nutritional status is also very poor, albumin less than 2.5. These are all independent risk factor for anastomotic dehiscence. Then now these many things, it would be better if we discuss all this in the workshop. In the presentation it would be of no use if I discuss it over here. It will be better if you do it on your own, and when I will demonstrate it on the actual bowel specimen. Okay. Suture type, what kind of suture you use? Most of the time we use absorbable suture, that is the Vital 30 for the small bowel and Vital 20 for the colon, and sometimes you can also use SIL 20 in the colon, and in stomach you will use Vital 20 or SIL 20. Okay. Then all these types of stitching, Gabby stitch, conal suturing, Cushing suturing, smitten, all this I will demonstrate on the bowel specimen. Okay. Because it's not possible to tell it on in the PPT. You will not understand anything. So that's it. Rest I will be discussing in the workshop. So thank you. Now Dr. Nizam boss will be telling you about the anastomosis.
Next slide. Thank you, Vaibhav.
So Dr. Vaibhav has already discussed about the high and chewing anastomosis, and I will be continuing with staple anastomosis. So what goals which we need to accomplish? We have to maintain the hemostasis. Next, we have to give a good occlusion along with optimal compression for appropriate staple placement or formation. So these are the three basic goals which we need to cover. So there is something like must know simple framework in this. Few consideration we are going to take. First, we have to have a stapler with us, and we need to create a anastomotic stapler line with the help of a device that is known as a stapler. So we have a stapler, we have a tissue, and we will create a staple line with it. Apart from this, there is a second consideration in which the relevant properties of the tissue that affect its interaction with the device. So how the device interacts with the tissue. So we will see in this presentation. So going to the history, it was first stapler was created in Russia, in Budapest, Hungary by Dr. Humer in 1909. It was made of a wood, and it was a commercial failure. Later on, the modern stapler which we see is made up of titanium. So basically, what are the principles of tissue management while we are dealing with a stapler? So the tissue should be coapt with a given amount of compression. So you have to compress the tissue to a certain level so that the staples get into it. and there is a simultaneous cutting between the opposed staple lines along with a sturdy anvil, and the staple line should hold tissue immobile while driving metal staples with precision. So, staples inside the staple, when you are applying the staple, the tissue should be immobile, so that to get a good staple line. So, now the question arises, how much pressure do you have to apply and for how much time? So, how much compression you are going to give and for the how much time period? So, a study was done in Russia in which was performed on dogs. So, the amount of pressure which was calculated was about 8 gram per meter square in the stomach and 6 gram per meter square in the esophagus and intestine. So, adequate amount of pressure you have to apply. So, if we press for too long, tissue cannot recover, and if we are compressing for it is too short, it will lead to leak and bleeding. So, to prevent this, we have to give an optimum pressure while applying a stapler. So, while dealing with the tissue, there are certain properties which you need to consider: the thickness of the tissue, the compressibility, the property, variability, and biphasic nature. So, the thickness of the tissue, different tissues are different. In like vascular, you need a different stapler, and a bowel, you need a different stapler, and other tissues, you need a different stapler. So, you need to understand the tissue dynamics first. So, what is the tissue dynamics? What is actually happening with the tissue as different type of forces are applied on it. When we apply a stapler to the tissue, how the tissue reacts, it presents with the tissue dynamics. So, prior to stapling, we need to compress the tissue. So, it refers to the application of pressure to living tissue to achieve an adequate thickness for stapling. So, we need to adequately compress the tissue, so that we can get a good staple line. So, what are the benefits of compression? If compression migrates fluid from the tissue, so when we compress the fluid from the tissue, it migrates out and it ensures a more consistent thickness. And after compression, the tissue is ready to accommodate a securely closed staple. So, first we have to compress so that the water inside the tissue comes out and we can get a consistent suture line. So, what is tissue creep? So, when we are compressing the tissue, it elongates. This phenomena is known as tissue creep. So, when the tissue elongates after compression, it is known as tissue creep. So, while stapling, no one device that fits every application of the patient. So, a patient may need different types of staples in different types of tissues. So, you have seen this type of staplers. There is a circular stapler and there is a linear stapler in open surgery. So, how does the mechanism of stapling works? You can see in the photograph there is a rectangular shaped staple in the first image, and when a certain force is applied, it turns the linear staple is converted into a B shaped stapler. It takes the shape of a B and it holds a tissue inside it. So, this is the mechanism of stapling. So, if we are not taking the adequate size or adequate compression is not done, we get certain failures. So, we have to choose the appropriate type of staple for appropriate type of tissue. Thank you.
So moving forward with the mechanics of stapling, दो तरह के stapling patterns हैं. One is open stapling platform and endoscopic platforms. तो जहाँ हम open surgery में अगर use करें तो those will be called as open stapling platforms, and laparoscopic surgeries में these are endoscopic stapling platforms. So they are typically designed to adjust to the different tissue thickness. जो भी इसकी sizings होती हैं, they are for the accommodation of the tissue thickness. Each stapler will deliver compression differently based on the tissue thickness and procedure for a secure anastomosis. सो ये डिवाइस है, इसके बारे में विल टॉक इन डिटेल इन द वर्कशॉप, बट दिस इज़ ए GIA लीनियर स्टेपलर. पार्ट्स आपको दिख रहे हैं ऊपर, दिस वन इज़ एनविल, देन यहाँ पर दिस इज़ द चैनल, इस पे कार्ट्रिज फिट होता है. दिस पार्ट इज़ कॉल्ड एज द शोल्डर. दिस इज़ द लॉक लीवर हैंडल, एंड पीछे अभी यहाँ पर नहीं दिख रहा, बट देन देयर इज़ अ रिलीज बटन एंड एडजस्टेबल फायरिंग नॉब. दिस इज़ द एडजस्टेबल फायरिंग नॉब. यहाँ पर देयर इज़ सेफ्टी लॉकआउट. सो 4 तरह के स्टेपलर्स हैं. वन इज़ लीनियर, देन कर्व, सर्कुलर एंड लीनियर कर्व. तो जो अभी स्टेपलर इसके पहले पिक्चर में था, दैट वाज द लीनियर GIA स्टेपलर. कर्व्ड स्टेपलर इज़ यूज्ड फॉर स्टेपलिंग इन दी पेल्विस, मतलब जो डीपर स्ट्रक्चर्स हैं, जैसे सपोज LAR हो रहा है, लोअर एंटीरियर रिसेक्शन, वहाँ पर कोलोरेक्टल एनास्टोमोसिस करनी है, तो वहाँ पर क्योंकि linear GIA stapler will not be able to go in the pelvic region, so therefore the curved staplers are used. Circular stapler is used for example in MIPH. So these are designed with system wide compression, gently and uniformly compress along the entire length of the targeted tissue. तो कार्ट्रिज और एनविल के बीच पर बावेल या जो भी टिश्यू है, that is placed, and then we compress, and then there is a time for which it has to be compressed, and it will designed to create varying degree of compressive load. So what is the configuration and composition of staple? These are made up of a crown and a leg. A piece of plastic, that is the cartridge body, sitting on the back end of it is a little wedge. तो जो स्टेपल, जैसे स्टेपलर की पिन होती है, the horizontal part is the crown and the vertical parts are the legs. Legs की जो length होती है, that you can see as 2.4 mm, 3.8 mm और 4.8 mm, and color coding उसी की legs की है, ठीक है. तो that will tell you the penetration. जिस तरह का टिश्यू है उस तरह की हमें legs वाले cartridges लेने हैं, use करना है. So cartridge body, there are staple drivers and staple retainers. We'll talk in detail about this in the workshop. So पहले rectangular wires आते थे, these were the type. इसमें penetration उतना अच्छा नहीं होता था and the chances of leak were higher. So now the technology is DST, directional stapling technology, and it targets a larger target area. So ultimately जो design बन रहा है, it should be an inverted B after the stapler has been fired. यहाँ पर जो color coding है, this is grey, white, blue, gold, green, black. Mostly you will see white, then you will see blue, you will see green. जो यहाँ पर length लिखी हुई है 1 mm, 1.5 mm and green में 2 mm, these are the length after closing of the device. ठीक है, पहले क्या था, white is 2.4, blue is 3.5 and green is 4.8, but this was the length before firing of the device, crown and the length, right? Now after the device has been fired, the closing length is 1 mm, 1.5 mm and 2 mm. This is for white, blue and green. तो जितना पतला टिश्यू है आप वहाँ पर white यूज़ करिए. For example, vascular applications, the closing length is 1 mm, white. Blue will be used in small bowel and colon, and tissue which are thicker than small bowel, for example stomach, यहाँ पर green stapler use होता है. Two other things that you see is 60 mm, 80 mm, 100 mm, that is the length of the stapler. तो उसमें आएगा अलग अलग, green, blue, white, ये आपकी length है staples की, ठीक है. इसका 60 और 80 और 100 से लेना देना नहीं है. So this was, we are talking about white, blue and green. Before closure this was 2.5, 3.8 and 4.8 mm. After closing 1, 1.5 and 2. Fine, and staple length is 60, 60, 80 or 100, 60, 80 or 100. And then there are the tissue descriptions. Thin tissue, little bit of thicker tissue like small bowel and colon, blue, and even thicker tissue, scar tissue or stomach, यहाँ पर आप green या bronchus है, वहाँ पर green stapler, cartridge. दिस इज द डायग्राम ऑफ अ सर्कुलर स्टेपलर. यहाँ पर जो आप देख रहे हैं 21 mm, 25 mm, these are the diameter of the anastomosis. And नीचे cartridge staples की crowner length mentioned है. So colorectal anastomosis है which are a little bit of on the higher side, 31 mm वहाँ पर use होता है. तो different color codings for the circular staplers. Composition क्या 99.5% titanium से बना होता है, and depending upon the instrument there are different versions of titanium allowed. So what we have to understand, it is made up of a titanium stapler device. ये opposition after firing है. अगर so what did I tell you earlier, it should be an inverted B in the appearance. That is the very good type of tissue opposition after the firing. तो जो आपका स्टेपलर की जो पिन है वो इस तरह से दिखना चाहिए. तो अगर आप देख रहे हैं ये बावेल मतलब ये टिश्यू है, तो क्राउन भी इधर अंदर है और आपकी जो लेग्स हैं वो भी कर्ल होके पूरे अंदर अपोज हो गए हैं. यहाँ पर अगर देख रहे हैं तो द टिश्यू पेनिट्रेशन इज नॉट कंप्लीट. यहाँ पर द इट हैज़ नॉट क्लोज्ड. हियर इट हैज़ स्टार्टेड क्लोजिंग बट ड्यू टू मिस फायर और नॉट अ वेरी गुड फायर it is not complete fired. So these are the ideal staple linings. TA stapler, two staggered row of staplers होते हैं, ये कट नहीं कर रहा है. And then there are the GIS stapler जो अभी mainly the staplers that we will deal today is a GIS stapler, linear GIS stapler, and endo GIA बोलेंगे जब वो laparoscopic तरीके से use होता है. Okay, so now I would request you all to proceed to the workshop.